Hello, check, 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 check.
Check,
Anushka?
check, 1, 2.
good morning to all. Respected friends who came to me on time today, and already we have 600 virtually connected cardiologists today. Once again, good morning to you all. We are on the day 3 of penultimate day of course 5D PCI Exotica, where we will be starting with the live case from MMHRC by Dr. Selvamani and Sampath team. In between, there will be 2 lectures where Dr. Karupaya will be giving a lecture on image-guided versus angio-guided PCI, and Manoj Suramakrishnan will be talking on mechanical circulatory support. Following which is a tightly packed session, 5 sessions for the whole day, back-to-back, with the tea break and lunch break on time. We'll be getting the hub from Chennai from 11 o'clock to 3 p.m., where there will be lectures by Dr. Elilan on managing high bleeding risk patients. There will be a case-based learning from real-world coronaries by Dr. Selva Ganesh from Madurai, and there will be a chip scenario discussion by Sundar, the cardiologist very much from Ramnad, settled at Chennai. And there will be a keynote international lecture from Julio, who doesn't need an introduction. And again, from the hub, from Madurai hub, will be representing from here physically as well as to the Chennai hub, where Harish Mehta and Pradap Kumar will be giving a lecture on valve interventions and CTO respectively. In between those 2 lectures, there will be a live-in boxes by Dr. Keshavamurthy from Tanjavur and Giridhar Muthu from Tirupattur. Then we will be having a fantastic live case from Vadamalayan by Dr. B.R.J. Kannan. In between, there will be a adult congenital intervention lecture by Shiva. Then again, we will be, as we starting the case with the live case from MMHRC, we are closing the day with a live case from MMHRC by Dr. Ganesan and Jayapandian. In between the lecture, there will be a cath lab nightmare by me. So let me ring the bell. The session starts now. I welcome, for the live case session, I welcome the chair, my retired professor of cardiology, Dr. Amudan, to the dais, please, sir. Professor of cardiology, sitting professor of cardiology, Dr. G.S. Sivakumar, to the dais. Assistant professor at Vadamalayan, Dr. Sasindrar, please. Now, Dr. Amudan, Sivakumar, and Sasindrar will invite Dr. Selvamani to proceed with his case. Thank you. Dr. Amudan, sir. You can invite Dr. Selvamani.
Good morning. I first of all thank Dr. Sivakumar for this wonderful session.
Yeah, good morning, everybody.
Yes. Can you say a few words about the case which we are going to do?
Yeah, good morning, Amudan sir. Good morning, Shivakumar, and I think Shashinder. Yeah, I think I can see Shashinder there. Good morning, all of you, and good morning, Shiva there. And today we have a case here which Dr. Sampath will be telling you the history, and then he will tell you certain plan also. You can always suggest what we should do for
just a minute, Selva and Sampath. Our NIC chairman, Dr. Pradap ji, is here. Just to respect his presence on time today, we just elevate him as a course director for the entire 5 sessions today. I am inviting him. So please come to the podium. Please, there is a live case. You can take a nice lead with Dr. Amudan and other. Thank you, sir. Selva, Pradap is here with you.
Yeah, good morning, Pratap sir. Welcome back to Madurai. Nice having you here for the live case. And now we are more confident that you can guide us in a proper way doing this live case here. And Sampath will tell you the history, and we'll go ahead with this live case here. Sampath,
this is a 40-year-old male. He was a diabetic, but he was not on regular treatment. He presented with angina. His troponin was positive. His ECG showed T inversions in anterior leads. There was a regional wall motion abnormality in the LAD territory with a near normal ejection fraction. And he underwent angiogram outside, and there were multiple lesions. So he came here for further evaluation and management. And this is what the angiogram is. Angiogram showed a short, wide left main. There was mild osteal LAD disease. This is outside angiogram, so the clarity is not that good. There is a mild osteal LAD disease which we wanted to evaluate, and there is a OM also which has a very significant critical stenosis,
small vessel,
but it looks slightly smaller in size, and there is a critical tight LAD disease just after the diagonal, and the diagonal also has some osteal disease and some mid disease also, and this is the RCA which has mild long lesion, mild only I think in the mid segment, and this is what the angiogram is. Our main focus is on LAD today, what we should do for that LAD diagonal lesion, and what is the actual disease level at the LAD ostium level. Over to Selva.
Yeah, Pratap sir and Amudan and all of you, Shivkumar there. And basically, this is an young person who presented with a non-STEMI, TROP-I positive, an angiogram done outside. And he was referred for CABG here. But anyhow, we were looking at the angiogram. We thought that probably he is a candidate for PCI. And this is the angiogram here. You can show the angiogram which I have done just now. So this whatever angio you saw was done outside. And this is the angiogram here. You see here, it's a circ is a non-dominant circ. And there is a moderate sized second OM, which is disease but long disease there. Critical but a long disease is there. And when you concentrate at the proximal or osteoproximal LAD, there looks to be some disease in this angle. Now go to the next angle. So this is the epicranial view here. It's a moderate sized D1 there. I think that's a very important diagonal because there is no other diagonal in that area. That's the only one, but it's a diseased vessel there. And LAD is a type 3 LAD, but almost around 90% stenosis at the diagonal. And when you look at the characteristic of that angio itself, it looks like more or there is some amount of calcium and it's not a straightforward, simple vessel there. Probably some amount of calcium and fibrotic lesion is expected in this lesion. And osteoproximal ilivocaudal. Next shot, taken. Ilivocaudal is there and there is some disease there. But in this view, I feel it is not so significant. But anyhow, we have planned for an image guided PCI for this lesion. Go to the epicranial. And so what I did is I just put a wire into the LAD and the diagonal. And I have dilated the tightest spot there in the LAD. That's because of if you don't dilate, you may not get a OCT clearance there. And then I have done a OCT here. I will show you the OCT and then you can guide me like how I should proceed. We are at this level now. And go to the OCT, please. Can you see the OCT here? And yeah, 1 second. So when you look at the OCT here, and this is the distal vessel, and when you just come more proximally, you can see the 3 layers at this point here. And that means probably this area is relatively a healthy area. And when you still come behind, there is a fibrotic vessel and a lot of lipid there. After that fibrous, you see that you can't see anything. And a lot of fibrotic, this lipidic lesion there. And when you just come up again here, it's a tight stenosis. This is the spot where I have dilated. And post-dilatation also lumen area is very narrow there, 1.4. And these are some of the septals coming up there. And again, you come here and I have co-registered. You can concentrate on the co-registration marker also here. And when I come here, we are reaching the diagonal. Just at the opposite to the carina, you see here, something is projecting here. It is something like a nodule, which is really getting there. And now this is the carinal angle that you are seeing here. So this is the LAD diagonal bifurcation. And the ostium of the diagonal looks okay, but I think there is some amount of calcium also there. And you come up here, it's again a lipid lip rich area, relatively thin capped only. It is not very thick cap, but in certain areas, thickness is somewhere around 60, 65. or 70, something like that microns. And then a little bit further, it's all thicker fibrotic area you can see there. And you just come up, there is no three-layered structure which we can see here. And it's typically a diseased vessel. But here at this area, the lumen is adequate, almost it's a good lumen here. So what I thought is I will take this as a landing zone if needed. Now coming to the osteoproximal LAD, when you come here, so this is the osteoproximal LAD, is definitely diseased. And this is the lumen area what we are there, around 4 to 3.8 to 4 there, 3.8 to 4, and then again you come back near, this is the ramus and this is the LCX takeoff. And when you come there near the LCX takeoff, it's almost 5.1 there. So this is the OCT finding, and you have the vessel here. And I think you can suggest me what will be the ideal technique for this patient, and then we'll go ahead with the procedure. And it is over to you for that discussion now.
Good morning, Dr. Selvamani, sir.
Good morning. Yeah.
Sir, it's a nice case which you have selected. It is definitely, I feel the mid LAD is the culprit, sir. Troponin positivity and hypokinesia and the LAD territory and ECG findings as well. I feel mid LAD is the culprit. And definitely mid LAD has to be addressed. I think we have to go with provisional strategy, sir, since I feel angiographically the diagonal ostium, the lesion is not that significant. But in the OCT, we can see some significant plaquing in the LAD, diagonal ostium as well. And what about your strategy for ostial LAD, sir? I feel it is intermediate. I think after addressing the mid LAD, bifurcation lesion, I think, should we go for an FFR to the ostial LAD, or based on the imaging findings, we can leave the ostial LAD, sir?
Yeah. See, actually, what my thinking, Sashinder, is, as you say, suggested, post-PCI physiology is an excellent thing for patients like this who have a diffuse disease. And if you are really not doing a post-PCI physiology, I think there are certain criteria on imaging also on which we can take a decision whether to intervene or not. But let us hear from Dr. Pratap what he has to say.
Selva, actually, I have
Yes, Pratap,
two, 3 points I just want to tell. One, there is an, almost like an occluded OM which we are not going to deal today. That is number one, right?
So, Pratap sir, we are unable to hear you properly. Hold the mic nearby, near to you.
Some other mic, some
Actually,
other
the mic is given, but the mic is, Anand, your mic is not working. All the mics are not working. Now I taken another mic. Can you hear now?
Yeah, good. Now it is good.
Now the point is actually, in this angiogram, the OM is totally occluded. If you are actually leaving this OM, not to do anything for this OM, then the ostial LAD point will come up. So I'm just telling that OM is to be totally left alone. That is what is your idea. Or your concentration is totally leaving away. If I am in your place...
Now our idea is, if we are treating the osteoproximal LAD, before that we will treat the OM and then treat the osteoproximal LAD.
That is the point. That's the first and foremost thing is angiographically. Without image also, if you are actually doing something to the ostial LAD, you have to treat the OM first. If at all OM is significant, you are feeling it is significant. For me, OM is totally significant. So that area is actually maybe 7% or 8% of the myocardium, which actually I am not very clear about it. In the previous angiogram, I was seeing that the OM is a moderate size vessel, which is 2.25 to 2.5 vessel. That is what I was feeling. That is just left alone. And the second point is actually 3.8 area with OCT in the ostial LAD. Whether it is significant or by image wise, that is the second point. And as he mentioned, we actually could not see a significant disease in the ostial diagonal. So diagonal is diseased away from the ostium. Even if we are treating the diagonal, that is to be treated away from the ostium by angiographically. Image wise, since it is not done an image from the diagonal to the LAD, we are not sure that. And diagonal is also a decent vessel, but the ostium of the diagonal is free of disease. In the LAD part, as you mentioned, the proximal LAD is a big size vessel and this LAD is a size wise it is very less. So whether if you are doing a stenting, will you do a 2-stent strategy in the lady, or you take a larger stent or a medium size stent and dilate with a high pressure in the proximal part? These are the 3-4 questions I asked. I have to answer everything one by one.
Yeah. Yes, Pratap sir, excellent suggestion that you have given. But when we looked at the first angio, there was some ostial diagonal disease. If you can concentrate there,
Yeah,
very
sure,
ostium, but,
sure.
yeah, but it is not a long lesion in the ostium. It is not extending beyond 5 or 10 millimeter from the ostium, but very short lesion in the ostium of the diagonal there. And now our aim is we want to preserve, as Sashinder suggested, since the area, the ostial LAD is 3.8 or something, now immediately I am not intending to treat that ostial LAD. If at all I am going to treat later, probably
You
I
will
will
do actually after a physiological assessment, you will take a decision, right?
Probably.
Probably.
After
Then if you are telling about the
physiological
diagonal part, ostial diagonal is actually, if there is no disease also, if you wanted to treat a diagonal, you may have to put a longer stent covering the proximal part and the ostium. That means it will be a 32 or 38 millimeter stent. Then only you can cover the diagonal totally. Or you are totally leaving the diagonal away, only treating a lady. That is the second question.
Yeah. See, my point of interest, my thinking is, I thought I will not treat the diagonal, but I want to preserve the diagonal. I don't want the LA diagonal to get occluded, because that's a very big diagonal, very important diagonal for this patient, and we want to preserve it. Treating this diagonal is one thing. Like as you rightly said, we'll have to put a long stent there, and if at all we are going for elective 2-stent strategy, our thinking will be different. But today I am not planning for elective 2-stent strategy. Probably I want to do a provisional in this patient, because the vessel in the LAD is also not very big. It's all 2.5. This is a vessel which is fibrocalcific and lipid rich also. And putting 2 stents and what technique again is a issues there.
Actually,
So I thought,
Selva, I understood the point. You are telling you are keeping it as a provisional. Once you are keeping it as a provisional and keeping a wire into the diagonal, what is the aim of keeping a wire into the diagonal? Provided if the diagonal is occluded or if diagonal is pinched, you have to do something to the diagonal, right? In that situation, you have to take a longer stent.
correct.
So
I understand.
What is your expectation in the diagonal? Your expectation is only 2% diagonal disease or diagonal progression of the disease, or you don't expect anything, or you may be expecting.
No, angiographically, we will discuss in 2 ways. Angiographically, when you look at the angle, it is somewhere around 60 degrees angle there with the ostial significant or borderline lesion, which looks to be calcified also.
Now you
can
come to the
show them
OCT wise.
Yeah, this is angiographically.
Okay.
Now coming to OCT, what I feel is, there are certain criteria which you are all familiar with.
I want you to talk that.
I will repeat it again. See, this is the, in the longitudinal view, it is the bifurcation point there. So this is the carina. Whatever I am pointing is the carina. So, and this is the branching point. And this is opposite to the carina. And this is the distal main vessel. And this is the side branch here. So now when we look at the plaque characteristics just opposite to the carina, you see here, there is something projecting like a calcific nodule. So there is definitely a thick calcific nodule or fibrotic thing which is projecting opposite the carina. And when you look at the plaque around the carina here, this area looks to be lipidemic also. So then when there is a lot of lipid around the carina, the chances of occlusion is high. And when something opposite to the carina is very hard, like a calcium or a nodule, again the side branch occlusion chances are high. And when you look at for the eyebrow sign or the carinal point or the branching point distance, here it looks to be less. It's somewhere around 1, 0.8 to 1. So that means again the distance is lesser. So looking all this criteria on OCT, the chances of this vessel is closing is more than 50%. So in such a circumstance now, what are the ways that you can prevent closure or how you can restore that vessel. So whenever I see a condition like this, when the chances of closure is very high, I will be prepared to reopen it or do something for the vessel to get from getting occluded. So generally, if you are here, Pratap sir, what will you do there? And I will just tell you what I did also.
I will definitely put a stent, long stent to the diagonal. I will be taking this case as a dual stent technique, no doubt about it. I'm just telling provisional is actually your choice because all the EBC people, I'm not, I'm a non-EBC Chen fellow. So I'm actually for a dual stent technique because I see that there is a chance of 50% chance of closure of the vessel is number one. There is a disease after that. So when you wanted to put a long stent, through the stent, it will be more cumbersome than you are planning for the dual stent technique initially. That is number one. Number two, in this case, if at all you are going for a single stent technique, I may go for a balloon embedded technique because I don't want to lose the vessel.
Yeah, correct, sir. So you are planning that that is the jailed balloon technique to prevent that.
Because I don't want to lose the vessel, that is what is
correct. So that is also a good suggestion, sir. And but
Selva, we can take the opinion from the floor as also. Somebody actually, because otherwise everybody will become active. Otherwise only you and me will be active.
Correct. I think Sashinder or somebody can just give a suggestion. Or Shiva, are you there? You can also give me a suggestion.
Yes, Selva, I think the provisional is not a bad strategy. Of course, Pratap was thinking differently, probably because there is a disease down in the diagonal. That's making him to upfront two-stent strategy. But you can provisional also, if the disease doesn't progress by nature in that mid-diagonal with a good lifestyle and high-intensity statin, you can just target this LAD. Your message was very clearly conveyed by you from the OCT. There is a opposite to the carina, there is a hard pathology which is now going to impede where the carinal tip, spiky carina is sitting up. I think what I will do is, still I will hang on with your provisional strategy. I will wire the diagonal anyhow. I will put a cutting balloon right at the LAD so that it will have a programmed dissection in the main vessel. It will make an impact on the nodule rather than impacting the carina to push and occlude. Then maybe a jailed balloon technique is an option, but already we are contemplating a deceased diagonal. So I don't want to further keep it cumbersome over there. Maybe finally when I do a kiss, maybe I will do it with a dub in the side branch. So cutting balloon to prepare the main vessel, finish it with a kiss, that is a dub in the side branch. That's my thinking.
Okay. Yeah, well,
I wanted to make a point very clear, actually as Shiva told, that is actually I cannot accept that because in a balloon embedded technique, you don't have to take a longer balloon. The vessel, the deceased diagonal is nearly 12 to 15 millimeters away from the ostium. So naturally you can take a 12 millimeter, 8 millimeter balloon embedded technique in this case. There is no problem in that. And the cutting balloon strategy is very good. If you are doing a cutting balloon to a dub in the diagonal, you can do a cutting balloon into the diagonal part. Actually, all these cases actually demonstrated by...
That's a perfect suggestion. Same cutting balloon, you can blow it up in the diagonal.
You should do the cutting balloon into the diagonal, then deb into the diagonal is a very good strategy, which is actually now demonstrated by Colombo in many cases, and actually now they are avoiding even angioplasty stenting to the patients. Just do a cutting balloon and a deb balloon.
Yeah, correct, Pratap sir. What we did is, we also did what you were thinking. So I prepared both LAD and diagonal both with a cutting balloon. So I have put go to the next. What I did is, initially I dilated with an 2 NC and then I took a Wolverine 3 size.
Can you show the angiograms?
Can you see the angiogram?
Nothing.
Show the angiogram.
Okay. What is the cutting balloon size?
Yeah, go next. It's a 3 size Wolverine which I have taken. And I had difficulty.
No, 3 into 12 or 3 into 10 or 3 into 15?
It is 12, 3 into 12. It's a 3 into 10.
Wolverine is only 10, 15, 6, 10,
10.
15.
Yeah, it is 10. 3 into 10. Wolverine stent there. balloon there, and this is that balloon expanding there. So then I dilated a little bit down and above also in it, because all it's a fibrocalcific disease. Next.
Actually, how much atmosphere you have gone? What is the pressure you have gone?
We went slowly, 8, 10, and finally in the proximal we went up to 16. 16 atmosphere we have gone there.
People may think that
And
actually
next.
you should go only 6 to 8, and sometimes I go up to 20, 22. There is no problem in that. Basically, that should be, you
And
should go
one more
gradually.
point here is, many people feel that if there is a wire across, it can cut the wire.
Nothing.
In my experience, it has not
No,
happened.
you are
You
not
do
in your
worry.
experience. Nobody's experience it is there. It is only a illusion by the people.
People. So you can confidently do with the extra
Everybody is
wire
smiling
also.
by the statement of illusion.
At some point.
Yeah. Next. So, and this is again, I have put a cutting balloon to the diagonal. Come back.
The same cutting balloon or the another size or 2.5?
No, it is 2.5 cutting balloon which I have put in the diagonal. So this is in the diagonal. So why I did this is, one is this OCT finding. You can show them the stent boost. See what happened is, yeah, in the show him the stent boost here.
The second.
Idhula. See, can you see the stent boost? தெரியுது அப்ப என்ன வரல
இங்க வரல.
ஸ்கிரீனுக்கு வரும் இந்த இதுல வரும். Can you show? Yeah. So when you look at the stent boost here, I put a balloon there taken. You see that calcium there in the LED as well as in the diagonal. There is a significant calcium seen there. And looking at this amount of calcium, I really wanted to take something like Volviren so that I get a better preparation. This was one, and OCT also showed the same thing. And what
But
we were
OCT
thinking
was not
as-
showing that significant is the calcium there, you know.
No, lot of lipid there. It is mixed with lipids. See,
But
that's
actually,
the problem.
angiographically, you are seeing a calcified calcium there. But actually, if you see the image now, you may see that it is a calcium. But in angiographically, actually, the OCT wise, we see actually more of a severe lipid. I don't know whether this.
See, that is the problem. See, when there is a lot of lipid, you cannot see anything there. It becomes darker there.
That
So
is
we
actually
have-
one way of actually telling that if you have an underneath calcium with a severe lipid in front, that is actually the plaque actually, the lipid is covering the calcium. This is one fallacy with the OCT in calcium.
OCT, yeah. It's very difficult. Even in IVUS, when there is a lipid, you
No, I'm
cannot
not
make
telling about
movement.
IVUS or OCT, I'm telling that OCT we think that the
Imaging,
calcium, the best imaging modality is calcium, but the lipid covering the calcium in OCT is a problem. That's what I'm telling.
Correct. That is said. So lipid content, if it is very high, very difficult. But anyhow, we could see the nodule there. In the OCT, it showed us, definitely there is a nodule which is projecting there at the carina. And with this stent boost also on an angio, it was very sure that looking at the stent boost itself, we had a lot of anxiety to be very careful with this lesion, although looking very simple. And with this idea only, I prepared it with a cutting balloon. I'm just waiting now. So
No,
even
one problem I tell you that these type of patients, when you prepare the lesion, you put a cutting balloon there. In the normal segment distal to that, when you dilate very high pressure, you may create a dissection distal to that. If you create a small dissection there, what actually we would anticipate, there is a lesion distal to that. Nearly from the 12 millimeter onwards, another 12 to 15 millimeters, there is a lesion in the diagonal. So that lesion along with this calcium there with a cutting balloon, probability of having a dissection in the LAD diagonal osteoproximal part is high chance.
Yeah,
I
but
think,
what we think is, when compared to a NC balloon, when you use a cutting balloon in the side branch, chances of dissections are very, very less.
So
Only if
actually,
use
you
an
have to
NC
be
balloon.
very fast, you know. The meeting is meeting, and they are actually taking time is also important, you know. So please,
No, we will go a
please be
little bit
fast.
faster now.
In another 2
Yeah.
minutes, you should tell the steps you have done. Then we will go to the session.
No,
2
that's all.
minutes.
Now I'm going to do the steps now. If
Oh,
can
you are
want
going to do the steps only.
Yeah, you go to the top and come back.
We will be
I'm
keeping
going to
your
send the LED
images
now.
on one side, and we will have a talk on the other side.
Sure. And as I told you, I'm sticking on to the provisional stent now. I'm going to stent the main vessel, and I am for protecting the side branch. What we are doing is we are just we have dilated with the cutting balloon. I think that is sufficient here now.
Selva, why I
And,
told a different opinion, if you are sticking on to that, I am also telling yes, then what is the meaning here? It is a competition, we are actually fighting each other.
No, but whatever you said, why I am not contemplating jailed balloon technique in this patient? We do that. We have done it in few cases.
Yeah, you did a cutting balloon and actually we are happy with that, and let us see the next session of angiogram going on, and Shiva is actually very clear that he wants one talk to be done.
Selva, fantastic. You have platformed the case fantastically. Go ahead with your strategy. We'll come back to you in between two lectures. If you permit us, can I invite Dr. SKP to proceed with his lecture, Selva?
Yeah, sure. Go ahead.
Please.
And by the time we would have probably will come back after the lecture and show you what we did.
Don't worry, your diagonal nothing will happen to your diagonal. Don't worry about that cutting balloon, and in between the segment, dissection, all that. Whatever happens, you have a lot of experience to manage everything.
So I welcome Dr. Karupaya sir for the keynote lecture, Imaging versus Angio-Guided PCI, sir's experience. Over to you, sir.
Good morning, everybody. I thank Siva and the team for giving me this opportunity again. Today's topic will be IVS versus angiography guided PCI. Before sharing my real life experience, I just wanted to present one trial, ultimate trial. There are a lot of multiple trials, both randomized and this one, properly randomized trials also there. Even syntax 2 trial, where they used almost 85% of the patients they used IVS. Compared to syntax 1, they used only 4%. There was definitely proven superiority of IVS guided PCI compared to angiography guided PCI in terms of target vessel failure, improvement in target vessel failure, re-MI and revascularization. This trial, ultimate trial, almost 1,500 all comers from 8 Chinese centers, randomized 1:1. IVS guidance 724, angiography guidance 724. Primary endpoint being TVF at 12 months. Secondary endpoints all cause death, MI, TLR, ISR, stroke, and individual components of primary endpoint. That's very clear. 12 months at the end of this is 12 months follow-up trial. 12 months IVS guided PCI gave a better results in terms of primary and secondary outcomes. Okay, with a significant p-value 2.9 and 5.4. P-value was 0.019. So the target vessel failure at 12 months was 2.9, and the IVS guided PCI group compared with 5.4 in the angiography guided PCI. All comers undergoing PCI, IVS guided PCI was associated with a lower frequency of target vessel failure at 12 months. That was the ultimate trial. I think this trial came in 2018. The recent trial, this case was followed up for 3 years now. This came recently. 3-year follow-up of the intravascular IVS guided drug-eluting stents implantation in all comers coronary lesion trial. You could see that very well. The target vessel failure rate, the blue was angiography guided and the red one was IVS guided. You see all the components compared to IVS guided PCI is better, clinical outcome is better with the IVS guided PCI compared to angio guided PCI. And also in that some sub-study, even if you do the IVS guided PCI, if you go by the predefined criteria of optimal IVS parameters, the results are much better rather than doing just IVS, making some measurements, some vessel size, everything. There are certain predefined criteria for optimized PCI. If you go by it, the results are still much better compared to suboptimal results of PCI. Okay. So with this, I just want to share some of my real experience. A couple of cases I want to show. This lady, 79-year-old lady, came with acute anti-reval MI 6 hours ago, not laced outside. Past history of PCI to proximal lady few years ago. Basic blood parameters were normal. Echocardiogram showed mild LV dysfunction with anterior hypokinesis, EF 45%, stable hemodynamics. So, being an elderly person and just 6 hours of onset of acute MI, thought we'll take her for primary PCI. Sorry. See, that was the first angiogram. You see the LAD is occluded proximally. Other vessel shows mild disease, diffuse mild disease. I went with a curve. I had to put a secondary curve to enter into the LAD, but even then it won't go. After trying for 15 to 20 minutes, being the salvaging of the myocardium being the primary point here, I just took her off the table, thrombolized with the teratoplase, and took her 2 days later. The fourth picture is 2 days later. The LAD is open now. Because initially for primary PCI, I could not find out the track at all. It was going into a small branch. So I didn't want to take any risk. The patient was stable. So I just thrombolized her at that stage. I took to the lab 48 hours later. And the thrombolysis was successful. Now I could see the whole LAD there. There was some bend there in the proximal. That's why I could not go. The wire was going like this all the time. The bend I could not see. So I pre-dilated the previous stent stenosis and did the IVAS, obviously to know the mechanism of failure of the stent and also to see any atherosclerosis and other things. The IVAS obviously shows there is a huge underexpansion. The previous stent used was 2.75. That was few years ago where it was angio-guided PCI. Only 2.75 stent was implanted. Now the measurement was almost 4. You need to implant 40 stent. The media to media measurement was almost 4.5. And there was not much neointimal growth. I don't know if there is post-dilatation, IVAS shows that. There is gross malopposition, not under expansion, or it could be acquired malopposition. I don't know. That was the reason, and that caused thrombus in the proximal to the stent, causing MI. So use the cutting balloon, score flux, and routine procedures, dilated it well, and that is the final result of the PCI. We had a reasonably good result, even though she had some diffuse disease in the mid and distal segment. There was a good TIMI3 flow, and symptoms settled, hemodynamics all settled, and this I did it 2 weeks ago. Is so far doing very well. So, what did I learn from this case? Without IVAS help, how did the IVAS help me in this case? Obviously, it showed that the vessel size was 4, proximal LAD size was, whereas the stent implanted previous few years ago was 2.75. We know that under expansion and under sizing of the stent is the most potential cause for further complications in the form of stent thrombosis and stent stenosis. Actual size of the vessel was 4. So it helped me in selecting the correct, in selecting the balloons for correct pre-dilatation, selecting the balloon for cutting balloons, and also helped me in selecting the current stent size also. And to some extent we can quantify the calcium in the IVAS, and also to decide the need for other devices and confirm the optimization of the results, like proper expansion, proper apposition, and minimal area, luminal area. All those things you confirmed with the IVAS. This is how IVAS helps compared to angio-guided PCI. Most of the IVAS-guided PCI compared to angio-guided PCI, 30% of the cases they ended up using larger balloon to post-dilate. So this is where you get a gain of good minimum stent luminal area, which helps in long term better clinical outcome. So this is some parameters to confirm with the IVAS for optimization of PCI. Complete stent apposition, of course, minimum stent area more than 90% of the reference segment, or there is, if you can't go to the reference segment, the distance between the adventitia and stent, if it is more than 0.5, that you can take roughly as an under expansion. And there should not be any proximal stent deformation. There, of course, no dissection or hematoma, and you should not land, the landing zone should not be more than 40% plaque burden and stent edges. If you go by this optimization PCI, the results are still much better. Long-term clinical outcomes are much better. Second case, it helped me early recognition of significant calcium. This man is a 56-year-old gentleman, unstable angina, recent anterior MI, type 2 diabetes for 15 years. Echo showed severe LV dysfunction. Angiogram showed significant proximal LV lesion. And because of LV dysfunction and few weeks prior MI, did the viability study. It showed LAD territory showed more than 70% viability. So took him for the lab. That's the angio. How much you can quantify the calcium in the proximal LAD angiographically? I think even though there is some suggestion of calcium, angiographically I would not say there are significant calcium which needs any major devices. That was my impression angiographically. So what I did was I did an IVAS after pre-dilating the lesion. IVAS showed significant calcium. Even though I could pass the balloon, 2-0 balloon, it showed significant calcium. See, almost more than 180, sometimes almost 360-degree calcium was there. So I decided it's a proximal LAD, which helped me to decide to go for rotablation upfront. So did the routine stuff, and the final result was good. And still this patient, I think November, sometime I did doing well. So I was compared to angiogram in this case, helped me to make a decision to go for upfront rotablation, because I was showed significant calcium compared to angiogram alone. If I go by angiogram alone, if I didn't have IVAS, probably I would have keep on dilating with NC balloons and maybe ended up with under expansion or suboptimal result of the PCI. The rotablation really helped me to optimize the results. Okay. Another just small case, 59-year-old gentleman, progressive angina of 1 month duration, had PCI to RCA 4 months back in the other hospital. Troponin and essential parameters were normal. Echo showed infralateral hypokinesis. Left side angiogram showed some moderate disease in the middle AD, but there was a big diagonal which showed critical lesion there. We did the FFR of the LAD, which was negative, but the critical lesion I wanted to address the diagonal. Before that, did the RCA. This picture was post dilatation. Okay, I confirmed with IVAS there was a significant stenosis somewhere here, instant stenosis, and also IVAS confirmed 2.75 stent implanted, but the vessel diameter is almost 4. Probably that was the under expansion was the reason for the instant stenosis here. So RCA was pre-rated with 3.5 volt. I decided to treat it with the DCB. Okay. Sorry. So pre-directed with the 3.5. The guy, according to the IVAS guidance, we have to almost go for 1:1 ratio pre-dilatation. Once you decide to go for DCB, 3.5 30 millimeter DCB I used got a reasonable result. Then what happened was I went back to address the diagonal. When I finished stenting the diagonal in the left system, FFR was negative to the LAD. Patient had some chest pain. That was almost 20 minutes later after I completed the RCA, chest pain and hypotension. So I came back to just check the angiogram, the RCA. That was the picture. We missed the dissection. When we did the pre-dilatation, it was somehow slipped. We missed it. I retrospectively analyzing everything, there was some dissection when I finished the case. Mild dissection there at the edge of the stent, which we missed it. But after addressing the diagonal 20 minutes later, when the patient developed chest pain, we realized there was a huge dissection there. So, no problem. I passed the wire, but how to be sure before stenting whether you are in the true lumen or false lumen in such situations? Wire went in easily, but before stenting, we need to be very sure whether you are in the true lumen. Okay? So, what I did was, because I already had IVAS, I just passed the IVAS. See, once I saw that branch, this was a distal branch from the lesion. Origin of the branch, probably once there is a 3 layers were visible first. all the 3 layers are visible. That means probably that indicates you are in the true lumen. And another evidence was when you see the origin of the side branch vessels, probably that also helps you to confirm it is in the true lumen of the vessel.
And you can know the extent of the dissection also. But this is a 20 megahertz, isn't it?
Yeah, 20 megahertz only. So then I was very confident in stenting that dissection because I was in the true lumen. Okay, that was the final result. This case, IVS helped me to confirm I am in the true lumen before stenting the dissection. That was very important because if I wrongly gone for the false lumen, it will be a disaster. So what's the take home point? IVS has been in the guidelines, ESC guidelines, everything. It was given us 2-year indication in selected number of days. By real life experience, I would suggest, I think everybody will agree that we have to go beyond the guideline and use the IVS more liberally for so many reasons we experience in real life. Thank you very much.
Thank you, Dr. Karupaya, sir. All 3 cases were excellent. Next, we'll go to the next lecture by Dr. Manoj Sivaramakrishnan. Topic is role of mechanical circulatory support in shock PCI versus high-risk PCI. Over to you, sir.
Thank you, Shiv Kumar, for this wonderful invite for this PCI 5D Exotica. And I might slightly overshoot the time allotted, and the organizing chairman has allowed that. And respected NIC chairman, Dr. Pratap, Professor Amadam sir, it's a wonderful time to be here with you at Madurai and had a pleasant darshan this morning, which has been elusive for me in my lifetime. So this is a presentation on the hemodynamic support of the CHIP PCI in both high-risk PCI as well as the cardiogenic shock. We know that coronary artery disease is the most leading cause of morbidity and mortality among the non-communicable diseases worldwide. And the guideline-directed therapy as well as the PCI and CABG have increasing the scope of revascularization, reducing the clinical events as well as the improved quality of life. PCI, as we know, that is becoming increasingly common mode of coronary revascularizations, and the technology as well as the technique has significantly enhanced in the past 2 decades to encompass high-risk patients with old age, complex anatomic lesions like left main, coronary artery disease, CTO, multiple comorbidities of the patients as well as the anatomic complexities, and also for those subjects where the surgical revascularization is precluded. The high-risk PCI has emerged, therefore, as a very valuable therapeutic modality, and is terminology of complex high-risk and indicated PCI has come into place in our practice. Angina refractory to guideline-directed medical treatment and also patients with refractory heart failure are candidates for high-risk PCI after review by the heart team. So we know that when the patient has a high surgical risk or the anatomical risks with a high syntax score with high amount of complexities, we need to do a PCI in these high-risk subjects with complexities involved with the support system. And the support, what we say, is the hemodynamic support. And the complexities could be in various dimensions. Every one of us know that who is being involved in this work of CHIP PCI. There could be complex coronary artery disease morphologies of left main bifurcations, multivessel disease, heavily calcified lesions, bifurcation disease, and also CTO, especially retrograde, which has a long dwelling PCI period. The patient complexities could be surgical ineligibility, previous cardiac surgery, heart failure, diabetes, advanced renal disease and renal insufficiencies, and also acute coronary syndrome. Hemodynamics can add significant comorbidities and complexities because of the immediate procedural outcome, which could be a moderate or severely depressed LV ejection fraction and also high elevated EDP, and the patient being an acute pulmonary edema. So why are hemodynamics so essential? The catheters, the guide wires, the balloon can themselves obstruct the coronary flow, particularly at the native aorto-ostial as well as during the course of the balloon inflations, which may be required multiple times during the course of CHIP PCI and can worsen the ischemia, and myocardial depression can occur in an already depressed left ventricle. Patient may have either acute or chronic left ventricular decompensation with a poor cardiac reserve and cannot sustain any further reduction in the coronary flow. Adverse hemodynamics will lead to incomplete revascularizations, which has an impact on the short as well as the poor intermediate term outcome with cath lab disasters. What is hemodynamics by say? So hemodynamics refers to the principle that govern the flow of blood through the cardiovascular system, and this is by studying and understanding the flow dynamics of the blood through the heart chambers and also to the organs. Involves monitoring of the pressures in the heart chambers, circulatory systems of the arteries and veins, and measuring the output of the heart. Hemodynamics is the essence of sustaining life. It supports oxygenation, delivers fuel molecules for the energy requirements, and removes and transports the waste products of metabolism, sustaining the cellular integrity as well as the vitality of the life. When hemodynamics is unstable, the life is also unstable and is at stake and in jeopardy. So the four factors that affect the hemodynamic conditions are the intravascular volume and also the cardiac contractility, heart rate, and also the vasoreactivity. So mechanical circulatory support devices come in a long way to support the poor cardiac reserve systems, and one of the most important and ubiquitously available and has been practiced in the country as well as in the world for the last 50 years, since 1968, its inception, is the counterpulsation by the intra-aortic diastolic augmentation by the balloon pump. Centrifugal flow devices like the tandem heart and VA ECMO are being increasingly considered. Tandem heart requires a surgical expertise and perhaps not very freely available. The more commonly implanted, very simply insertable, is the axial flow device like the Impella. Will take it one by one. So comparison of these devices show that the tandem heart is not of quite discussion at this point because of its non-availability. However, many of these devices could give a variable cardiac output augmentations. If you look at the IABP, it gives about half a liter per minute of cardiac augmentations, but the diastolic augmentation is not equivalent to the augmented cardiac output which we receive from the IABP, and many of the trials that we see that were not positive in these conditions of cardiogenic shock. Impella and ECMO can provide an increased augmented cardiac output ranging from 3.5 liters to about 4.5 or 5 liters depending on the flow rate that we set. So the role of mechanical circulatory support system is to maintain and normalize the favorable hemodynamics and that maintain the cardiac output and the mean arterial pressure, which translates into the cardiac power output, which is the most single predictor of the survival in patients with cardiogenic shock. And this is by normalizing the oxygen delivery at the tissue level, maintaining the tissue pH as well as the lactate levels. It also treats and prevents the pulmonary edema and thereby maintaining a low or favorable pulmonary capillary wedge pressures and improves the systemic oxygen level. It also tries to treat and prevent increased central venous pressure. So the target for these hemodynamic support devices is to maintain a mean arterial pressure of around 70 to 80 millimeters of mercury and a mixed venous saturations of around more than 60 or preferably more than 65. The indications for temporary mechanical circulatory support are the cardiogenic shock from an acute coronary syndrome, acute decompensated heart failure situations, acute myocarditis, post-cardiotomy shock, and also acute rejections following a cardiac transplant. Higher risk PCI, which includes the chip PCI as we discussed in the complexities that the patient involves, and also the ventricular tachycardia ablations in ventricular VT storms. A bridge to LVAD and also the right ventricular failure are some of the other associated clinical situations where you may have to invoke mechanical circulatory support. The more ubiquitous is the intra-aortic balloon pump. It's a well-known technology for all of us, increases the coronary perfusion, and there's a modest increase in the cardiac output with ease to use and also affordable. The cons is it requires a minimum of cardiac function and needs a stable cardiac rhythm and modest unloading that it provides, and also negative studies. The magnitude of the hemodynamic benefit from the IABP depends on the size of the balloon, and the larger the volume of balloon, the larger is the volume augmentation displaced to the aortic root, and the blood volume displaced to the aortic root at 1:1 support is about 6.4%, and 10% if it is 1:2. So perhaps 1:2 would be a better way of augmentation to achieve a greater aortic root augmentation for a coronary pressure. The hemodynamic parameters pre and post Impella showed that only the cardiac power output was modestly significantly increased, whereas many other parameters like the blood pressure, the heart rate, the central venous pressure, the pulmonary capillary wedge pressure, pulmonary artery pressures, the lactate levels, and the pH did not significantly differ, understandingly that it does not augment the cardiac output, and at the tissue perfusion or systemic perfusion level it doesn't add any much of value. So these are the trials that did not show the BCIS as compared to an unplanned IABP. The IABP shock also, as compared to not having a control or placebo IABP, did not show a significant outcome. And therefore, the IABP has been downgraded as a support for the cardiogenic shock and also sometimes in a high-risk PCI. Impella, the world's smallest heart pump, can be inserted retrogradely through the aortic valve into the left ventricle, has the automatic impeller controller and also the axial flow pump devices. It's a non-pulsatile microaxial flow with an Archimedes screw that continuously spins, and it can provide a flow rate of about 2.5 to 4.3 liters depending on the impeller 2.5 CP or 5 devices. It continuously pumps blood directly from the LV to the aorta independent of the cardiac cycle and results in continuous left ventricular unloading, which is volume dependent. With increasing pump flow rate, the LV becomes increasingly unloaded and it reduces the LV EDP, decreases the LV work and myocardial oxygen demand, resting the heart and allowing the heart to recover. Greater degree of unloading results in greater dissociation of the LV peak pressure and also aortic pressure, resulting in ventricular arterial coupling, improves the distal coronary flow as well as the coronary perfusion pressure in the presence of critical stenosis, and therefore lessens the ischemic burden. So you would see that appreciably that there is a significant depressed left ventricle, and with the impeller CP, you would see that there is a distinct improvement in the myocardial contractility. So once you put in the impeller as a retro-aortic LV to aortic pump, there's an increase in the flow and mean arterial pressure, cardiac power output increases, LVDP reduces, and the wall tension, the mechanical work by the LV is also reduced. It increases the coronary flow and perfusion and reduces the coronary oxygen demand and improves the coronary oxygen supply. The mean arterial pressure increases, cardiac output increases, cardiac power output increases, pulmonary capsular wedge pressure favorably reduces. So the impeller coronary blood flow, with increasing levels of performance of the impeller, there is a reduction in the coronary artery microvascular resistance, and therefore with increasing support of the impeller, you can have an increased coronary blood flow. You will see that comparison in the animal models with a placebo versus IABP, the increase achieved in the coronary flow by the IABP is 13%, whereas with the impeller it is close to 47%. So you would see that in the native cardiac heart is unloaded, the native cardiac output or index becomes less. However, there is an augmented cardiac output available from the impeller, and significantly more than what you could achieve by the intra-aortic balloon pump. And this translates into improved systemic perfusion with reducing lactate levels, and also significantly translates at 30 days in the PROTECT 2, that almost a 1/3 reduction in the major adverse cardiac and cerebrovascular events. Some of the case studies that I wish to share is this Rocky Mountain chip PCI, which you would have seen having presented in many platforms. It's an 81-year-old gentleman who came with an acute coronary syndrome, and initially troponin was normal. After 4 days in the hospital, developed end-STEMI, increasing troponin levels, increasing creatinine levels, depressed left ventricle. He had all the comorbidities of the hemodynamic complexities, complex coronary anatomy, and also the clinical comorbidities. When you look at the protected PCI algorithm, if a gentleman has, the subject or patient has ejection fraction of more than 40% or a basal cardiac index of more than 2.2 liters per minute, it's unlikely to need any kind of mechanical circulatory support. However, if the reverse is the case with a reduced ejection fraction of less than 40% and cardiac index of less than 2.2, you would have to assess various other parameters, which I'll touch upon that. And if you have none of these associated parameters, it's unlikely to need mechanical circulatory support. If you have one or two of these, you should strongly consider, depending on the various resources that the patient may have. But if it's 3 or more, definitely there's a strong indication to support the patient with a mechanical circulatory support. Some of these patient characteristics are the high syntax score, depressed left ventricular ejection fraction of less than 25%, ACS presentations, prolonged revascularization of more than 2 territories, retrograde CTO, requirement of atherectomy devices, and also significantly elevated LV EDP, which are more stronger in clinical indicators to add mechanical circulatory indications. This gentleman of 81 years had a very high pulmonary capillary wedge pressure of 24. He had a severe PAH and all the requirements with more than 2 vasopressors. So this patient was, the coronary anatomy, you would see that there's very intensely calcified left main, and there's a mountain of calcium in the whole of the left main, and that you would appreciate going into the distal bifurcation into the LAD and the ramus, and a complete revascularization could be achieved with the use of Impella, as well as you would see that it's a VA ECMO device has kept as a standby. But most of the time the VA ECMO was not initiated, and the Impella CP was introduced, and this patient required a serial multiple rotablation with 1.25 and 1.75, and then had a successful, you would see the amount of calcium on the imaging, and multiple balloon dilatations after the multiple rotablation, atherectomy with IVL and a bifurcation stenting, and he had a very successful PCI. So this gentleman, who had a native cardiac output of 1.96, had an unloading to bring down the ventricular output of 1, and the Impella CP gave a 3.5 additional cardiac output, sustaining almost 6 hours of the procedural time, and post-procedural hemodynamics was quite stable, as you would see that all the parameters, the PA pressures have come down, the LVDP has come down, the ejection fraction immediately recovered to around 46% in 24 hours time, and we have a 1 month and 3 months follow-up. Subsequently, this gentleman passed away due to his age, and also during the second wave of the COVID. His ejection fraction at 3 months of follow-up had come down to 52%. He was angina-free. The second case is a 83-year-old lady who had come to the ER with an acute coronary syndrome, and she was in pulmonary edema with a saturation of 78 and with the S3 gallop, and developed a cardiac arrest. She was revived, and she had another two more consecutive cardiac arrest with VT-VF in the ICU, and was revived again. And you would see the global ischemia with ST elevation in AVR, and also the lead V1. What was also striking was she had a peripheral arterial disease with the calcific nodule in the aortoiliac junctions, which required treatment with IVL balloons, peripheral IVL, and then we could do, and initially IABP supported left main ostial PCI, and you would see that the hemodynamics had reverted to normal. But soon after the PCI with an IABP, you would see that the pressures were still low. Patient was in cardiogenic shock. Pulmonary capillary wedge pressure was 18, and we had to use an Impella CP upgradation with an Impella, and IABP was removed.
So
and post Impella, you could.
I think in MMHRC they are ready with the case.
All right, no problem.
We would like to hear a lot from you, sir. You can join us.
No problem. Yeah. That's okay. Maybe another 5 minutes. No, if they want to, if they wish to.
Okay, then is it okay for you? Is it okay for you, Manoj? Manoj,
Okay.
is it okay for 5 minutes?
No problem. Sure.
You can also be part of the discussion of the.
No problem. Welcome. Thank you.
No, you can stand there also.
Yeah, I have something to jack up my height here.
Okay, live.
Yeah, warm welcome and greetings to Dr. Julio. Welcome you, sir. You are on mute.
Thank you very much for inviting me.
Thank you, sir. We have a great chair here. Nick Chairman Pratap, interventional cardiologist from Delhi, Dr. Balbe, Professor of Cardiology Amudan, and a lot of panel here. There is a live case from MMHRC, Dr. Selvamani is doing, sir.
Yeah. Connect பண்ணுங்க. Connected, huh? Yeah, okay.
Please. Now no Tamil, only English.
Yeah, can you hear me?
Yeah, only English.
Pratap sir, can you hear me?
We can hear you,
We can
sir.
hear you because the Anand is creating all the problem. Nobody, no communication.
Okay, so when we left here, I can see Dr. Julio here. Sir, welcome to Madurai. And I can see Dr. Manoj also there. Good afternoon, Dr. Manoj. And here we are in between this live case where we were dealing. You can make this, you can show them the screen, angio screen. Angio screen coming, angio OCT வருதுப்பா. நம்மது இல்லையா அங்க வருது அங்க இருக்கணும். Sure. See, where you left us when I had done a cutting balloon in the LAD and in the diagonal ostium. What I have done is I have taken a 2.5 into 38 Zines expedition stent there, and deploy it from the proximal LED across the diagonal there. So this was deployed, and then I have done a post dilatation. Go there. This was the end pot and the NC done there. Next. 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 So the diagonal was still was well preserved there. There was no issue. And after NC, but anyhow, I want to be very careful when I do a pot for that LED stent there. So I rewired through the stents now, through the stents into the diagonal, and I have done an adequate pot there. Show them the result. And this, I did a final kiss also for that LED diagonal. I have not put a stent in the diagonal. It's only a final kissing balloon thing what I have done there. And this is the final angiographic results here. So, and I have done a pot also. I did a pot with 3.75 balloon in the proximal segment. And this is the final result after doing a final kiss there in the LED diagonal. And now we will go to the OCT. I have done a OCT also. You can show them the OCT here. Other 2D model. That off. Then off. ACR, go to ACR. Yeah, right. Yeah. So this is the OCT that you are seeing there. And you see here, we have actually landed at the exact position where we had planned. You can see the 3 layers of the vessel here, and there is no distal dissection. And although it's a diffuse disease, the plaque burden at this area is minimal. There is not much of plaque burden in this area. That is where we landed. And you see that stent expansion is reasonable there. With an expansion area of around 3.5, 4.5, 4.23, but it's a small vessel there. So well expanded stent there. And when you come here to the bifurcation point here, and this is the septal there. When you come here, this is the diagonal here. You can see the diagonal here, and it's well open. And what I'll do is I'll try to bring it down here. So this
further move the cursor down a little bit.
Doing it. So you see that this is the LED diagonal bifurcation point here in the longitudinal view you are seeing. And when you come up here, we dilated with a 3.75 NC, and you see here the struts are well opposed there in the proximal segment, and there is no dissection with excellent opposition there. And coming to the bifurcation point here, at this point, we can go to the bifurcation mode also. See there are no struts across the side branch there. Yeah. So this is the side branch opening, what we are seeing there. The diagonal opening. There are not much of, there are no struts at all across the side branch. And the side branch is well open there. And the opposition everywhere in the proximal and the distal part is all excellent there. And we have a good result. I think with the provisional itself, we went ahead and we have got a good result. The diagonal is well preserved. And any comments?
Well, I think it's a great result and beautiful imaging and perfectly commented. The only point that remains in discussion is after the septal branch in the distal part, you have an NSA less than 4.5 because it is 3.4. And with expansion that automatically was assessed as a 56. So the question is, do we need to do an additional post deal? Which type of balloon did you use for post dilation at this segment? The ones where you have the red.
Yeah,
here you have. Okay,
Yeah,
here is
yeah.
clear. The proximal
Actually-
landing zone is 274, and the distal landing zone is 222. And so, which type of balloon was used for post-deal?
Yeah, see the stent expansion in this, actually now what I have done is I have divided the stent into the proximal and the distal part here. And now, but although as you said that the MSA is around 3.43 there, what I have done is the EL of this vessel here, when you look at this, is only 2.5, but I have taken a 2.75 NC and I have dilated up to 14 atmospheres there. So when you measure the EL, it is somewhere around 2.5 to 2.75, and I have exceeded or almost slightly above the EL size I have used here. In spite of that, that is what the lumen area we are getting. The MSA is also there, and I don't think we can go beyond this because the EL is not bigger, and we have reached the size of the EL. And what other options do we have to get a 4.5? But the vessel itself is small there. I think that is why the MSA is around 4.8 or something. And now when you look at the percentage of expansion, now when you divide the stent into this two segment, I think you will have an almost 100% expansion there. Now you look at the expansion here. Are you seeing the full screen? Yeah. You should see for the expansion here. Our software here, whatever is saying, there is some corruption, so that is not correct here. So you should always see in this year, this 100%, and then keep expanding. It's almost everything more than better expansion, but this one area is slightly lesser when compared to the proximal segment.
So the difference is mainly in the plaque. The distal one is normal, but I'm with you. I got the point. But here you can see that the EL is minimally visible because there is a more plaque burden. And so in this case, I think that you can, if you are considering to make some additional balloon dilation, you need anyway to be quite careful. But this is the point. So lesion preparation is extremely important to end up with a perfect result. Here, there is a little bit of under expansion of the stent limited to the plaque burden that possibly is more at this point.
Selva, retrospectively, do you think you could have used that cutting balloon down below also?
We used actually 2.5 cutting balloon there.
Use that particular area, distal main vessel. I saw you using.
But probably that one area below the diagonal, probably we have not touched with the cutting balloon. That is why we are having a smaller thing now. But now options left.
No, actually, I just want Selvamani. Dr. Julio, my question is actually, when the luminal area distal to the stent, where all the three layers are seen, it's only 3.4. Then how do you expect that the vessel should be 4.5? That's what is my question.
Yeah.
That is an important point. So you try to mix the reference, that is an important point, with the final area. But in fact, if you are looking to the two landing zones, the proximal reference and the distal reference, you can see some significant tapering. And of course, now you wanted to say that, Dr. G, why not to be based only on distal reference instead of the proximal one? And that is another point. So there are multiple different methods to assess the perfect expansion. And in this case, you highlight that the risk to have a full expansion disrupting the vessel is no marginal. So I'm taking 2 points. The ones of the operator that said, we haven't used the cutting balloon in this segment. Lesion preparation is extremely important, but also your point of view that said, Dr. G, we are at the limit of the distal reference, and so why not to accept? I think that is a good position. I'm with you.
One more point is there, because The proximal reference cannot be taken here because we have a diagonal there. We have a second, it's a large side branch with the proximal vessel. So the proximal reference, how can we take it as a point here? He is telling after post diagonal, that is what.
No.
Oh, you
But
split-
actually, Pratap,
Yeah.
I have kept the proximal marker after the diagonal.
Okay, then it is okay.
I have kept it just
it's
after the
perfect.
diagonal and
Yeah,
divided
then
into
it is
two parts.
perfect. Okay.
No, it's perfect. The landing, the identification of the reference was perfect. So thank you very much. I think you addressed two very important points. The relevance of lesion preparation, but at the same time, to have a look to the size of the distal reference, because sometimes we are really at the limit.
Perfect case, Selva. I think the message was clearly conveyed, very demanding case. The cutting balloon strategy was excellent. Probably the message is conveyed that this expansion part was fantastically discussed. Proximal reference, distal reference. Thanks, Dr. Julio joined us right on time. It's time for you to conclude your team.
Shivakumar, I have a question.
Yes, Dr. Balbir.
Excellent, sir.
Selva, 1 minute. Dr. Balbir want to interact with you.
So, Julio,
yes, sir.
if we look at all the trials, if you look at the ultimate registry, if you look at the element 4, they don't go by this software. This software may show you 53%, but this is not correct. You have to match it to the difference, distal reference area, which is what all these trials have said. And sometimes in the Indian vessels, achieving a 4.5 area is impossible. You can't get it. So without risking a rupture. So just going by the software and saying that it's 53% may mislead some operators to actually overdilate and cause a rupture. So I guess one has to be very careful and not take what the software is telling you, that this is under deployed. It is not. The distal vessel we saw was a normal vessel and the area was 3.3. And this lied just within that distal vessel. We can't make it 4.5 by any chance.
Okay, I think you are fully correct. I wanted to clarify my position. So there is no way that one software can substitute in de-skilling the operator. All type of software need to be confronted with the reality. And in this case, this is a great example of how we need to compare the automatic response with the clinical judgment. So I think that is relevant.
Good. Sir, excuse me, sir. Sir, one question. I'm Selvignesh here. Sir, you did a final kissing balloon to avoid the floating stud in the side branch. How often you do in a LED diagonal as well as in the left main bifurcations?
Yeah. See, in the elective stenting strategy, when you do final kissing is always controversial. But here, what I decided is it was a long diagonal, important only diagonal left there, and ostium was also diseased there. Although there was TIMI3 flow there, generally if it was a left main, what I do is before doing a final kiss, I will do a OCT run and I will see how many struts are across the circumflex ostium. But here, this diagonal was a smaller vessel. Even if you do a OCT, many times you may not see in which strut you are crossing. So what I did is I tried to cross distally and I have done a kissing. And now post kissing, I have demonstrated there is no struts at all. So the criteria to do a final kissing is if there are significant struts and if there is a connecting carina, especially across the circumflex, I think you should kiss. And if there are no struts, I generally don't kiss at all. But in this specific case, why I did is since it was an important diagonal and I was a bit buried also, so to be very careful, I do not want to lose it. So I did a final kissing, but it's given a good result.
Yeah, fantastic, Selva. You can just conclude by thanking your team. I could see Sampath, I could see Shankar.
Yeah,
please.
See, all this, we had a good discussion, me and Sampath, and then here Thomas and Ganeshan, and we discussed this case, and then we went ahead. And it's our team here on a Sunday morning, very bright and happy year, Dr. our anesthesians and our senior technician Anbu, senior staff Sampath, Sandal and Esther, all are here. Thank you very much for the beautiful audience there and very good advice from all of you seniors.
So Selumani, you should come and join with us.
All of you there.
Selumani, you should come and join with us. Selumani and Sampath should come and join with us.
Yeah, we are coming there.
Please.
The next
Okay,
work is
thank
only
you,
there.
thank you.
We are
Thank
coming
you.
there.
Right. This is an opportunity for me to invite a hub from Chennai, where the lead chairperson is Dr. Anandaraman. With this, I am closing the present chair, and I am inviting from here Madurai hub Dr. Jawahar Farooq, Dr. Keshav Murthy, and Dr. Karupaya, and Dr. Vadivelu to go and occupy the dais. And we will continue with Dr. Manoj. Now, Manoj is lucky. He is representing the Madurai hub as well as his own native Chennai hub too. Yes, Manoj, please go ahead.
Thank you, Shivakumar, for allowing me to come back again.
You can say hello to your friends there.
Yeah.
Sundar. I welcome the Chennai hub, Dr. Anantaraman. I could see Sundar. Can you just show the Chennai hub in a minute? Yeah. Yes, Sundar. Anantaraman is in the center, and I could see Elilan. Great. Fantastic. The studio is marvelous there.
Thank you, sir. Manoj sir can continue, and then we'll join.
Yeah, thank you for allowing me to be back on this hemodynamic. So this patient, I was saying that post-PCI, she continued to remain in shock, and the pulmonary capillary wedge pressure was 18, and after the treating of the peripheral IVL with a shock wave with aortic iliac calcification, we could introduce the impella and remove the IABP, and you would appreciate that the post-impella, the central aortic pressure had significantly augmented because of the increase in the cardiac output. So if you see the blood gases at baseline, the lactate was 2.15, and post PCI, before the impella implantation with IABP, the lactate had gone up to 15.4, and post impella it had dropped by around 2.7 in about half an hour post. Also, the PO2 also was significantly enhanced with the impella initiation, which speaks of the reduced pulmonary capillary wedge pressure and also improved oxygenation at the liver, at the lungs. So next is the extracorporeal membrane oxygenation. It's a portable modification of the heart-lung bypass. VV ECMO provides respiratory support. VA ECMO provides both the respiratory support as well as the hemodynamic support through oxygenation and also perfusion pressure. The main indication for VA ECMO includes profound cardiogenic shock with respiratory failure and also cardiac arrest. So the primary hemodynamic effect of the VA ECMO is the decreased preload and also increase in the afterload. So the contribution of the increasing afterload, depending on the flow rate that you are fixed with the VA ECMO, is a progressive LV distension and absence of the aortic valve opening, leading to increase in the LVEDP, increased myocardial oxygen demand, ultimate decline in the myocardial perfusion pressure, and also the patients with especially significantly depressed LV functions. VA ECMO has, however, been shown to have a high feasibility of success to allow the high-risk PCI to be completed, and is also associated with improved short-term survival and favorable neurological outcome in patients with out-of-hospital cardiac arrest and also cardiogenic shock complicating acute MI. So depending on the flow rate, you could have the mixing cloud moving proximally and distally. If you have a high flow rate, there is also increased risk of stroke. If you have a low flow rate, the risk of stroke becomes lesser as the cloud of mixing the oxygenation as well as the deoxygenated blood becomes lesser to the aortic arch. So the case is VA ECMO supported CHIP PCI in a post-CABG ACS with cardiogenic shock. 60-year-old lady post-CABG developed a progressive chest pain which was ignored because of the sternal pain, and finally she came with a rest angina and pulmonary edema. You would appreciate there was a significantly depressed echocardiographic. The EF was around 18 to 20%, and she had acute kidney injury. Only a ramus was patent. Most of the other vessels were closed, and also you would see that the RCA was total, the LAD was total, and the grafts were all occluded. The only graft which was patent was the venous graft to the diagonal, which is a huge diagonal, which also had anastomotic as well as tandem shaft stenosis. And this was the pressures to start with, a femoral artery pressure of mean of 54, central aortic pressure mean of 50, and the VA ECMO was initiated, and this was about 7 years back when we did not have the impella available. So we would see that during the balloon inflations, there's a progressive diminution of the electrical complex velocity. The ECG QRS becomes very diminutive, and that translates into reduced pulsatility because of the myocardial depression, and almost become a near non-pulsatile linear flow maintained by the VA ECMO. And subsequently, a successful PCI could be achieved. Immediate post-PCI, you would see that the hemodynamics becomes extremely importantly improved with the pulsatility recovered, with the QRS voltage also recovered. So VA ECMO maintained adequate perfusion for this patient with the repeated balloon inflations and the transiently depressed with further myocardial contractility to near non-pulsatile laminar flow. This is another case of ECMO-protected primary chip PCI in an out-of-hospital cardiac arrest. 27-year-old gentleman who came with chest pain. He had multiple massages as well as about 7 defibrillatory shock, and transient echocardiogram, the ECG showed a VF, and you would see that after he achieved a sinus rhythm after the 9th shock with a CPR time of 33, this patient had ST elevation and was transferred to the hybrid OR. He again had a VF continuingly persistent, and ultrasound guided VA ECMO access was taken, and PCI was performed. And soon after the ECMO was in, before the ECMO was in place, you would see the pH was 6.7, lactate was 15, saturation was 4%, and this was a dead man's blood gases. So you would see that transiently he was in a sinus rhythm with a cardiogenic shock situations, and during the sinus beats there is a contractile reserve of the myocardium, but most part of the time this patient was in VF maintaining adequate mean arterial pressure by the VA ECMO in a non-pulsatile linear manner. And the PCI was done for the LAD with a Meares absorb stand, Meares bioresorbable scaffold. Patient post-reperfusion also remained in VF, but the mean arterial pressure was maintained around 89. You would certainly appreciate that without the VA ECMO, this patient pressures would have been abysmally at 0 levels. 2 hours post-reperfusion, this patient returned to sinus rhythm and maintained normal hemodynamic. He was in VF for nearly 8 hours, and he leads a normal life now with his wife, and came for the COVID vaccinations about 6 months later. This is a case which I would not show because I think Sundar is showing it, and there's another case of cardiogenic shock which we did. For want of time, I will skip this case, and we'll go to the conclusion, and you would get more details from this from the Sundar of this case that we recently did. I'll go to the last slide. So the hemodynamic support by way of mechanical circulatory support is an essential and critical necessity for a high-risk complex PCI, also in patients with cardiogenic shock of various etiology. Percutaneous insertion of mechanical circulatory support is a delightful experience for patient as well as for the chip operator, and is the best possible chance for the patient to survive. Impella efficiently saves the heart and also feeds the body, and is the best way forward. VA ECMO provides the advantage of maintaining the oxygenation in a patient with a high risk of cardiac arrest, especially with shockable rhythm with ventricular tachyarrhythmias and sometimes in asystole. The role of hemodynamic support in high-risk PCI is only minimally addressed in the guidelines because of the lack of evidence of randomized trial. We would appreciate in many of these trials the randomization could not be completed. A team effort from interventional colleagues, cardiothoracic colleagues, perfusionists, cath lab person is very vital and paramount for the success. Impella experience gives a very compelling indication for its chip use in chip PCI with a depressed left ventricle. And if you have the machine, the device, the man, and also the mind, you could certainly recover the failing heart. And thank you for your patient listening. And these are the cases that were rewarded in the Singapore Live in the last couple of years. Thank you.
Thank you very much, sir, for this wonderful talk, actually. So you have the routine, whatever we use it in IABP, one side, Impella and ECMO, which the cost is most important consideration, actually. And when you select a patient, how do you select these devices according to the clinical situation? When you want to upgrade, what are the parameters you take into the consideration, actually?
I think it's quite vital. I didn't put those slides because of want of time. But if you feel that the patient has more of a ventricular tachyarrhythmias because the Impella needs a certain amount of volume dependency on the left ventricle, then if you do not have a stable rhythm, Impella may not work in that situation. So you have to go for a VA ECMO support. In most of the other situations, I think Impella certainly is superior to the IABP. But many of the trials have not shown a significant survival benefit, but perhaps we will see from the PROTECT 4 trial whether that is the case depending on the IABP. But we certainly know that not only the coronary perfusion improves, but also the systemic perfusion also is enhanced by these mechanical circulatory support devices, whether it's an axial flow or the mechanical circulatory support. So if you have a shockable rhythm and there's a frequent ventricular tachyarrhythmias, I would embark on a VA ECMO support, because when there is poor LV filling and there's poor circulatory return to the heart, I think ECMO is much better. Obviously, the cost is a significant constraint in these situations, and availability of these devices. We are fortunate to have this Impella in our shelf anytime that we require, and patient agrees to put in, then we will use it.
Manoj, one question. Cost is a major factor. No randomized trials telling that this is beneficial also.
Randomized trials have not been able to complete, actually, in cardiogenic shock, yes.
Comparative study is always possible with the low ejection fraction indications. Actually, we should start a study where there is availability, non-availability of these materials versus the available usage. But I think that should be started in the country.
True.
Because
Absolutely.
as you told, this is actually to be started in the country where it is non-available in many places, but the indication written there is a list of indication. Over-usage of these materials in some hospitals also there. So that is to be compared and finally we can conclude something that these are the absolute indication where to use, not like an American uses for these things for every patient. That is what is my concept.
I think because of the cost considerations, I would say that there is a significant delay in initiation of these devices, even in our cases, because the moment you put across the cost aspect of this,
Manoj, what I'm telling about the indication, what is written, many of the situations where we can just get away without these devices also. But I'm telling that we have to have a randomized trial in the country. This is actually, we can actually initiate, since I am in the NIC, we can initiate in the country with this trial. 1 or 2 patients in the country, in 1 year also okay. We can actually,
I think
will
there's
just
a
plan
definite
it.
need for that to understand whether these are appropriate in these clinical scenarios and also in our situation.
I will plan it.
I think the statement by Nick Chairman, whether it is cost effective, whether it is really required in that case, whether this could be managed without the support is definitely a question need to be answered. At present, definitely data is lacking, but this is the way to go. Another one will definitely agree the case scenarios which you have done, the entire team, Chennai team, ECMO as well as other supports, I think we need to figure it out where it is definitely helpful. The statement from Pratap is great that we need to exactly tell where it is beneficial. So let's conclude this session. We should specifically thank Dr. Manoj. To the audience, I should tell, before he is stepping up to the airport, he had a cardiogenic shock patient at Chennai and stabilized and came here, of course, without MCS. Now the session is handed over to Anantaraman. Slight change in the program, Anantaraman. You can invite Dr. Julio to start his talk first because he is on time. Then subsequently we can move on as per your schedule.
Thank you, Shiva sir. Good morning to one and all. And firstly, sincere thanks to Dr. Sivakumar for putting together this 5D PCI Exotica. It is truly Exotica. The cases we have seen and also the discussions, everything has been excellent. Without further ado, I just will introduce my co-chairs. Dr. Aylan sir, who doesn't need much introduction, is one of the senior interventional cardiologists at Madras Medical Mission Hospital with enormous experience with all complex PCIs, including imaging. And to my right, I have Dr. Sundar, who is my co-colleague at Kaveri Hospital. And Dr. Manoj, Dr. Sundar, and myself, we have a fantastic teamwork together. Without them, we cannot do any of these complex PCIs or chip cases. So it's been a sort of boon for us. So without further ado, I invite Dr. Giulio to share his presentation. Again, Dr. Giulio doesn't need much introduction. He's from Bergamo, Italy. He's one of the leads for the image-guided PCIs in whole of the world, especially OCT-guided PCIs. He was the ex-president of European sort of Society for Cardiovascular Imaging. And I invite you, sir, to give the keynote lecture on the imaging. Thank you.
So thank you very much for the invitation. Can you see my slide?
Yes, sir.
Yes, sir.
Okay, so we are going to have a journey to the center of bifurcation that is not an easy task. Why that? So coronary bifurcation lesions are challenging and associated with a high risk of adverse events compared to non-bifurcation lesion. So two possibilities, one to stay simple, the other one to go more complex with a two-stent strategy. And we know that the more the decision is going toward complexity, the more you need to be accurate to try to reduce the events. Give me one example, simple, left main, Excel. Here you have the results comparing PCI and stents of last generation to the surgery. When you are dealing on the right side with the osteo and body of left main, absolutely in overlap, And when you are dealing with a distal left main bifurcation, still a big gap and very significant. So any type of bifurcation is more challenging in terms of requirements. Here are a few of key challenging anatomical procedural features that can be in favor of any use of imaging, including OCT in left main bifurcation. Ostium is difficult to be evaluated and is difficult to wire. Left main trifurcation is quite frequent. Potentially, you can go behind the stents with a guide wire, and then you might change, distort the stent, going under extension and malposition. Let's go one by one. Difficulty in evaluation of circ, ostium. Here one example where you are really in trouble to say what it is. This one is for sure, many of you will say that it's a tough stenosis on the ostium of the circ at the left main distal bifurcation. You can go in, you can take a look, you can see a nodular of a calcification that is never simple to be approached in a very large lumen. Don't touch, don't do it, anything if the physiology is negative. The second point is which type of information we can get at the bifurcation level, and of course, at the left main bifurcation that remain the most important for the patients. Well, multiple. You might have some idea about the involvement of the left main in terms of risky plaque. Here you have an example, when a thin fibrous kappa atheroma and ready to rupture. On the involvement of the plaque on opposite of the flow divider, and you can take precise measurements. You might have information about the carina and the ostium, and of course, you are going to assess the landing zone in terms of measurements. All this type of information can be obtained at each bifurcation. Simple, stay simple. So left main involvement, plan your strategy. The first point is, does left main be involved in this lesion or not? So that is an important question. So when you have intermediate lesion, you are going very quickly, one single pullback, and then you know if the left main is involved, which type of minimal area do you have at the left main, but in addition, you can understand if there is a huge calcium or not, how to prepare the lesion, and based upon the measurements that always are critical, decide which type of strategy apply. Once again, simple provisional stent. Here you have the sequence, then KBT, then POT, and then you are going again to assess the results. And the results can be assessed in many different ways, especially when you are challenged by the longest segment and multiple segment. Here, one example of multiple dual division of the extension of the left main in this site, and then the extension at the level of the distal part of the stent. So clearly, judging in a more objective way what you have done. And here you have a different vision of the patency of the circ ostium after the KBT and the integrity of the pot. Let's escalate in a little bit the situation and go into something that is different. Left main bifurcation 111, calcium. So you wanted to know how much calcium do you have? Where is calcium? How to prepare? Here you have phenomenal information. You can see the thickness of the calcium that IVUS never is able to provide. You can see the angle of the calcification. And in addition, you have multiple information, the minimum size that you have, the minimum size at the left main ostium, and also the big amount of the plaque. Here you can see the large discrepancy between the lumen and the EL proximally and distal in the side. bifurcation involved, as all the imaging are suggesting in this case, you needed to do 2 pullbacks. One was the previous one from the LAD, and then you go to the circ. And in the circ, you can see that there is some calcium, seam located deeply in the distal vessel. You are taking the measurements. In the past, we were taking manually the measurements of the EL and automatically the ones of the lumen, and then you are going proximally to see what do you have at the level of the ostium. Difficult to see because you have a very small lumen, and it seems that you have some calcification at this point. Could be calcification, could be lipid-rich plaque. Let's understand a little bit what and how we are interacting with actionable imaging. So here we saw before the thickness of the calcium, the minimum lumen. So let's go with a rotational atherectomy. And here you can see the effect of rotational atherectomy with the post-treatment assessment. The burr was 175 based upon the size of the lumen that was 169. And here you might see the longitudinal view where you can confront the results of the lumen before and the lumen after. And at this point you say, well, I'm still with a huge amount of calcium thickness, what to do? And then you decide to go with additional lesion preparation, with a captain, plus a non-compliant high pressure balloon, plus a DK crush. Despite the angiographic result, despite the fracture, that does not guarantee always the full expansion, you still have a very unexpanded stance. And that is something that is very difficult at this point to fix it. If you are flying to the vessel backward or forward view in the left main, you can see clearly the amount of calcium that is remaining at the level of the left main, giving you this under expansion, despite the fact that you have a fracture. And here the results from the circ, because if we are suggesting to do the pullbacks at the beginning, we are suggesting to do the same at the end of your implantation. And here you can see what was clarified. The ostium has this type of nodular calcification, so you are leaving apparently a perfect angiographic results, but with a suboptimal stent expansion at the level of the distal left main and at the level of the ostium. And this is the same patient at 6 months later. That is not so frequent to be catch by high quality imaging. And you can see what was happening at the ostium of the circ and also involving the distal left main. You have a huge neoatherosclerosis going ahead with involvement also a piece of the left main disease, the bifurcation. And if you are doing additional procedure, you needed to know the story. This was at the time of the original left main disease. This is when the patient had a recurrence. And once again, when you cannot optimize the results with imaging, this again the patient back with again a lot of neointimal and neoatherosclerosis. Sometimes OCT can be crucial to unravel stent tissue at the bifurcation. Which one? Patient coming back with a stent failure involving left main bifurcation. Once again, you needed to clarify the situation. It's quite easy after a minimal pre-deal, do a dual pullbacks in the both vessels and to know the causes. Here you may see somewhere there was some excess of neointima, but the setting was a strong underexpanded stents, especially confront with the size of the distal and the distal LFD and including the left main. You needed to do the same also in the parent vessel, in the side branch vessel, and you are discovering the same. So under expansion of the stent could be one of the causes of this stent failure. Another possibility to unravel the miss point of stenting is patients with AF lateral MI. Some years ago, he had bare metal stents to try at that time to avoid the increasing bleeding risk. You have a digesting bleeding, discharge of aspirin and anticoagulation. He had a continuous recurrent STEMI with apparently 2 mutes angio performed at a different hospital, and then he went back another time. And this is your angio. If you are very accurate, you can see that there is a minimum filling defect at this point, but it's not enough. This is what we had inside the lumen with a pullback from the LAD, and you can see what we had at the bifurcation level. Very accurate in this case. You needed to be very careful in trying to get into the diagonal branch, and you can see the accroachment of the struts plus the thrombus formation. Sometimes you are not understanding the situation. Another patient, STEMI, was fixed with a stent in the proximal LAD, but he had a multivessel disease, was a callback for a staged procedure on the CIRC. He went back for a staged procedure at the CIRC. He had 2 months, apparently beautiful results on the LAD, nothing to do, and then still the lesion on the CIRC, and then tried to get into the CIRC. Impossible. Huge problems with a balloon. And then we tried to get one pullback from the LAD, and here is the situation. Incredible protrusion back of the proximal margin of the stent, inviting the ostium of the CIRC. So based upon this imaging, we decide where to cross with the wire, to go with a small balloon, and then to finalize the procedure with a V-stenting. Here you can see the procedure and then the final results, both in terms of cross-sectional visualization with the number 8 appearance at the level of the bifurcation, and the clear changing in a 3D assessment between before and after the procedure. Of course, there is a growing evidence for some techniques that is more demanding. 2 stents, likewise a DK crash. You can just limited to use the imaging for assessing the results. Here the usual procedure, the 2 stents, then KBT, then POT. You can limit at the end of the procedure to assess the expansion of the stent. This is on the LAD distally to the bifurcation, identified by the pink point and divided in 2 halves. And here you might have the same for the proximal to the bifurcation with a perfect expansion. And here is the type of information if you wanted to limit the use of imaging only to the end. You can see different type of a view. This is a DK crash, as you can see in cross-sectional view. This is fly through with the evidence of the bifurcation and the full apposition of the struts. Here you can identify the lengths of the protruding part of the branch that was a crash. But OCT may escalate in use to guide highly complex bifurcation, not just to limit to the end of the judgment. This is one of the cases of Illumin 4. We run complex bifurcation, LADD1, 2 important vessel aneurysm in between. Of course, in this case, if you want not to risk too much, gentle pre-deal 2.0 to be sure. After wiring, that was not so easy to keep the vessel patent, then quick pullback to know what. type of plaque. Do we have calcium or not? Aneurysm, which type of size do you have? And which type of landing zone do we have in terms of sizing? At that time, we were manually using the research of the EL. Same done with a pullback from the diagonal branch. Here you can see the catheter, and here you can see the focus, especially on the aneurysm, to know something about the dimension and to have a look to the plaque. So no calcium, you know the dimension, and then normally you are doing this way, normally. This is a different time. Here you can see what we have new. This is Ultreon that is telling you where the calcium is and if there is no calcium. At this point, you started to see some minimal calcification at this segment before the lesion, but is lesser than 180 degree, is not highly significant in terms of a global thickness, and you can move segment by segment to know if there is a calcium, and in this case is displayed in orange on the top, on the overlay of the vessel, and how much is the calcium. So a confirmation that calcium was not a part of the lesion, and it was reassuring. Here you have a second point, the possibility to have automatically calculated in the white line the EEL is important, it does not matter. Here you can see that when you don't have visible the EL, like at this point, you have only the lumen depicted. When you have instead visible the EL, you have both lumen and EL automatically displayed. This is no marginal in decision-making when you are working at a high complex level. Here you might see the freeze frame of this LAD. Here you may see the freeze frame collected from Ultreon based upon the diagonal assessment. Then the usual procedure, DK crash, I wanted to skip very quickly, positioning, ballooning, and then again, final kissing balloon, and then a final pot, and then you check. And in this case, the results seem beautiful in terms of bifurcation. When you are going into details by using imaging, you started to see that the carina is no neutral, and it is dramatically displayed toward the diagonal branch. You can see from different perspectives. Here is the 3D reconstruction fly-through from the LAD showing the protrusion of the carina toward the diagonal branch. Here is the pullback from the diagonal branch showing the protrusion of the carina. So you are going back again, repeat KBT, repeat pot to optimize the results. This was the original lesion. This is the final of these Illumin 4 cases. It's not so infrequent to have a highly distorted stance plus malposition in DK crash. The beautiful angiographic results does not guarantee a perfect result. Here another case, you can see the level of distortion and the malposition in this DK crash with this apparently nice results of the left main. What to do? Once again, you need to rewire in the proper position and then additional KBT and pot, and then you can reshape at least at the best you can the dramatic deformation of this stent without any significant change in angio. The angio looks always great and beautiful. No easy to have a clear vision on how to recross and where to recross. Depends if you have a carina with a link free type, or if the link is going on the top of the carina, so many different things. I wanted to finish with one message about escalating difficulty. This is a dual CTO plus a DK crash in bifurcation. So LAD occluded after the origin of the first diagonal. You can see collateral from the same left circulation and also from the right coronary artery. So this is the procedure. Microcatheter, then first cross of this CTO, and then when you reopen the vessel, you are seeing much better the CTO of the second diagonal branch. So going into, in this case, with a Gaia wire, and then you have these two vessels, the LAD and the diagonal reopen. Now we are starting the interesting part, because the point is, when should I assess with imaging? If you are reestablish the flow, but is TIMI2, and if you have a collateral from the parent vessel, here is the type of imaging that you can get. Very difficult to be judged in terms of culprit lesion, because the blood is not fully reestablished, and then you have collaterals coming back. So that is not a good option. This is with a full predilation, as you can see, TIMI3 flow, you can do much better. So the secret is don't go in rush to assess immediately the vessel when you reestablish the patency. Try to reestablish a full TIMI3, and then you can see much better. You can see much better what? The culprit plaque, no calcium, so you can go ahead very quickly, and then you can assess also the distal segment, where to land. Why is important? Sizing. Why that? Because immediately after the culprit CTO, you have a small vessel. If you are watching a little bit more distally, you have a much bigger vessel. Then you can size correctly and do your procedure. And this is the results that you might achieve with a neutral carina, great evidence of what can be obtained in terms also of a stent expansion. Very important, Dr. G, where are the data? The data are fixed. Why they are fixed? This is October. There are 1,200 patients randomized 1-to-1 with a complex bifurcation and the side branch more than 2.5, and the need for rewiring and stent during the treatment, randomized to OCT guidance versus standard guidance. Which endpoint? A surrogate? Not at all. Primary endpoint, 2 years. MACE for superiority. Very complex trials with a lot of time spent in defining the type of approach and clarify to the investigator where, and here you have some example, where we are. Few weeks ago, the trial was finished in terms of enrollment. So I'm ending my presentation here to say that this is going to be an incredible source of information for the future of imaging in bifurcation, and especially for OCT imaging in bifurcation. So I think that I can conclude here my presentation, and I'm open to your question if you have it.
Thank you, sir.
Thank you,
That
sir,
was
for
an
that
excellent summary of the complex lesions. Image, prepare, image again, stent, image, optimize. So that is the protocol, and that's what most of the people follow. And you've shown exceptional cases of why it's important in each stage. It's just not the imaging before, or it's just not the imaging afterwards. At each stage, it makes a huge sort of decision-making in terms of getting the best outcomes. Now, these patients, obviously 2 different patients. One you have already answered, the CTO, the case you showed, because most of the times we kind of have limitations and sort of fear of using the OCT in those cases. But you have clearly showed that unless you have crossed, unless you pre-dilated, unless flow is there, OCT is not going to help. And the second thing is the renal failure patients. How do you do in your center for the renal failure patients? You do it with half contrast, you do it with saline, because your images are exceptionally good. How do you do it?
Okay. I was advising in the same way a few years ago because I know the technology. There is technology coming that can acquire in 1 second the pullback. So it's not a matter, it's a laser problem. It's not a matter with the technology, it's the matter now. But the possibility to scan very quickly the vessel in the same high resolution is solving the problem, because it's likewise to have a shot, a single angiographic shot. At the present time, I'm always recommended, if you have a severe renal failure, why not to go with a different imaging technique, likewise IVUS. I think IVUS can be suitable, is already demonstrated for zero contrast. But don't say that OCT will never be back with this story of the contrast in a renal failure, because it's a technical issue. If I wanted to use at any cost OCT in renal failure, number one, try to avoid to do 5 or 6 injections before starting. So you need to plan your procedure. You can fix on your screen the images of a referral. You can try to get into the lesion with the wire without injecting the contrast, having parallel screen to be oriented, and then try to do the minimum possible. Is a saline solution the final solution? It could be sometime. Sometime is disappointing. It's not so easy to predict a high quality of result. So it's in your hands, is your balance, but this is our position.
Thank you, sir. Sundar, sir?
That was a very excellent presentation. And I want to ask only one question: how you, when you encounter an ostial LMC lesion, if you really want to go with the OCT, or if you prefer IVUS here in this scenario?
When you have an
LMC, ostial LMC, left main.
Well,
ostial left main.
Left main. So let me say this one. If you have a super fan of the ostial left main and you wanted to see the ostial left main because it's important, you can go with, there are multiple demonstrations with a guideline for seeing the ostium, because you can clearly see, I'm sorry, I didn't have this slide with me in my presentation. Normally, the more than 3/4 of the lesion involving the left main are involved in the bifurcation, 78 in the XL. So the vast majority of left main is involving the distal part and can be nicely, and the body can be nicely approached by OCT. Can be do ostial left main by using OCT. We did some also in India at the Apollo hospital. I do not remember the city, but in this case, you needed to have this type of tricks for approaching. Otherwise, again, could be IVUS, but OCT is suitable with these small tricks.
Dr. Julio,
thank you, sir. Now, the Madurai Hub, Keshavamurthy sir is there and my colleagues are there. Any comments or questions? Sir?
Yes, Anantaraman, this is Shiva. Dr. Julio, you showed some cases of under-expansion. Even in our live case, we had relative under-expansion in one particular area, which of course it was debatable. So by nature, OCT being high resolution with lesser penetration compared against IVUS, there are certain areas like plaque burden. The IVUS proponents say the plaque burden is not exactly assessed by OCT. Another is positive remodeling. Again, cannot be got better by OCT. What is your points against in these scenarios compared against IVUS versus OCT? Plaque burden and positive remodeling.
Easy. IVUS was using, and it's using single cross section. talking about positive and negative remodeling where at the tightest point. We are not using because we are using longitudinal view with reference and automatic detection of the normal zone. So you are not based upon the single frame where you have the maximum amount of plaque burden, but you are based on the reference. One very important point. Sometimes the plaque burden can be relevant also for assessing a perfect result, because you might have the lumen, you might have achieved the lumen, but you might have achieved the lumen in a more large vessel due to the plaque burden. Is this important? We do not yet. We think that that is a matter of debate, but OCT is approaching a different way this story. We are based upon the reference area and not only on the cross-section.
Perfect. I think Anandaraman, we can move on. Thank Dr. Julio. We can move on to the further proceedings of the Chennai Hub, please. Thanks, Dr. Julio. That was a fantastic deliberation from you. We all enjoyed your lecture. Thanks for joining us today, sir.
Thank you very much for hosting me. Thank you.
Thank you, sir. Now I have with us now Dr. Aylan, sir. Again, as I said, it doesn't need any introduction, and they were part of the Illumin 3 and 4 core lab as well. So from the OCT side, they are the best centers in the world. Now, sir will be speaking about a high bleeding risk, and he will give a keynote lecture. Please, sir.
Thank you. Good morning, respected Chairperson Dr. Anandaraman and my co-speaker Dr. Sundar. At the outset, I would like to thank Dr. Sivakumar for inviting me to this 5D PCI Exotica, and it has been true to its name. The conference has been really exotic. I'll be talking for the next 10 minutes on managing high bleeding risk patients. If these patients, how to identify these HBR patients, and if they are going to PCI, what should we do? Now, who are high bleeding risk patients? If the age of the patient is more than 75 years, if he has comorbidities like renal disease, liver disease, or active cancer, if his lab shows anemia and low platelet count, if patient is having stroke, ICH, or AV malformation, if he has a bleeding diathesis or a prior bleeding or transfusion, and if the patient is on oral anticoagulation, NSAIDs or steroids, and if he requires a planned surgery on DAPT, or if he has a recent trauma or surgery on DAPT. These are patients who are at high bleeding risk. Now, what percentage of patients in our practice are HBR patients? 80% are normal bleeding risk. 20% of the patients will have high bleeding risk, and it is important we identify this 20% of patients so that they do not land up with complications. Now, we know post-PCI, we usually give dual antiplatelet therapy. Cyclooxygenase inhibitor, aspirin is standard. Along with that, we give one of the P2Y12 inhibitors, which could be clopidogrel, prasugrel, or ticagrelor. Now, choosing one of these three is the operator's discretion, but you have to choose it according to the need of the patient. Usually, we give this DAPT if it is a bare metal stent for 1 month, if it is a drug-eluting stent for 6 months, and if it is a ACS setup, we give for 12 months. But this is not standard. If you look at the bleeding rates in DAPT trials, these are the various DAPT trials, and the incidence varies from 0.3 to 2.8%. But unfortunately, if you see, the bleeding has been measured by different criteria, like for example, the bark bleeding, TIMI major or minor bleeding, gastro bleeding, etc. And high bleeding risk patients have been excluded or underrepresented in this trial. So if you see the true incidence, it should be much higher. And the scores available to assess bleeding risk are the following 6 scores. So different trials use different criteria to define bleeding and different scores to assess the bleeding. So you need a uniform consensus. And that is why the Academic Research Consortium defined high bleeding risk. They said that identification is of major importance to ensure appropriate treatment, but due to lack of standardization in defining this population, it limits the trial design, data interpretation, and clinical decision making. So 31 experts from Europe, USA, Japan, and South Korea had 2 meetings in Washington and Paris, and then they formulated this high bleeding risk criteria. So how do you define this bark bleeding? You have 5 types. Type 1 is not actionable bleeding. That is some minor like ecchymosis or some skin discoloration for which you don't take any treatment at all. And type 5 is fatal bleeding. Patient dies because of that bleeding. Type 2 is bleeding where you require to go to the hospital, you need to do some investigation or you even need to take treatment, but it is not significant bleeding. So it is the type 3 to 4, 5 which are important or serious bleedings. In type 3, you have a hemoglobin drop of 3 to 5 grams. 3B, it is more than 5 grams. And type 3C is intracranial hemorrhage or intraocular bleed. And type 4 is related to CFG bleeding. So this is how now we classify high bleeding, and it is only the 3 to 5 which is considered serious. So according to HBR criteria, if you have BARC 3 or 5 bleeding risk of more than 4% or a risk of intracranial hemorrhage of more than 1% within 1 year after PCI, then you called it as a high bleeding risk patient. And this they have divided into major and minor. If the BARC 3 or 4 risk is more than 4% and ICH more than 1%, it is major. If it is less than 4% or less than 1%, it is considered as minor criteria. If you have 1 major criteria or 2 minor criteria, then the patient is at high bleeding risk. Now going with the characteristics with which we define high bleeding risk, age more than 75, it is considered as a minor criteria. Renal disease, if the EGFR is less than 30, it is major, less than 60, it is minor criteria. Cirrhosis with portal hypertension in liver disease is considered major. Active cancer within 12 months is considered major. Anemia, if it is hemoglobin less than 11 grams, it is minor criteria. If it is less than 13 in males and less than 12 in females, it is considered as a minor criteria. Low platelet count below 1 lakhs is major. Similarly, if you have prior spontaneous ICH, known AV malformation, traumatic ICH less than 12 months, moderate or severe ischemic stroke of less than 6 months, then it is considered as a major. And if any other prior ischemic stroke, it is a minor. Bleeding diathesis, chronic clinically significant bleeding diathesis is considered as major. And spontaneous bleeding plus hospital and transfusion less than 6 months or at any time if recurrent is considered major. Same 6 to 12 months is not is considered as minor. If you are on oral anticoagulations long term after PCI, it's a major risk. If you are on NSAIDs and steroids in chronic use after PCI, it is a minor criteria. And planned surgery on DAPT or recent trauma or surgery is considered as a major criteria. So now how do you manage these high bleeding risk patients? One is during a PCI, you have to choose the right access. We know that when you go by radial route, you can cut down the miss and bleeding complications. Then choosing the right stent, choosing the right duration of DAPT, and choosing the right choice of antiplatelets. All this needs to be taken care of in a patient with high bleeding risk. Now what do we look in stent? The things that we have to look are thickness of the stent. We know thinner studs are better than thicker studs in reducing mist. The type of polymer, the durability of the biodegradable polymer. You can have durable polymers and biodegradable polymers. Then you have coating of the polymer which can be conformal or abluminal. Then you have polymers which get absorbed in within 3 months or which might take even 2 years. And we know polymers, if they stay long, can cause stent thrombosis and very late stent thrombosis. And the type of drug used. So far, except for strut thickness, we don't have concrete evidence that any of these factors reduces risk in high bleeding risk patient. But still, you have to choose the stent with the lowest, thinnest strut and the one where the polymer gets absorbed fast. Now, do you have evidence for giving only 1 month or 3 months of DAPT? Yes, you have with this following stents evidence. For example, the Synergy stent has a 0-month DAPT trial, the asset. It has 1 month trial, the senior Poem and Synvius, and the 3-month DAPT, Evolve Short DAPT, 4-month DAPT, Ideal Left Main. With Resolute, for 1 month DAPT, you have Onyx 1 and Onyx 1 Clear. And for Zynes, you have the Zynes 28, Zynes 28 USA and the Stop DAPT trials. And for 3-month DAPT, you have the Stop DAPT 2 and Zynes 90. So in a patient with high bleeding risk, you are justified in using one of these 3 stents since they have evidence to show that you can use them for only 1 month after a stenting. Now coming to antiplatelet regime DAPT, previously we were giving standard DAPT for 12 months, but now you have shorter DAPTs where you give for 1 month, 3 months or 6 months, and you have prolonged DAPT where you give for 24 months and 36 months. That is not in high bleeding risk patients who have increased ischemia. Now we have come to know that the bleeding risk and ischemic risk differs. The ischemic risk comes down in a day and then within 30 days it stops. After that it is the same throughout. But whereas if you look at your bleeding risk, it increases and then comes down. Beyond at 1 to 12 months, there is a persistent ischemic risk, but excess bleeding risk. So this tells us that beyond 1 month, continuing DAPT in a high bleeding risk patient is not necessary or it will cause harm. And if you look at the this prospective study involving 14,963 patients, the brown ones are the patients who are high bleeding risk patients and the blue ones are patients with low bleeding risk. Now, if you have low bleeding risk, whether it is non-complex or complex, there was no long DAPT was better. But whereas in high bleeding risk, whether it was non-complex or complex, shorter DAPT was better. So based on the ischemic risk and bleeding risk, you decide as to how many months of DAPT you have to give. So any patient undergoing PCI, immediately at the PCI, you do a precise DAPT score. If the precise DAPT score is more than 25, give a short DAPT. After 1 year, if there is no bleeding, then calculate a DAPT score. And if the score is less than 2, then stop DAPT. So these are the various trials which have shown that a short-term DAPT is better. Now coming to the antiplatelet agent, we think that clopidogrel does not cause more bleeding. Ticagrelor and prasugrel cause more bleeding. But now you have evidences with the ticagrelor. This is the twilight complex where complex PCI patients were given ticagrelor for 3 months and then single antiplatelet was given ticagrelor. And again the TICO trial in ACS setup. All this showed that you can give ticagrelor. If you see among patients who underwent complex PCI, as defined by a combination of high-risk angiographic and procedural features, a regime of ticagrelor monotherapy after an initial 3 months of DAPT with ticagrelor plus aspirin was associated with lower clinically related BARC 3 and 5 bleeding. Thank you.
Thank you, sir. Thank you for that wonderful summary of how to deal with these high bleeding risk patients. Sundar, sir, any questions, any comments?
Regarding choosing an antiplatelets, so a lot of other criteria such as the length of the stent and the type of the lesion, and also if it is going to be an acute myocardial infarction or a stable coronary artery disease. If these are all the other factors which will play in a major role in choosing the DAPT. So how do you consider these factors comparing to the stent studs or other indications?
I mean, the twilight complex sub-study of the twilight trial showed that in patients who are considered complex, that is the stent length more than 55-60 millimeters, involving more than 3 stents, multi-vessel PCI, bifurcations, CTOs. In all this setup, they have tried ticagrelor. And definitely in complex PCIs, you want a more powerful antiplatelet agent. Now in high bleeding risk patient, we are worried that ticagrelor can cause more bleeding. But that trial has clearly shown that in those patients, even giving ticagrelor for 3 months is enough. It did not increase the ischemic risk. And beyond that, continuing ticagrelor alone, single antiplatelet also did not lead to any increased ischemic risk. So I think in those kind of subsets where you have done a complex PCI, it is better to give ticagrelor than giving weaker antiplatelet like clopidogrel.
Thank you very much, sir, for that excellent presentation. It's always nice to listen to you. And what is your strategy for people, octogenarians who undergo PCI in relation to the DAPT therapy actually? What is your strategy? And second one is, what is your antiplatelet strategy for a patient who is undergoing non-cardiac surgery, who has undergone the complex or a chip PCIs actually?
Yeah, thank you, Farooq, for the questions. Nice to see you. Regarding the first question, elderly patient after a PCI, if he is more than 75, then he comes under a high bleeding risk patient. But it is only a minor criteria. In addition, if he has other criteria also satisfying, like if he has another one more minor criteria, then we will consider him as a high bleeding risk patient. So definitely, I would prefer to give him Ticagrelor plus aspirin for the first 3 months, and then continue Ticagrelor alone for the remaining 6 months, if it is a non-ACS setup, and for 1 year if it is a ACS setup. After that, I would prefer to switch over to clopidogrel.
Sir, many.
And what was the second set you asked?
The second question is when patient undergoing non-cardiac surgery who has undergone the complex chip PCI who having a high thrombotic risk, what is your antiplatelet plan?
Yeah, how to stop the DAPT for the surgery. Yeah, I mean, I would be only if the surgery is very urgent and required, only then within 1 month I'll agree for that. But if it is not an urgent surgery, we should try to postpone it for at least 1 month. In a patient, if we had anticipated before, we would have used stents where 1 month of DAPT is enough. So after that, you can stop the one antiplatelet agent. The other antiplatelet agent also you can stop just 1 or 2 days before the surgery, and then take him up for surgery. So instead of stopping for 5 days, I would prefer 3 to 5 days of stopping the dual antiplatelet. Keep him on one antiplatelet. If the surgery bleeding is controllable, you can even send him for surgery on a single antiplatelet.
Sir, unfortunately, we cannot follow most of these trials for our patients because most of the patients with high bleeding risk also have high ischemic risk, like elderly frail male with calcified coronaries with low hemoglobin. He has got high ischemic risk for recurrent MACE also. Also, he is at a high risk for bleeding also. So these trials, obviously, they exclude, if they want to prove the low bleeding risk, they will exclude all these patients. So from the literature, we have very positive data that the trial, the population with both increased bleeding risk and increased ischemic risk are not adequately represented.
Yeah, that's what I showed in my second slide itself, that most of these patients have excluded high bleeding risk patients. The incidence of bleeding which I showed in the various trials, most of them did not incorporate or include high bleeding risk patients. So similarly, as you said, in the real world scenario, it is different. You patients are always with high bleeding risk and high ischemic risk, then it is difficult to manage. Theoretically, they tell us that if the patient has high ischemic risk or high bleeding risk, you choose your treatment. But when there is both, how do you go about? We don't have any concern.
Dr. Anantharaman, I think we can move on, Anantharaman, because it is tightly packed. None other than Elilan can do a better job than this. He is always very astute clinician. Thank you, Dr. Elilan. Please, Anantharaman, go ahead.
Thank you. Thank you.
Thank you.
Thank you, sir. And may I invite Dr. Selvagnesh, who is my close friend from Madurai Velammal Hospital. He is one of the senior most cardiologists there. And his topic is case-based learnings from real-world coronaries. May I invite Dr. Selvagnesh?
Good afternoon, everyone. Respected chairperson and dear colleagues, I'm happy to share interesting challenges which we commonly come across in the real-world scenarios. This is my first patient, who is 74 years old, male, diabetic and hypertensive, presented 3 years before with a history of unstable angina. This was his coronary angiography. You can see the right coronary angiogram was diffusely diseased vessel and which was being tackled with DES implantation, and we could see the middle picture which is showing the post-stenting angiography, which is giving appealing result. But within 2 years he presented with a unstable angina. Again, we can appreciate a significant amount of instant restenosis in the proximal part as well as in the middle of the RCA. Similarly, this is left coronary angiography. Here too we can see the left coronary, there is a significant tight lesion in the mid-ALD without any angiographically appreciable calcium here, which has been dealt with drug-eluting stent. This is the final angiographic picture during the index procedure. You can compare this. Unfortunately, the LAD system also has a significant ISR after 2 years. Here, intravascular imaging was done to evaluate the underlying mechanism. This is the intravascular imaging. After the ISR, we could appreciate a significant amount of calcium here with neoatherosclerosis as the responsible factor for the instant restenosis. So where did I miss? Instant restenosis within 2 years, probably in this patient due to underexpansion of the stent due to underlying calcium which has not been dealt properly. During index procedure, imaging was not done and the stent might not have been properly optimized. So now we have to deal this in-stent restenosis. Actually, for the LAD, since the calcium was significant by intravascular imaging, we need to take intravascular lithotripsy to crack the calcium behind the stent state. Then we did a disc implantation. For the right coronary artery, we got a great challenge to cannulate the right coronary coaxially because the ostium of the right coronary artery is well deep into the coronary sinus, and that has been modified by the previous procedure and ostial stenting. So what we thought is we could wire through the proximal stud and crush the proximal edge of the stent and exclude it away. Then we have to plan the stenting. Similarly, we decided to deal the distal ISR with a distal ISR with a OPN balloon. Then finally, we treated with a drug-eluting balloon. So this patient had a difficult cannulation after the previous procedure. So finally, this is the end result of dealing with the in-stent restenosis. This one is the left coronary system. Yes, what are the learning points from this patient? See, in-stent restenosis has a multitude of risk factors starting from the patient-related factors like genetic factors as well as procedure-related factors, then the stent-related factors, of which the procedure-related factors can be modifiable, especially if we do a imaging that will guide us about the characteristics of the lesion. According to that, we can select our toolkits and we can optimize the stent properly. So the optimization could have prevented the in-stent restenosis in this patient. But one important point is never take the stent without adequate lesion preparation, because sometimes even OPN balloon, high pressure OPN balloon may not give adequate expansion after putting the stent without proper preparation. Then the patient number 2, he is a 79 years old male with history of unstable angina, history of COPD on inhalational therapy. And he had a recent hospitalization for a COPD exacerbation with his PCO2 was around 59. And this is his coronary angiography. We could see the left dominant system here, and the LAD is significantly diseased and minimal calcium. The LAD lesion was tackled with the rotablation, and stenting was done in the LAD system. And the circumflex, we could see a significant disease, which is a bifurcation type of disease involving the major circ as well as the OM branch. We wired the middle part of the OM, and we could see a significant OM branch. So we decided to go ahead with a bifurcation type of stenting, that is true bifurcation. So we decided a double stent strategy. Accordingly, we stented the OM branch. We could see the OM branch has been stented distally. Then we decided to go for the major circumflex. The major circumflex was not yielding with a 2.5 NC balloon. So we thought of taking a score flex. We took a score flex balloon 2.75 and dilated, and this is what the result we could get after dilating with the score flex balloon. Here we can see the significant amount of type C dissection involving the major circumflex. So, and the patient becomes symptomatic, having an angina. So we decided to take the drug-eluting stent, and that has been taken and implanted in the main circumflex distally, following which we completed the procedure with a bifurcation type stenting step crest, and the final kissing balloon was done. Obviously, after stenting, we could appreciate there was a leak at the level of the circumflex in the distal part of the stent. So we thought of a balloon occlusion technique. We decided to occlude with a NC balloon, and echocardiography was showing a minimal amount of pericardial effusion without any hemodynamic compromise. But despite after NC balloon inflation, patient was having a leak. Hence, we decided to take the cover stent. But initially, cover stent was not able to be tracked down easily, so we have taken a guidezilla support. In the guidezilla, we had a difficulty in tracking the graft master in the proximal edge of the guidezilla. Then later, with the balloon anchoring technique, we have deep-throated the guidezilla into the stent. Then with the slight manipulation, we could able to track the cover stent down, and we have deployed the cover stent in the distal part of the circumflex, and we could see the cover stent is deployed here, and finally we could achieve the good result. This is the final result we could get. This is the final result. We can appreciate the better result in the LCX after the complete bifurcation. So we can compare the pre-procedural angio as well as the post-procedural angio here. So the other side of optimizing, the complications like perforation and dissections are inevitable. So be prepared with the toolkits like a cover stent and tackle such a complication at appropriate time. Now the patient number 3. He is a diabetic hypertensive smoker with a history of 3 episodes of syncope and he denies history of palpitation. Neurological workup was not significant, and hence we decided to go for a coronary angiogram. Here we find here the significant right coronary calcium with tortuous vessel, and the LAD also calcified. Initially LAD was dealt, and we are decided to tackle the right coronary artery, which is having a significant calcium. We could appreciate in the angiographically itself. In the tortuosity at the origin of this place, we could see the significant amount of calcium. So how to handle this patient? Initially we need a rotablation, but the problem is the high tortuosity. How do we track the rotablator catheter down? Initially we dilated the distal lesion with 1.25 balloon. Then we decided to tack the rotablation. The rotablation catheter was not able to be tracked down, so we have taken a guide cell as support to pass the rotablator catheter down. And the rotablator catheter was passed down with a great difficulty. This is a second run, so which is easily passing down after polishing with the first run. The first run was not recorded properly here. And after doing the rotablation with the guide cell support down, then we have taken the stent. After that, the stent was able to be tracked down and deployed. Here we could see the stent is tracking down very smoothly with the guide cell support. We deployed the distally, then proximally another stent was taken, and that was also deployed well. So we could see the final result here. We can compare the final result with the previous angiography. Yeah. So this is a before stenting and after stenting comparison. The tortuous angled calcium handled with rotablation, then final result. This is our final patient. Patient number 4, 75 years old male with inferior wall MI, lies with a retroplace, presented with a complete heart block for pharmaco-invasive approach. With this case, I will stop. I request a chairperson for giving extra 2 minutes for me. And this is the left system, which seems to be normal. And the right system, total occluded right coronary artery in the proximal part. So initially we have taken a 2 balloon which is dilated the proximal part, but which is not crossing beyond the mid part. So we have taken a 1.25 balloon then and dilated. Finally we have taken a score flux of 2.5 into 10. With that we have dilated with a very, we thought since the balloon has yielded very well, we thought we could track the stent down and we prepared the lesion properly, but we had a difficulty, hence we took a guide cell support. With the guide cell, we could track the stent down. After tracking the stent down, we contrast was staining, so we thought of taking little bit the guide cell out, but unfortunately the whole system came out, and with a slight manipulation we could able to hook the guide again, and stent was tracked down. And we deployed the stent and another stent in the proximal part. This is the final result we could achieve. So here the way to deliver the guide cell, the balloon assisted tracking is otherwise called as inchworming, is the better method because the razor effect could have been avoided by the balloon assisted tracking, so that unwanted dissections could be avoided. The learning points: the tortuosity, angle and calcium needs an upfront planning, like long sheath, an active support guide, an adequate plaque modification with the rotablation and cutting balloon or scoring balloon. The guide cell and guide linear will help us to cross the stent easily through the uncrossable lesions. Finally, the perseverance matters. To summarize, as we see more complication, we become more confident to deal with the complex lesions, and complexities are inevitable. And meticulous planning and perseverance will help us to challenge even a syntax score of more than 32, which sometimes we need to do also, because some patients elderly who are not fit for surgery, we need to tell them. So meticulous planning and perseverance will challenge the syntax 32 even. Never forget the femoral approach and long sheath and active support guide to handle such a complex diseases. And upfront imaging is mandatory that will guide us and save us from the unexpected calamities in between the procedures. And adequate preparation of the lesion with the available devices like rotablation, intravascular lithotripsy, cutting and scoring balloon will help us. But never forget the other side of the coin. So we may need to deal with the dissection or perforation also with the appropriate devices like cover stent. And optimization will reduce the risk of ISR and future events. Thank you. I'm ready to take up the questions.
Yeah. There was.
Thank you, sir.
Yeah.
Can you hear?
Yes, Anandaraman. That was a fantastic presentation from Silva. Just I have a question. You've shown an RCA where the wiring was done through intrastud and omitted a portion of studs into the floating iota. So that of course, the reported cases are there, but that you should keep it as a last resort. You should not do it by intention. What you have to do is, if the first wire goes in that way, allow the wire to go in. Now, if you are taking a balloon through that wire, the balloon will not go because there is an impediment of strut because you have wired through. Now the guide will back out. When the guide backs out, try to put the another wire. The guide may back out in a way, it may face the stent. Coaxiality. This is my just suggestion. What Anandaraman feels, other people feels there. Of course, you can enlighten his other cases too.
Absolutely, sir. I think, as you said, we can try different guides, try to get coaxial, but if none of that works, then obviously what Selvagenesh sir said and done is acceptable. I think these are very difficult cases, complex cases, and as put in the summary slide, it is very, very important for meticulous preparation. We have got several aids in terms of imaging, in terms of delivering, in terms of getting result. But the most important thing I would say is before you start the procedure, make sure that you have bailout kit in your lab. You have the covered stent, you have coils, and you have more than that, a supportive colleague. If you're going to start a good complex case, make sure you have a supportive colleague, because when you run into a problem, you will be concentrating on one thing, and your colleague will be the one who will be bailing out. So it's very, very important in these cases, have a good supportive colleague to help you out in these cases. Hedlund, sir.
Yeah, I would agree with Dr. Sivakumar. I mean, we should try. Maybe after 20-30 minutes of trying, if you are not able to enter through the ostium of the vessel, then maybe the strategy, because that floating struts inside the aorta always poses a risk for thrombosis and MACE at a later event. All the cases were well done, and I congratulate you, Dr. Selvagenesh.
Anandaraman, we can invite Sundar to go ahead with this.
Yeah, so we'll go on to the next talk. Dr. Sundar is a young, aggressive, upcoming interventionist from Kaveri Hospital, and he has been doing great job in complex cases. And today he will talk to us for the next 10 minutes on chip case.
Sundar is also an innovator. Probably, I think most of our colleagues probably will be knowing or just starting to know. Sundar is an artist as well as innovator, and he's innovated several things which you will be hearing in the next few months, few years to come. So congratulations, sir.
Thank you, sir. Thank you so much for the nice introduction. I feel very happy to be here. And I thank Dr. Elilan, sir, who is for me, he is the encyclopedia of cardiology. And also I thank Dr. Anantaraman. He is more than a friend to me, and he has his advices and his approaches are very, very useful to me. And I also take some time to thank Dr. Sivakumar, who is the superhero of South India, and he's doing an excellent job. And thanks for inviting me to address this august audience. And my case is a chip case. I'll directly go to the case history. I'm very sorry for the image quality because I didn't have any time now today, because after proctoring for 2-3 days, I came today morning only, and then I took a video through the mobile phone, and I'm just uploading. I'm sorry for that. And here is the case. 86-year-old male and he had breathlessness for the past 1 week, and he had an exaggeration of his breathlessness symptoms for the past 2 days, and he became very symptomatic of class 4 dyspnea. For the past 3 hours before presentation, he initially presented to one more hospital, and where they stabilized him with oxygen and NIV, and then she shifted the patient to here. And he had angina too. He had 3 episodes of the angina in the past 1 week. And on arrival, his systolic BP was only 70, in spite of having 2 high anatropes. And ECG was showing evolved inferior volume. It's not an acute, it's an evolved inferior volume. And echo was showing a global hypokinesia and LVEF of 30% and with moderate MR. And he had a serum creatinine of 1, and output was around 35 ml per hour. His initial lactates were 2.4, heart rate was 112. Intermittent AF was going on the rhythm. And because my previous speakers and Dr. Anantharaman was insisting on the help of the colleagues here, and because it is going to be a chip scenario, and we need a very, very wonderful colleague, and I'm very lucky to have in Kaveri, because I always work, we always work as a team, Dr. Anantharaman and Manoj and Dr. KPS. Everybody work as a team here. So this is the initial scenario. So we initially we thought we'll go medically stabilize him, but because considering his age and frailty and all lot of other comorbids, he had diabetes, hypertension as well, and then the family was really particular in having an invasive approach, and then we wanted the patient to be saved at any cost. So after explaining all the details of all the complications, especially I detail more complication to them in this scenario, because I don't have this because I don't mind telling that, because we have to accept much of the defeats in this type of scenario, but we have to explain all those scenarios before going into the procedure. And I just put upfront IABP here because of his cardiogenic shock condition. I just wanted to see how the coronary anatomy is. So IABP was inserted through the left femoral artery approach. You can see here it is a very much calcified left main, very much calcified LAD. It is a diffuse disease. You can see some of the ectatic portion in the mid LAD, and following that it's a diffuse calcified lesion. And the circumflex was non-dominant here. And this is one more view, cranial view. You can see LV dysfunction in the LAD territory, and also much of calcified disease here. So we wanted to take the pulmonary artery pressure here, and the pulmonary artery pressures were very high in this patient, more than 48 mean. And also you can see this, because he presented initially with an evolved inferior volume, you can see 99% in the proximal RCA, and the PDA was occluded. So the lesion is, the culprit lesion is here only, the PDA got occluded. But there are a lot of other lesions also, but and patient was in cardiogenic shock. And I came out and I was talking to the patient attenders, and it is going to be very complex, and we need upfront MCS support, and also a lot of team effort here. And I was thinking of a lot of options, like whether I can stabilize him with by doing RCA first, and then take up the LAD, LMC and LAD in the next scenario after stabilizing him. That is also an option, and we discussed at the time. And I should thank Dr. Manoj here, and I was calling him, and then we discussed all the options of going ahead with Impala. So we explained everything about Impala to the patient attenders, and they had a huge discussion by the time we were stabilizing the patient, and then a lot of other doctors from other states, US, everybody involved, and we had a meeting, video meeting. And then finally they concluded, and we have to go ahead with the Impala, upfront Impala, and we're doing this complex case. So initially we wanted to address RCA first. RCA was not much of a problem. Upfront Impala was done, and Impala we took a CP, and it was implanted. It was a very easy approach, and the impella was placed, and we were monitoring the cardiac output. And with that support, we were did a wiring of the RCA. And, RCA was too much tortuous and calcified, and a lot of times the guide was coming out, and in spite of that, we dilated the lesion, and also we took an IVL of 2.5 here, and 2.5 into 12, and then IVL was done, and we were able to have a good access, and the IVL was 3 into 12, and then after doing the IVL, we did use a telescope to bring the stent inside, and that stent was deployed, and we had a good result in this. The RCA was optimized, and you can see still the PDA was little bit open, still the thrombus was there. And after doing the RCA, we had a good little bit improvement in his hemodynamics, and still the hemodynamics is in the borderline stage. And here also we had a discussion whether to address the left side or we have to come out and stabilize the patient. And we had a maybe I can say we had a biased opinion, and then because the impella was in, and we thought when the impella was in, and we can take a chance. And because the patient still had to improve more in the hemodynamic upfront. So with the impella, we thought we can address this left side, and again it was engaged, and then wiring was very difficult too, and the wire was not easily passing, and it had a tortuosity, calcium everywhere, and finally we were able to wire the LED, and the balloon was not going up, obviously. So balloon, the guiding was backing out, and the balloon was not entering. Even 0.8 millimeter balloon was not going inside. So again, the next choice will be the rota. So again, we thought the rota will be the only one option. We can go ahead through this type of calcium, and luckily we were able to pass the rota wire, and we were able to do the rota. So rota, we took a 1.25 bar, and initially we had a difficult in that critical portion, and finally the rota was going inside, and we were able to achieve a good lumen, and it was upgraded to 1.75. So rota bar was upgraded to 1.75 because I am not going to show all those things, because we had a balloon dilatation, and we took a IVUS, and we were not satisfied, and then we took a 1.75 bar, and then we were going inside. And after doing the bar and post dilating with the NC balloon, we were able to pass 2.75 into 33 lines inside, and we were able to deploy the stent in the mid LAD. So following that, I'm sorry, I'm repeating again. So again, this was the IVUS. This is the pre-IVUS. I'm sorry. I'm showing you these were all the critical lesion we wanted to. I just wanted to here. I wanted to show the critical lesion in the mid LAD part. So the constraint of time, I'm just passing, and we did use the IVL here with the 4 millimeter IVL from the left main to LAD, and we passed here. This is 4 into 40 millimeter Vivo ISR stent here. We deployed through the from LMCA to LED. So this so post dilated everything was done, and this was the final result we were able to achieve, and it was a fairly a good result, I can say, because all the branches were open, all the side branches were open, and we were very happy because the he was able to tolerate this procedure. Hemodynamics didn't deteriorate, and also we thought we can keep the impella here for some time. So I'll take, this is not going to be the end of the my speech, because the post impella scenario I wanted to discuss, and I'll just take 2 minutes to explain the scenario, how the patients reacted to this procedure. So once the patient procedure was over, he was shifted back to CCU, and he was stable, and we were able to step down the impella support from P8, P7, P5, P6, P5, everything.
And the patient was also doing good, and he was producing much good urine output, and his creatinine was only 0.7, and the lactates were coming down. It was almost 0.9. So, and after 12 hours, we had a problem of, we had a alarm in Impella, that is a suction alarm. So we thought it is going and hitting the LV myocardium, and that is why the suction alarm is coming. So we just pulled back the Impella, and we were able to maintain at P5. And finally, again, the same thing happened. The patient, the condition, after some initial brief improvement in his hemodynamics, and it was static, and then he started deteriorating. His lactates was going up, and the urine output was coming down. And his, it's like kind of an AKI, and his bowels were not moving, and SGOT, SGPT started rising. And also his hemoglobin was dropping. So we thought somewhere something is happening, or bleeding is happening. We did all the ultrasounds, and even the CT was done for him. And sorry, not CT done, only the ultrasound was done to rule out the extra retroperitoneal hematoma, and also to rule out any other hematomas. So we were not able to find out any bleeding sources, but his hemoglobin was dropping from initially from 11 to 7, and there were evidence of hemolysis. The hemolysis in the sense the LDH was very high, haptoglobin was very low, and the hematologist was confirming that it is an active hemolysis going on. And also the bowel movements are not going, the bowels were not moving, and we can expect all the other complication later and later. So he had an ischemic bowel. So finally we again the cycle started with all the problems, all the so we did use CRRT with the cytosorb, and we wanted to push out all the toxins. So we were thinking of the terms that it is an Impella-induced hemolysis, or it is going to be cholesterol emboli. What are the things? So to be on the other side, to be on the sad side here, and to be on the happier side in the other, the LV started moving very much. So from the initial less than 30% to now it is more than 40 to 45% the LV. But even without the Impella, because the Impella support we intermittently stopped. We wanted to stop the Impella for some time, and then we were able to check for some time, and then they were, and his BP was maintaining without the Impella support at that time. So here I wanted to press some of the points, but see, being we are going to do an Impella, it may give a false sense of confidence that everything can be done because the Impella is behind, like a God is behind us. So it is not so, because a lot of complications, because a lot of talks may be promoting this as a savior, but it is not going to be the same. So we had a problem like this, all the complications of the Impella, and also the other issues we have to, because of his comorbids, because of his age, and even the hemolysis is we just saw during this Impella, and all the complications further, like elevated liver enzymes, and all the bleeding things. And these are all the things I wanted to highlight in this case. Unfortunately, we lost this patient at by 5th day. So even though we just removed all the support, he was going, but because of the metabolic complications and the lactic acidosis, which was going high and high, and unfortunately we lost the patient at by 5th day. And let me conclude the talk, and I will be happy to answer some of the questions you can ask, and if I am knowing those answers with my little experience, I can answer that. Thank you so much.
Dr. Sundar, it was an excellent presentation. Did you look at LV EDP before Impella,
Yes.
during Impella, before RCA PCA, after RCA PCA, before left side PCA, and after left side PCA, LV EDP?
Yeah. we did measure the LVEDP pre-procedure, sir. Once the RCA was done, we didn't measure the LVEDP here, but we did the LVEDP pre-procedure. So the LVEDP was substantially high in this patient before the procedure, and then after doing the RCA, we were just seeing the pulmonary pressures there, and it was kind of reducing from 48 to 36 after some time after. I'm not going to say immediately after PCA of the RCA, but still some maybe 20 or 30 minutes later of RCA PCA. So we had improvement in the pulmonary pressures. We didn't check the LVEDP there after PCA.
I think, with the permission of Anantharaman, you want to say something? Shall we, before closing this particular chair in Madurai Hub, can you just sum up, Anantharaman?
Sure, sir. Sure. So, obviously, that's a fantastic case. And as you said, these are very high-risk patients, elderly patients, and this hemodynamic support device does have a downside because it is a 14 French. So, we do have to sort of keep that in mind. And bowel complications, bowel ischemia, as well as hemolysis is one of the things which has to be closely monitored. That's where we lose the patient. We will have a good heart, but in the end, it will end up with a problem like this. Otherwise, it is a very good supportive device. And where we decide whether we use ECMO or Impella, it's a difficult option. And obviously, the cost is a major issue for us in India. And majority of complex PCIs can be done as much as with ECMO as with Impella. But we have to have a good patient selection. It's been a fantastic session, sir, Shivakumar sir, and Erilan sir, final comments before. And also we are joined by Dr. Shivakumar sir, our pediatrician, and as well as the structural heart interventionalist, who will be here for the next session as well. Welcome, sir.
Yeah, warm welcome to Shiva from Madurai Hub, from all the people here. Thanks, Shiva, for joining us. I think the Chennai Hub is going to continue with us till as much they are available to us. Let me close the present chair and let me invite for the next session, where there is two keynote lectures by great people here, Dr. Harish on valve intervention and Dr. Pradap on CTO, who is the present NIC chairman too. And for this, there will be, in between the lectures, there will be cases by 11 boxes by Dr. Giridhar Muthu as well as Keshav Murthy. For this, I invite Dr. Veeramani, Dr. Shanmuga Sundaram, Dr. Adarsh Narayan, and Dr. Neelambujan to go to the dais and conduct the, invite Dr. Harish Mehta to give his lecture on valve intervention. And the Chennai Hub by the lead faculty, Dr. Anantharaman, along with Sundar, Elilan, and Shiva. Also, it's the right time that Shiva is here, there is valve intervention is happening. So I think the panel is great here.
Too high. Shall we go ahead?
Good afternoon. For this first topic, the learn from the master, valve interventions by recent experiences by Dr. Harish Mehta. Over to him, sir.
Yeah.
Thank you.
Thank you very much, Shiva. Thank you for having me here and giving me an opportunity to come to Madurai and see the Meenakshi temple and meeting Pratap and Selvamani sir. So my journey started in 2017. I trained with Giza Fontos and Peter Andrika at the Göttingen Institute in Hungary. And we were the first ones to get certification for independent center for TAVR in Mumbai. So this was the learning curve. I'm just going to run it, both the cases together. So we started with doing contralateral injections to locate the common femoral artery to puncture the artery. The very important aspect of TAVR, as you know, is that you have to puncture the femoral artery common, don't puncture superficial femoral. And the pigtail is placed in the NCC, and then this is how you load the valve. When you check the valve, this is the self-expanding Medtronic valve. You load it to see how it looks, and it's loaded properly before you start venturing to pre-dilate or something like that. And then in most patients in the beginning, we used to not pre-dilate the valves. And based on the marker, we had to put it 3 to 6 millimeters below the annular line. And The advantage of this valve was that you could retrieve the valve even after 80 to 90%. If you're unhappy with the position, you could just retrieve it. Like in this case, you realize we are too deep, so you can retrieve it completely and go back again. But if you see the other slide, we did a balloon pre-dilatation. So I put two separate to show that in some cases we do balloon pre-dilatation, especially if it's a very critical AS or if there is a bicuspid aortic valve. And then we again position the valve. And once you are happy with the position, you just quickly release the valve. As you say, we release the valve here. And then we are releasing the valve there. But if you see here, there is some PVL. And we post-dilated this to reduce the PVL. I'm not going to go into how to post-dilate and all that. And then finally, we close this femoral with ProGlide, and then the case is done. So I'm going to give you show you cases of different valves. So this is TAVR by Medtronic valve using a bicuspid valve. This is a lady, 89-year-old lady. This was my first TAVR in India when I came back. And as you know, we have a high population of bicuspid compared to normal population. We have 30 to 40% patients who are bicuspid. So we always take a shot in the non-coronary cusp and see what next you're going to do. In this patient also, we started deploying the valve as shown. And we always, up to this 1/3, the valve pressure is okay. Once you're happy with the position, you have to rapidly deploy to 2/3 because the pressure drops, because there is no cardiac output. Because the native valve is open and this valve has not started functioning. So you have to go rapidly up to 80% to deploy it. NCC, yes, NCC. And the purpose of pigtail is? To locate your annulus so that you can mark where you're going to start. But of course, if you're not sure, you should keep injecting little contrast. But if you have patients who have bad renal dysfunction, then you want to do without contrast. So that's why we always maintain that position. Now, if you see this valve, there's a narrowing in the center. So obviously, this valve is going to leak. So we know that. And when we check the aortogram, the valve is leaked. So we know that this patient will need post-dilatation. So we selected a post-dilatation balloon. And this is the end result. Now you will say there's some PVL still. The advantage of this valve is a Medtronic valve is a self-expanding valve. It keeps expanding over the next few hours. Now this lady is now 5 years down the line, 5 or 6 years down the line, and she has 0 PVL. So don't chase to perfection here. If you have a mild PVL, accept it and wait for another day and see. If the next day you still find that the PVL is bad, you can always go back, put another valve in, make a valve in valve. So don't chase mild PVLs. That's the game in these self-expanding valves. This is a very beautiful case, and this is the type 1 indication for all valve in valve. Failed bioprosthetic valve, the only treatment option should be TAVR, unless you're going to cause problems with TAVR, like coronary obstructions or a very small annulus, and you're going to make the annulus worse or make the patient prosthetic mismatch worse. Then you may opt for redo surgery. So what we go is, there's an app by Dr. Vinny Bapat, which tells us the size of the valve to be used based on the size of the valve implanted. And of course, you can measure the inner diameters. So we know the perimeter and inside. So we know which valve to use. Now, when you have small bioprosthetic valves implanted in the aortic position, especially in our country, you'll see all valves are between 18 to 20. Nobody implants more than 21. So that already makes the annulus small. So if you put a balloon expanding valve in such patients, you're going to leave the patient with a very high gradient and very high patient prosthetic mismatch, and also the risk of valve deterioration, structural deterioration if there is a high gradient. So in such patients, you always have to use a supraannular valve or a self-expanding valve. Now these are important views. These are the implanter views which you get on the base of CT. And this is the angle. That is the angle that the valve has to traverse to enter the LV. So these angles are important to decide how you're going to take your valve, which valve are you going to take down. And the most other important things to see is the femoral arteries. So we have to see the access has to be more than 5 for a self-expanding and more than 5.5 or 6 for balloon expanding. Now this lady had a low coronary. So if you see the poles and the coronaries are close by. So they measure something called VTC, valve to coronary distance. If it is less than 0.25, you definitely need to protect the coronaries or do a procedure where you tear the leaflet of the bioprosthetic valve called the basilica, or you protect your coronary when you deploy the valve. So we put the Jutkins in there, and then we took a shot. So we knew that we have to protect this coronary. You can see a stent there. You can see the stent there. So we kept a stent there. In case our coronary occludes, we will go and implant the stent into the left main. Then again, you have a very clear, because this was a 19 valve, we know it's a 23 Medtronic self-expanding valve will fit there. Then again, the same position, you start releasing your valve. And if you want accurate release, you start releasing under pacing. Earlier, we used to not release under pacing. Now we've started releasing under pacing, so the valve doesn't dive up and down. So it maintains that position. So if you see, the pacing has started here. Can you see the wire moving fast? And then we release the valve. And you can see the valve will open here. There you are. That's it. The valve is released. And once you do that, and we checked again with an aortogram, the coronaries are flowing well. You see that left coronary is flowing well. So we decided to pull the stent and wire out. We didn't deploy it. But if you watch this again, there was a PVL. There was a significant PVL there. You'll see that. See that? Now this you can't leave. So this valve needs post-dilatation. And of course you check the gradient also. If the gradient is still high, then this valve needs fracture. So these valves can be fractured with a non-compliant balloon. So that's the balloon we are putting in. We are positioning the balloon, and be very careful when you're using a big balloon. The balloon should be more towards the LV, so you don't destroy the leaflets, because the leaflets are attached higher. So your balloon should be more into the LV. Now see this. Zero PVL. The PVL is gone completely. So these are important.
When you were post-dilatation?
After post-dilatation, the balloon, the PVL went off.
No, the more into the LV.
Yes, especially in, see, depends if you use a big one. So each valve has a different waist. So the smaller valve has a waist of 20, then there is 22 waist, 23 waist, 24 waist. Suppose I'm going to use a big balloon. If you get it closer to the waist where the commissures are sutured, you can cause structural deterioration and tearing of leaflets. So in that, you have to try to put the balloon more towards the LV. Then my experience after self-expanding, I said, we need to do all the valves. So we started doing balloon expanding valves also. So this is a young 94-year-old male, extremely fit. He just said he wants to live for his wife who was 92 but was demented. He wanted to take care of her. So he said, do what you need to do, but I need this breathlessness to go. So he's a young 94-year-old. He had a gradient of 80 by 45. This is the 23S3, the Edward Sapien valve. It's a very, very sleek, very beautiful valve. So as a rule, in young patients with a small annulus, I don't put a 23 because it's going to give a higher gradient compared to self-expanding. But in the age of 94, that's good enough for him. And now you see this, after deploying, you deploy it at 80-20. So the marker just goes above the annulus, and when you inflate, the lower part of the valve foreshortens. The upper part never foreshortens. So this part which is in the LV foreshortens. So you have to place according to that, so that your valve will move into the annulus. Now again you see a PVL here. After that, we did a post-dilated with a ZMET 23 balloon. And now you see the PVL has disappeared. And that's the groin. Now for the groin, I just want to tell you that we've moved ahead now in life. We don't do any more of these. We do only Doppler guided punctures. We don't check shots, we don't do anything. We just keep the crossover to check the arteries after we close with ProGlide, so that whether there's any stenosis there which needs fixing. Then we moved further to valve in valve in TMVR. This is another 80 85-year-old male. He was a head of TCS in the past, and he had bioprosthetic valve Magna 27. Knowing the valve is very important, so you decide your next valve in that. And he had a CABG Lima to LED. And again, you see the perimeters, everything inside, because that again confirms that your valve was Magna properly. But sometimes he give you the wrong name or the wrong size. And the most important thing in a valve-in-valve mitral is your neo LVOT, because that can cause LVOT obstruction if you put a valve into the like this. But you can have maneuvers where you lacerate the valve, the bioprosthetic mitral valve, and then Gopal has said one case where you simultaneously balloon the LVOT and the mitral valve together so that the LVOT is not encroached. But we would prefer to have a good LVOT. Yeah, Kiba procedure. So before, we generally like the good LVOT, but his LVOT was really, really huge. The reason being, he was operated for MR valves. Most of our Indian valves are MS valves which are replaced. His valve replacement was MR degenerative. So we know the LV was big for him. So he was a much safer candidate. These are very important markers which tell us the septal positions and where we are going to puncture and how the valve is going to track. If you puncture too high, then your valve may not track down at all. And if you puncture too low, then you form an angle, again the valve will not cross. As we know in BMVs, if you puncture too low, you know the struggle you get into BMV. So the best part with TMVR is that puncture is now controlled because we do septal guided punctures. So we see the short axis, we see the cable, bi-cable views and 4-chamber, and decide the height also. This height is not important in TMVR, but it's very important when you're doing mitra clips or if you're doing appendage closures. So you have to change your heights and positions as per where your appendage is. So this was his mitral valve area 0.91. This is a bioprosthetic valve. He had a TR. And now this is where we are measuring his septum, where we are going to puncture, and we are also seeing the height on TE. And this is how we puncture. We go postero-inferior. So you go more away from the aorta and you go inferior towards the IVC. So this is how you see it. Now this patient had a very fascinating thing that despite the needle being there, a new needle we couldn't puncture. So then you can have radio frequency needles, but we didn't have it. We just used a cautery. You touch cautery to the end of the needle and the needle crosses into the LA. And this is how we get into the LA. And whenever we want to position the valve, we try to align the two posts together so that you know where your valve is sitting. And this is like a BM, we use the same wire. And this is the catheter across the interatrial septum. This has to be done under TE guidance. You can't do this procedure without TE because your septal puncture has to be accurate. Now this is the Agilis sheath which is rotated from outside. It can help you turn and twist so that your valve is crossed. So we keep trying. Sometimes direct pigtail goes, sometimes it doesn't go, sometimes you need a wire. But it takes a few seconds or maybe a minute or two, but if your puncture is good, it generally will cross. There's never been a case that we've not crossed as yet. I'll just show you. You can keep seeing how it goes. So then you again flex it a little bit more. Then it got caught in the frame. Then you reduce the flexion slightly, it went up. Again you flex it and rotate it a little bit more. I'm purposely keeping it so that you can see how it crosses and how you move your Agilis sheath. At one point it just goes across. You have to get more aligned to the valve. There you are, the pigtail walked in. Then you do a septal dilatation. Average septal dilatation, you need a 12 millimeter balloon, 10 to 12 millimeter. Smaller valves 10, bigger valves 12 to 14. You can see the septal dilatation there. We open the septum. That's very important because your valve has to cross. And this is also how it looks, the septal dilatation on the transesophageal echo. Then we dilate it again to be sure that everything is fine. Then is the 29 millimeter Edwards sapien valve, which is going across.
You will reverse the valve?
reverse the valve, very important. The valve has to be reversed in the mitral position. And even the rotation is different. In aortic, the Edwards looks up. In the mitral, the Edwards looks down. So your flexion changes. But it's a very sleek valve. I mean, it just goes across the septum like butter. If you've done a good septal dilation, it will just go across very easily. And then that is too deep, so we have to pull back. And as you see, we are aligning the poles. Because otherwise you will not be able to know because your valve will otherwise tilt and not deploy very well. Here the important thing is that you have to keep more of the valve into the ventricle and create a funnel so that it doesn't migrate further. So that's how it looks. You see that? That's the funnel you create. And this is the end-on view. Now see the echo. There was a very trivial PVL which disappeared. Now you see this. The valve is fully functioning, the new valve. My experience with Merrill Life Sciences, one of the best cases I've had, I was proctoring a case in Hyderabad. Some of you must have read it about Continental Hospital. So we started like we do. So it's the first case of the center. Yeah. As soon as I ballooned the valve, he had a very critical AS. He's been denying surgery for 5 years. So his gradient was some 140. His heart stopped beating. He just arrested immediately. And the CPR was going on. I was left with a choice to either let him die, and anyway we had opened the valve. So I said, let's put the valve blind. But I had no marker where my NCC is. And nothing was going at that time. He had torches, bad aorta, calcified, very difficult to get anything in. So what I did, I just managed to get a wire into the NCC. Can you see my small wire into the NCC? It's just a 3-5 wire into the NCC. And then you can see it on the right side. Can you see the wire in the NCC? The only advantage was that I don't have to pace him because he was anyways gone. And then we deployed and started CPR again. Today he's gone, he's already home, he's doing very well. Then the last valve, the Abbott valve. This is the new valve that's come into the market. The difference in this valve, it's a self-expanding valve, but it's a very sleek valve. So it can go into compromised femoral arteries. Of course, there's a chart for every valve, how do you use it. I'm not going into that. What is important that you need to know the annulus, you need to know the sinuses, which will accommodate what size of valve. I'm just done in a minute. We need to decide the LVOT and STJ, because where the valve will sit. See how bad her aorta is. Can you see that? And that time IVL was not available. This would be impossible for a balloon expanding to travel unless you do an IVL. And you see that on the left side, 4.5, 4.8 femorals. Will not take a self-expanding, will not take a Medtronic, will not take a... Then you have to have alternate access. But the problem with alternate access is that it's not class 1A indication. The best results are with transfemoral. Of course, we have an alternate access case which I didn't bring, but we've done subclavian and carotid both. So in this patient, we could not even put a pigtail on the side because the valve and the pigtail wouldn't go together. The aorta was so narrow. Again, this case also, we did. Can you see this? This is a valve which is going from the groin without a sheath. The only advantage is a very sleek valve. It just slipped across. And when you went down, there was no way you could take a pigtail down with it. There was no space only in the aorta. In the descending aorta, there was no space to take a pigtail. So again, we left a wire in the NCC. After pre-dilatation, we deployed a 23 millimeter portico, and you see the end result. No PVL, all fine, patient discharged. And this is the last valve, it will take me another 2 minutes. This was a lady, she was a resident of Kuwait, a very VIP there. She was traveled all over the country, all over different parts in Africa, everywhere for treatment because she had this recurrent ascites, pedal edema, she had bleeding tendencies, and she had intermittent AFib with old left hemiparesis. Everybody told her, you're gone, this is cirrhotic liver, we are end stage for you. And her echo was showing severe TR, moderate to severe MR, mild pulmonary hypertension, normal size RV, but the TR was torrential. And this was her ECG. And angio was showing this. The surgeon refused to touch her. We were re-evaluated the patient. We got her into India. She was there for a month. We re-evaluated her. This was what her echo showed. And we tried to stabilize her with hepatic congestion. Then we stabilized the patient and offered her this. We clearly told her this is a palliative therapy. We are not going to cure anything out of you. You will just get some more time to buy. So these are the valves. One is the IVC valve, is SVC valve. The IVC valve is a short skirt, so you don't occlude the hepatic vein. And there's a long skirt again in the superior vena cava. And then you do the valve dimensions. We won't go into details of that. So you need bilateral femoral venous access, both sides, left and right. And you also need a diagnostic right heart cath because it cannot be used in moderate to severe pH. It doesn't work. And you need a jugular access also to deploy the SVC valve, heparin as per ECT. So you locate that and you always put a pulmonary artery catheter here, so you know that your skirt has to be below that, so that you don't occlude any major veins. So that's how we deploy the valve there. There's no need to show that. Yeah, that's how the valve looks. Now you can see that it's allowing blood to go down, but it won't allow blood to go back. Then we deploy the IVC. This is the skirt here. So the skirt has to be over the hepatic vein. It should not occlude the hepatic vein. So keep a catheter in the hepatic vein. Deploy it. Hepatic vein is preserved. And then you inject in the RA and you see that no reflux into the SVC or the IVC. And now the beautiful slide you'll see is how the pressure changes. See, this was a TR which was continuing into the vena cava. And this is post-valve deployment. When you pull back, look at the pressure in the vena cava. Immediately went down. Her esophageal varices reversed. Her creat went from 1.7 to 0.6. OJD. Yeah, but this is palliative. If you have a new valves which are coming, which are going to replace the tricuspid valve, then I wouldn't do this. This is palliative. But till the time we have this, and we still don't have the triclip. If you had a triclip, you would have put a tricuspid clip rather than doing this. But she recovered beautifully. She has no ascites, LFT normal, hepatic transplant avoided. And I just spoke to her about a couple of weeks back. She's almost 3 years down the line. And surprisingly, she's still doing well, because the only concern with tric valve that everybody speaks about is that RA may keep dilating because you are not allowing the efflux into the veins for it to decompensate. But I don't know how they compensate. Probably the RV takes over and helps it to improve the cardiac output. So that was my last case. Thank you very much. Thank you, Shiva.
That was an excellent demonstration of an array of cases. I have a question, sir. Sure. So with a lot of developments coming up in the valve technology and the indications for TAVR becoming more liberal,
yes,
how do you foresee the long-term outcome of this procedure?
Okay. So data-wise, we have 5 years durability outcome in our TAVI valves. And in that, it has proved at 5 years to be superior to surgically implanted valves. So I think that we are looking, durability I don't think will be an issue. The only issue I see is that you have to select your younger cases properly. So any man who walks into your room, says 50, 55, don't just go and offer a TAVR to him. So you have to see the life expectancy. So if the expected life expectancy of a human is more than 20, then you should first offer him TAVR. But the important thing that we need to tell our surgical colleagues, that they have to enlarge the root. Because the smaller valve they put, then we end up putting valve in valve, which is again smaller, and we are going to expose them to patient prostatic mistake. So we need to have a conversation going with our surgeons. that I'm sending this patient, this looks like a small annulus, I would request you to put a bigger valve, do a root enlargement. I think that all surgeons should also get used to CT. So first time I went to Budapest, got the shock of my life because they told me to read the CT and I had no clue how to read the CT. Now I read our own CTs, we evaluate our own valve sizes. We don't rely only on the company, otherwise you have to rely on the company. And they say put 23, we used to go and put 23. And then we realized, in fact we did a case last week in, sorry give me 2 more minutes, at Hyderabad, and the company had advised a 24.5 my valve. So we went and evaluated and I said 24.5 will be too big for this. It looks to me 21.5. I mean that's a major difference in size. You can cause annular rupture. Suppose you have a quandary like this. What we did, we balloon sized the valve. So we occluded the aortic valve with a 20 mm balloon and injected contrast. And there was already good seal with no AR. So the rule is that put the next biggest size. So the next biggest size was 21.5. And we put 21.5 on that patient. He had a mean gradient of 4 and he had no PVL. So had I put 24.5, just listening to the executive of the company, I would have got a catastrophe. So we all cardiac surgeons, cardiologists, doing structural interventions have to start interpreting our CTs. We have to start interpreting everything ourselves. And once you're in that 65 and above age group, then definitely you can offer your patient TAVR. It's a type 1 indication. But again, you have to see the patient, like the coronary heights, what is the chance of the coronary occlusion, what is the chance of bicuspid getting you into trouble, or is the valve going to expand well, is there too much calcium? So all this you have to evaluate, because if you remember one thing, the coronary is very important because you're going to do a coronary occlusion on a patient who's 55, 60, he's got a huge life to remain. And we have the results of chimney. So you can put a stent and create a chimney into the aorta. So the results, we don't know what are the long-term results. What are the restenosis rates? How is he going to come back? So it's an evolving field, but we are there.
Excellent cases, Harish. Nice to see you there at the podium.
Hi, Dr. Shivakumar.
Hi. Fantastic cases. No, as you said, obviously now the technology has grown and it's become a day-to-day practice. TAVI has become a day-to-day practice. I think by next year you will have 6 different valves available in India. The most important thing is for operators to know how to assess and how to read the CT. It's very, very important. 90% of the procedure is done outside the lab. Only 10% is done inside the lab. So your CT evaluation, your CT assessment becomes very, very crucial in terms of the valve selection. And again, 90% of the cases can be done with any of these valves that you have shown. Only 10% needs specific sort of valve and specific indications depending on the anatomy and the other things. Otherwise, you can get a good result with 90% of the cases with any of these valves. Thank you. Relance.
Just one question for you. How do you close the now? Do you do it
vascular?
only with the ProGlide, or you use a ProGlide and an angiosync?
So we started
hybrid.
with 2 ProGlides. That's how we started our career. And then we realized that we Indians have a smaller femoral artery compared to where I trained. So now we moved to 1 ProGlide at 12 o'clock position. If it seals very well, I sometimes don't even put an angioseal. But if it bleeds, then I put an angioseal. So it's one ProGlide, 1 angioseal. So I would say 70% angioseal is required, 30% not required.
Thank you.
Dr. Harish, enjoyed your talk. I just wanted to know, when you do a transcatheter mitral valve replacement, how do you address the septal puncture in patients who have either significant TR or atrial fibrillation, who become a little blue when you take out the valve assembly and you are finding saturations of 91, 92?
Yeah. So if you have a large hole leaving behind, then you should close it and come. Use a device and close it and come. In this, he was a 94-year-old. I didn't want to unnecessarily do more. Actually, he was not a bad patient to close that device and come, because I don't think we'll ever cross the septum again. What is your view? Actually, good you brought that up. Which patients would you close the septum?
Yeah, if the SATs at the end of the procedure is 92, I always close, because if he is 92 on anesthesia, he will become 85 in room air.
Right.
And they will significantly suffer from breathlessness.
Yeah,
because
the
they were
outcomes are
never
very
used
poor.
to. Yeah, they were never used to hypoxia.
Right.
So they will become more breathless despite having a good functional mitral.
Right. Right. True. Thank you.
I think with the permission of Chennai Hub and the chair of the Madurai Hub, in between the two masters, let me invite the beast. Let me release the before April 14th, that is none other than Kashwa Murthy, to come up with Live in Box.
Good evening. I thank Dr. Shivakumar for giving me an opportunity. But he has sandwiched me between two legendary talks. That is the only thing. Anyhow, I try to do a little bit of justice. I am just presenting a case of coronary perforation, presenting as an atrial fibrillation, which is a bit rare. A 45-year-old man presented with the ACS to a neighboring benevolent facility, and he had a DVD, and LAD was 90%, L6 was 90%. They stented with Evermax stents, both LAD and LCX. He was discharged on day 3, and patient had a postural cough on discharge. 2 days later, he presented to the same facility with intractable cough and atrial fibrillation, and he was referred to electrophysiologist. He came to us in search of an electrophysiologist, and I was about to refer to Madurai Jayapandian as usual, but we did an echo, found that there is a collection behind left atrium. So in PCI was reviewed, the last shot was suspicious of grade type 2 coronary perforation in LCX after stenting, because patient had persistent AF with the ventricular rate is high, and intractable postural cough and hemodynamic deterioration, and hematoma-like thing in echo. So we thought we'll do an angiogram. There's a aneurysm of mid L6 at the distal edge stentage. Obviously, he didn't have fever, and we did all that workout fast. Later, the reports came like CRP was normal, POC, calcitonin were all normal. There was no infection. It was related to perforation. It was we wired with Fielder FC, and then we had 2 graft master stents. The size didn't matter because whatever we had, we are supposed to use it at a time, and because patient was deteriorating. So it was, I tried to do it with 1 graft master, so I put it in proximally, and but it didn't help. I did the inching technique. What I do when I have a perforation, I take a small balloon and inflate in various places, slowly pulling up, so that exact point of leak will come to know. Like in this case, there are multiple leaks, and another graft master was put, and we did post dilatation, but still because of there was some leak in the midpoint. By the time we could get another graft master from a neighboring hospital, another graft master was implanted in the middle, and finally the vessel was secured. This was a 6 months follow-up MRI, and it was going well. And now discussion. The Ellis modified Ellis classification of our coronary perforation. We have 4 types. Type 1 is bit of dissection. Type 2, there is less than 1 millimeter with myocardial blush, and type 3 we are all careful. When you see it's a gross perforation and pericardial effusion, you try to do something about it in the lab itself or in the day 1, but you will not miss it. But type 4 is a perforation inside the chambers, so nothing will happen. But type 2, we try to manage conservatively. This type 2 gives problems. Because type 3, you will see the effusion, you will be going on seeing echo for collection, and you will know that, and then you try to do something about it. But type 2, you try to manage conservatively, get into some problem. I am reviewing the literature. The perforation can present in various ways other than pericardial effusion. That is, one is coronary artery hematoma, and it can present as epicardial hematoma. It can present as pericardial hematoma, or IVS hematoma, like all CTO cases, it happens a bit high there. And our case, coronary aneurysm, which has happened in 5 days. So as pericardium surrounds the heart, we all assume that once perforation occurs, the collection will be there, and you tend to do echo every hour. You call your technician so that if at all anything you try to pick up. But it can present in atypical ways. In this patient also, he was telling me, whole night they were performing echo very frequently. Probably they tried to pick up this thing, but as there is no effusion, they assumed that it has sealed spontaneously. But the aneurysm has formed and compressing LA, producing atrial fibrillation on fifth day. So high degree of vigilance is warranted in case of type 2 perforation without pericardial effusion. So always it may not be a pericardial effusion tamponade. It can be something else also. So that's the part. Thank you.
Shan? Can somebody make a comment? Shan Mosundaram.
That was a nice case, sir. Just wanted to ask one doubt. So how many cases you have seen late onset pericardial effusion, probably after a week or so, presenting as a tamponade after PCI?
It happens. It happened on one of my cases. That was it is a pericardial reaction, maybe most of the time. I had one case of frank rupture, and he had hematoma, the pericardial collection. I would put a pigtail and was tapping. But on fifth day, I was there in the hospital for 1 week. On fourth day onwards, effusion became clear. It was blood has disappeared and serous fluid. So I was not able to. I didn't know how to manage it, but something stuck to me. It happens with surgeons. After surgery, after 3-4 days, they develop pericardial effusion, and then it's blew up because of pericardial reaction. So I have seen somebody giving 1 gram of methylprednisolone. So I did the same thing, and it recovered. It happens.
Yeah, I think Shiva will agree. In ASD device closure, there can be a pericardial effusion late because of the reaction to the nitinol.
Normal pericardial effusion also, even if your blood is withdrawn also, because sometimes you can have a serous collection, that is because of pericardial reaction also. Steroid may respond. But I just wanted to tell one point. When you do a pericardial in that stent graft, if the graft is not cleared by just normal pressure, you have to inflate with a balloon and keep it for 3 to 4 minutes. That again, you may avoid a third stent.
Yeah, in this case also, we did it. Actually, I don't remember what we inflated so that it slips. At that point, I myself forgot. I'll tell you.
That's it. Thank you, sir. Thank you very much for the.
Yeah, hi. No, one thing I want to talk about pericardial effusion is that people should remember, So we had a patient where we had a branch which perforated, and we coiled it. And we were very happy that patient stabilized, went out, and again he came back. It was the collateral that was bleeding. So you have to go beyond down distal to your perforation and close it. And in fact, put 1 coil into the perforation also. But otherwise, the collateral will make it bleed from down. So that is very important to know. That you go below that perforation if you're coiling the small vessel. But there you can't put a stent graft, it's a small vessel.
We had at least 2 cases where they presented with a tamponade after 15 days. We usually call for a review for 15 days, but with 10 days they had some tamponade effect, and I had to drain it.
Generally, it's a collateral.
The one which has happening within the same admission late in the IC is wire exit perforation. But this which we are discussing is, I think, reaction late, maybe antiplatelet downgrade. I think it's time to invite our Nick Chairman, Dr. Pratap. I think everybody walks in one direction, I walk in a different direction, and that's the right direction is his attitude. Let him invite and go ahead with this.
Actually, after the Harish talk and this talk has no relevance. I was telling the people there that Keshavamurthy, there is a role for C2 intervention, and people are hearing my talk for a long time now. It is nearly more than 12 years. The same talk
is our bread and butter. What I show is once in a while.
Once I'm telling C2 intervention, what is the big game in that? I'm showing two simple cases and how an image can help you. This is actually a C2 patient that has circumflex stenting done. You can just look at the angiogram. In the second frame, you have a lesion like this. You can see the wire is going down, but the angle, if you see, the line you draw, it is in the different line, and the wire is going in another direction. So I was thinking that whether if I push the wire, what will happen? So wire is pushing. The wire went down. I was in trouble because whether I went through a segment of normal segment, actually totally out of the vessel and then went inside. This is all I use, Corsair, Gaia second, all those tough wires. What to do? You just do an 1 point. No IVUS can be done because IVUS catheter will not go. Did a balloon dilatation of 1.5. Then I did an IVUS. I was actually showing the total lumen. It's a totally luminous. And there was actually, the angle made me confused that I am in the out of the lumen, but I put a stent and then finished it off. There are a lot of stents and balloons, final IVUS. So this is actually a second case, very interesting case. Anterior MI in 2007, unstable angina, and not done intervention, advised cabbage. It's actually now it is, you can see a lesion is an ambiguous entry point. What I'm telling is, whenever there is a CTO, we just look at whether it is ambiguous or not. If it is an ambiguous entry point, good retrograde collaterals, attempted antegrade. These are the absolute 3 indications of retrograde. So what I saw that there is an ambiguous entry point. You have an excellent retrograde collaterals. So I thought about just going with the retrograde collaterals. First of all, I don't want to show that fine cross is taken. You can see the fine cross with the microcatheter up. Fine cross, you can see this is the fine cross, a tip injection done. I saw this connection is there. You can see the angle, a very tough angle. This is Suhotri wire. It can take any angle. Tortuous anatomy, Suhotri is a 0.3 gram. It is very simple wire. The wire going up, you can see the wire going up. The wire went in. Once the wire went in, I just pushed the wire down because there is an angulation there. So with that angulation, I just pushed the wire down. When the wire down, I trying to push the fine cross there because there is an angulation. Otherwise, it can rupture the collateral. So you should be careful. At the same time, the wire should not come out. See, the wire is coming out. So when the wire is coming out, you have another choice. You can go to the diagonal or some other vessel branch and then go inside. See, I'm trying to take another wire that is actually diagonal. So with the diagonal wire pushing, I can take the microcatheter up. So now the microcatheter is going up. You can see the angle is taken up. If the angle is not taken up, you have to take a septal dilatation and then go. So with this angle, the angle gone. Now the microcatheter is going up because the wire is actually, once the septal is taken with the angle is gone, then the microcatheter gone up. Once the microcatheter gone up, I taken the fine cross up. The wire is filled rep seat, cannot cross. Naturally, I have taken a stiffer wire to take, or you have to do a reverse cut. These are the two options. So I decided to take a stiffer wire. I took a Gaia second. You can see the Gaia second is actually out of the lumen. So once the wire is coming out, it is almost near to the LMCA. You should be careful that in this case you have to put a wire under the circumflex before doing anything. But the wire is totally out of the lumen. Once the wire is out of the lumen, what I decided is I took a guide liner. You can do a balloon trapping with a guide liner. With a guide liner, I could take the microcatheter inside. It's actually a guide liner assisted retrograde entry with a Gaia second wire. So now the wire, I have to push the fine cross down. Now I am taking the fine cross down into the PDA. Septal is taken out. Once the septal is taken out, I took a balloon 1.5 millimeter. along with the RG3. Told my colleagues at the same time, I took an IVUS because to understand the vessel, two things, vessel size, stent length, and how many stents. So actually, then I was thinking, I took a 2 millimeter balloon. The 2 millimeter balloon was not coming down. There was a difficulty in taking the balloon down. It's a 2 into 12 mH balloon. It is not an ox balloon. It is a new balloon. Yes. Then when the balloon is not coming out after the IVUS catheter, there is only one thing. It can be subintimal. And subintimal is how much length? I just checked it. This is a subintimal part. So I'm totally out of the lumen. So I was actually thinking that the vessel is distally in the lumen, proximally in the true lumen, but in between it was totally in the false lumen. Once in the false lumen, what are the problems of this case? When I put a stent there, I will lose the major septal. Once the major septal is gone, what is the fun in doing this LAD C2 intervention? So I have to preserve that LAD. So how to preserve that LAD? So this is the point. So I just kept the balloon. I'm taking injection. The wire should go like this. So actually the wire should go like this. This is the way. So for what I did is, by subintimal stenting, the proximal LAD, we lose the major septal. But it is no meaning in that. The only way to put the wire is antegrade, keeping the retrograde wire as the marker wire. So I decided to do the keeping the, how do you keep? I took another wire. A wire is kept into the first septal artery, pushing the fine cross beyond the first septal artery. Then I take the fine cross distally, and there's no other wire cross except the congress fluid 12. One, the congress fluid 12 wire, because I know that this segment is totally luminal. The next is actually easy. I was done again. Totally true luminal. Balloon dilatation. Tried to cross the diagonal by retrograde again, but I just lost that diagonal. That was the loss in this case. 2.5, but I did not lose the LAD. I was done. Measured the size. LMC was 4 millimeters. LAD was 3.5. The length was 16. Distal lumen size was 3. That was the final result. Stent 3.5 into LAD proximal. I was confirmed. Contrast was 360 ml. 11 gray radiation. Fluoro time was 80 minutes. So this actually, the two cases I just showed, the one antegrade, I was helped in one way because I just wanted to think that it was in a different lumen. And the second case was a complication. I would have, if I lost the septal artery, the patient would have lost the muscles. These are the only things. So there is an importance in CTO. There are two absolute indications of imaging in interventions. One is CTO, second is LMC. Thank you.
How do you do this? Yeah? How do you do these? You should have shown the one with that zero contrast.
No, this is not zero contrast. I have done only one zero contrast in retrograde CTO. Probably that is the only case after Lombardi done in the world.
I have a question for you.
This case?
No, any case. Suppose you would have dissected the subintimal you saw. Suppose you had gone across the circumflex subintimal and then entered left main into true lumen. Then what would have been your strategy?
Ideally, you should actually keep the wire into the circumflex before doing anything. That is number one. You should preserve the LMCA number two. And the third thing is actually, whenever you have a problem like this, you should, people actually will think that, okay, my wire has gone out, so I am in the true lumen. That is a wrong concept. You may be in the proximal part of the LMCA or proximal part of the RCA. There are 2-3 retrograde C2 interventions. I stopped. By seeing that, the wire can come out of the right coronary artery through the aorta, pierce into the catheter. I have demonstrated one case like that. Then I decided that I should not do that. And I stopped it. Because rather than that, I created totally subintimal length from the out of the lumen totally. You can create that. These are all possible. So whenever you do all these things, I'm just telling only one point. We should be careful that, and we should understand that the proximal part, minimum in the intimal part. And here, why I did this case is a different case, because in any LAD intervention, the major septal should be preserved.
Disturb the nature as little as possible, particularly in the
Yeah. So the reason I asked you this, So as a rule, would you say if you're handling ostial or proximal LED, should you have an IVUS always so that you know what's
No,
happening?
you should keep a wire into the septal artery, and if you can take the retrograde wire into the circumflex artery, okay, no problem. And if your wire is going to everywhere, it is not a problem. Here there was a problem in this case. I was having a real difficulty in taking the retrograde wire. I was actually taking the retrograde wire into the guide liner. So it's a guide liner assisted C2 intervention.
If you have gone all the way to the LM subintimally,
No,
obviously your
LM
L6
I did not go.
I'm just asking. By default, you have gone. And you have,
Then
how
I
will you rescue the LCX?
Then I will put a wire into the circumflex, then I will put an LMCA to suck stent and finish. I will not do the CTO there. LED CTO I will not.
So you will not proceed further, stop. That's why you
Stop.
said I will keep a wire in the LCX before all this.
You have to put a LMCA to suck stent. Tomorrow, if you want, you can do a wire again and recross and then come. I have done actually retrograde CTO. If the PDA PLV is occluded, I put a wire to the PD and cross it, and the PLV I come antegrade by a crusade catheter. You can do that. These are all possible. You can do a pull-out later.
Yeah, excellent, Pratap sir, as usual. I think you are master of CTO. And, but today you said that it should be a class 1 indication for imaging in CTO, like probably in such cases. And that's what you meant, isn't it?
No, actually there are two situations where you preferably to do imaging is actually CTO and LMCA, because LMCA has proven with the data. CTO is actually, if you just imagine all the Japanese without imaging, they don't proceed with that.
And
they will do it.
And ISR.
ISR is definitely, that is actually.
I think we can involve with the Chennai hub also. Dr. Anandaraman.
Thank you. Any question? Okay. Shiva is there.
Fantastic,
Shiva will
Pratap,
not
sir.
ask questions.
One thing I'll tell Pratap, the way you talk, it is so soft like as if it's a deer. But the balloons, wires, they roar like a lion. So there is a difference between your voice tone and the way the catheters move. So that I used to admire for the past many years.
Shiva, you have stolen the show.
Always he stole, he steals the show.
I think.
Fantastic, sir. Excellent.
Yes, Anand.
Fantastic case, Pratap, sir. And as you said, the CTO is a completely different beast compared to the other coronary interventions we do. So it's very important that if in the initial stages, at least you have good support with expertise to do these cases, rather than just trying and then having a very difficult situation which cannot be salvaged. So there are a lot of interested people who are starting to do CTOs. So this message is that it's very important. Sometimes it will look very easy. Sometimes it is not an easy thing. As Sarah showed clearly that every step is important, especially in the retrograde. And every step you have to take care. Very nice demonstration, sir.
Please join for NIC meeting 16, 17, 18 in Ahmedabad. This time in person. There is no virtual program like Shiva and Salomani doing. Only in-person program, 17, 18, 19. It is coronary, non-coronary, coronary. There are two people came before me, where the scientific committee people, one fellow will be dealing with innovation, that is Krishamurthy. The valvular thing will be done by Harish. The person sitting there in the Chennai, that is Dr. Shiva, is doing with the congenital and all. Please come and join. And CTO, I will have a CTO bonanza on 6-7 August in Delhi. Again, IJCTO coming up this year, in person only.
Fantastic. Good luck to all your endeavors coming up. In between, after the two masters and the beast in between, let me invite Giridhar Muthu, the young cardiologist from a three-tier city, very energetic, very astute clinician. Let's all listen to him.
Yeah, good afternoon and all. So today we are going to see an interesting case of right coronary artery. Thanks to Dr. Shivakumar sir, and thanks for this wonderful conference and giving me this opportunity. Is it audible, sir? Yeah. Yeah, I don't want sound actually. I just. So as you can see this angiogram, it's a 70-year-old female. 1 month ago she had chest pain, inferior wall MI. She came after 3 days. Coronary angiogram has been done. She is a known diabetic. As you can see, the left side, LAD has a borderline disease and LCX has CTO. So you can see this RCA, this is a very much tortuous with extreme angulation, and there is a 95% stenosis in the mid RCA with so much of calcium. So our region of interest is RCA. We thought of leaving the LCX CTO because of bridging collateral, and there was a good flow. So you can see the CTO, the RCA, the extreme tortuosity. So we went ahead doing an RCA, PTCA. So radial route was avoided because she has a radial artery loop. Initially angiogram was done through ulnar approach. So we took a femoral route. So we initially went through femoral route. We took a JR 3.5 catheter. In view of extreme tortuosity, we thought of taking a cyan blue wire. There was no problem in wiring the RCA with cyan blue. Cyan blue just went like that. Then we took a 2O balloon to pre-dilatation. There was difficulty in pre-dilatation in crossing the balloon across the mid RCA. So we are not able to track the balloon across the lesion. We tried, we took another BMW wire as a buddy wire, but still we are not able to cross the balloon across the lesion. And every time when we try to push the wire, the guide got disengaged. When you are able to like deep throat the guide, there was dampening of blood pressures was noted. As you can see, the BMW wire, we are not able to cross it across the lesion, so that was abandoned. Then we thought of taking a guide liner. As you can see, when you're able to push the balloon, the guide got disengaged. So as you can see, there is a guide liner. With the help of the guide liner, we took a 2O balloon. We pushed across the lesion, pre-dilated. The entire RCA was pre-dilated till the distal RCA. Yes, sir. We took 2.75 26 ohmic stent to deliver in the distal RCA, but again there was difficulty in tracking the stent across the distal RCA. As you can see, there was difficulty even in taking a ohmic stent, even with the help of a guide liner. We took one more 2O balloon, N balloon, went with aggressive post-dilatation in the distal part. Yeah, as you can see, we have done again aggressive post-dilatation across the distal RCA. Still we are having problems. As you can see, there was a chunk of calcium here. Then by God's grace and Sukumar sir's magic, the stent has went across the distal RCA. It was deployed. We took another 348 stent for the proximal to distal RCA, but we are not able to cover the entire RCA. Still, there was some amount of unstented segment between the distal stent and proximal stent. We was trying to push the 348 stent near the stented segment, but we were not able to do that. Since we have crossed the lesion, so we thought of deploying the stent from proximal to distal RCA. We left the ostium because ostium is disease-free. Yes. So once the 348 stent was deployed, there was a good amount of flow. Then we tried to, like between the unstented segments, we tried to took one more stent, 2.75 into 18, but we are not able to cross it again through the stented segment. So we took a 3.5 balloon. We post-dilated it, the proximal stented segment. Then we took a 2.75 into 18 stent. We managed to cross the stent across the unstented segment, and we have stented it between the two stents. This was a post-dilatation with 3.5 balloon. Yeah, this was the 2.75 into 18 stent between the two stented segments. This was the post-dilation again. So this was the final result. Yeah. So the problem we encountered here is the tortuosity and calcium. We usually have problems when we have tortuosity in wiring the lesion. We usually have problems in getting the support, wiring, and taking the stent, a balloon across the lesion. So we encountered all these problems because of tortuosity and calcium. So for wiring, we took cyan blue without any help of microcatheter. We are able to cross it. Then with the help of guideliner plus, we are able to track the balloon across the lesion. Then always in case of tortuosity and calcium, it is better to take a thin strut stent to deliver distally for better trackability. So we took a onyx stent in the distal areas for better trackability. Then we again have problems in taking the second and third stent. So we again aggressively post-dilated. We deliver the stent there. The take-home points are always be prepared when you're doing a tortuosity and calcium lesion. It is better to have a good support. In our case, we took a JR 3.5. It is better to take an AL1 whenever there is bad support. And it is better to take a microcatheter when you're having difficulty in wiring. We don't have much difficulty in wiring. And then the third thing is lesion preparation. It is better to take an angiosculpt or cutting balloon whenever you have difficulty in preparation. But with normal 2O balloon, we are able to prepare the lesion well. And this final result. And this is the final result, I hope. Thank you.
With the chair's permission, I'm asking.
Yes, sir.
Giridhar, actually, if you're having the same case now,
yes, sir.
What are the different way you will do now?
I'd have taken a AL1 catheter.
That is number one. So
Yes,
the
sir.
catheter change.
Yes, sir.
You'll
I'll have better support.
Better support catheter is the number one.
Yes,
number
sir.
two.
And then I would have taken a microcatheter for wiring it. And the third thing I would have done, taken an angiosculpt, a cutting balloon for better lesion preparation and to get rid of the calcium over
But
there.
angiosculp, if this wire is not going, balloon is not going, how do you take it?
Or Or for calcium, we can do a Rota or IVL or something like that, but in resource...
IVL will not go.
Yes, sir.
OPN balloon will not go. Normal balloon is not going, Howdy. Rota definitely is a choice. But actually, I'm just telling you, first of all, the catheter to be changed.
Yes, sir.
The catheter should be a stronger catheter. If the left side it's a EBU or a Amplatzer, the right side is Amplatzer.
Yes.
Second thing is wire. Wire means with the wire there are two things. One, you can have an anchor wire in the side branch, or if there is more support you require, you can take the buddy wire down.
Yes.
And the buddy wire should be a second wire, should be a stronger wire like Grand Slam and all.
Grand Slam, yes.
Then the third point is actually, if it is not again not good, you can take an anchor balloon technique. And anchor balloon, one important point is 1:1 is the ratio, 6 atmosphere is the maximum, otherwise you dissect the vessel. And the third point is actually, if you take a guide liner, you take the guide liner with the balloon down, dilate the balloon very well, push the guide liner down as distal as possible. Then you can take a device inside. You should not take the guide liner, keep in the proximal part. Guide liner should be across the lesion, then it will be very good. That was one point. And ultimately, you just, as you told, Rota may require in this. We were all telling in that calcium, you managed to produce a wonderful result, which most of the operators in India will have told that this is very good, like me and like Shiva, like people. Wonderful thing.
No, your teaching points was really excellent. It's a learning for everyone here. The guide catheter support.
How do you do that? Actually, I have done a case 4 days back. There was a real difficulty that what I did is, I took a wire down to the PD and PLV. You have a PDA wire, and PLV you take a wire.
Yes.
You have a distal anchoring. That will be much stronger. You can take a stent down. Distal anchoring is very good. And this case, even distal anchoring was not possible. What I did is, I dilated a balloon in the distal part, in the same RCA, and dilated and inflated, and then take another balloon down. So it is possible. Otherwise, another technique is, when you deflate the balloon, you push the stent down. This Japanese technique. You push the balloon stent down when you deflate the balloon. These are all techniques, but it is nicely demonstrated. He told you are a young person. Now itself you can teach us.
So,
thank you, sir. Thanks.
I'm going to give you 2 tips which are not in the book. It's a beautiful trick. You can try it. Put propofol on your stent. Put propofol on your balloon. It slips in.
Propofol, sir.
Just coat it with propofol.
Okay.
I've done it so many times.
Actually, how it works?
So many times. Lipid.
Okay, sir.
Simple. Cholesterol.
Okay.
It's a lubricant. I have used it for TAVI.
Okay,
To push the my valve which was not going through the sheath, I dipped the valve into the
Propofol.
No reaction, nothing happens.
That's a great
Nothing
point.
happens. So use.
You ask Shiva whether Shiva has to push the device like that.
Okay. And second tip, and we'll come to Shiva again. And the second tip is which we're writing it, which still coming. So if you have encounter, especially with a balloon, if you get stuck, what do you do in a tornus? You rotate, right? I rotate the balloon. Holding the wire, rotate the balloon.
Okay.
Fast, it goes down.
Goes.
Not always, 8 out of 10 it goes down. But remember to unrotate it.
Unrotate it.
Otherwise your wire will come out.
New York balloon. New York small balloon.
Yeah.
No, small balloon actually I
But,
was telling the poor man.
but only thing is, unrotate the balloon. If you don't unrotate the balloon, you'll pull the wire out.
And you inflate.
You try these 2 tips, then we'll speak again.
Try to rupture that balloon. I'm telling 1 millimeter balloon, try to rupture. There is no plastic.
Use the balloon as a tornus.
I think Shiva wanted to tell. Shiva, please.
No. I just wanted to add that this propofol helps even when, for example, you have a smaller vessel, whether it is a femoral artery or a femoral vein, and you have a large bore sheath.
Yes.
Coat the top of the sheath with some propofol. As Harish was mentioning, it's a colloidal preparation, so it smoothens, it lubricates.
Even in the sheath,
Coat the sheath on the
outside of the sheath.
Oh, outside the sheath. Okay.
Outside of if suppose the sheath is not entering the femoral vein and it is getting stuck, or femoral artery and it is getting stuck, you just coat it with, just pour a little bit of propofol on the top and coat it around.
It works. Not done for
Thank you,
rotawire.
But that tornus thing I have to do long.
Fantastic. With the permission of Shiva there in Chennai Hub, let me conclude the present chair. And let me invite the next chair, Dr. Selvamani, Dr. Sambat Kumar, Dr. Anandaraj from Tutukorin, and Dr. Anand from Dindikal to go to the podium to invite Dr. Kannan from Velamal to do the live case. And we have two giants here, the giant in congenital from Chennai, the giant in congenital in Madurai, Shiva and Kannan. The podium is all yours.
Sir, thanks, sir. Just a small housekeeping announcement. Request doctors to pick up their lunch from the lunch arena there. You can pick the lunch and then come and sit here, sir.
It was a pleasure to have you, Pradap. And we need your blessings and prayers for the evening case.
Hello, Kannan. Hi, Biaji.
Okay, so very good afternoon, everyone. And today, I think we really learned about the useful of propofol as a lubricant. Really, we did not know this, and that was a good point. Now, before I start the case, one small information, Shivakumar, I am still in Vadamalayan hospitals, not Velamal hospital.
Oh, sorry, extremely sorry. Please, Sambat, once again you can invite.
Yeah, no problem. No, there's confusion. Both are we, the confusion.
That's a confusion. Extremely sorry.
No problem. So I have Dr. Sasindra with me here and Dr. Satish here. I have Govindarajan, our chief CAL technologist, and also Jayanti as our chief nurse here to help me. And today we are going to demonstrate a case of VSD device closure. And can I request Sasindra to present, please?
Good afternoon to one and all. Today before going to the case, we want to just discuss about previous cases about device closure of VSD. So VSD, we very well know there are different types, and among which perimembranous and muscular VSDs are amenable for device closure. Next slide. As you can see very well, the different types, perimembranous, muscular, outlet and inlet VSD, different positions. Next slide, please. So this is one of our previous case. This is a left ventricular angiogram in iliocranial view of a perimembranous VSD, showing the significant shunt from the left to the right side. Next slide. So this case, you can see the ventricular septal device was being crossed with a JR catheter and a thermo wire. You can see the ventricular septal defect being crossed from the left side, and the wire is parked in the pulmonary artery. You can see the catheter course. JR catheter is in the aorta, and then into the wire is in the LV, and then crossing the VSD, and then into the pulmonary artery. And from the pulmonary artery, we have to snare the thermo wire and create an AV loop, arteriovenous loop, in order to facilitate the deployment of device from the venous side. Next slide, please. This is the arteriovenous loop. This is after snaring and introducing an exchange length wire. Next slide. So this is the sheath being introduced from the venous side, from the right ventricle into the aorta. So the AV loop creates a support for the sheath to pass through the VSD. Next slide. And this is a ADO, Amplatz duct occluder 1 device, which is asymmetrical. It has one bigger side disc which should towards the left ventricle, and we need to deploy it only from the venous side. Next
So
slide.
this is a aortic disc. The aortic disc is going to help us as the LV disc. And the other side, the PIN, is going to stay within the tricuspid valve or within the RV. Okay, next.
So here ADO1 is being deployed from the venous side, and the position of the device across the ventricular septal defect is confirmed by a sheath angiogram, which is done from the right side.
And more importantly by echo. Every step we will do some check angiograms and also by echo. After this point we would have removed the wire and done a check angiogram by the pigtail before we release the device. Next. See, this is after the releasing of the device. And one can appreciate that the defect was quite large. And this was probably 810 device, I believe. It was a large VSD and we closed successfully. This is a way how we can take close large defects through the venous side. Next.
This is another case of perimembranous VSD. It's a restrictive perimembranous VSD. Next slide. Again, pigtail angiogram showing iliocranial showing VSD, and VSD being crossed from the left side and parked in the pulmonary artery. And in this case, the catheter is tracked from the left side into the RV, and the device being deployed from the retrograde approach itself.
That
Next
is
slide.
the the guiding catheter which was in the aorta is being taken into the RV directly. Next.
And from the retrograde approach, we cannot deploy the ADO1 device. We have the ADO2 device where it is a symmetrical device available in only less than 6 mm site, less than or equal to 6 mm size, 4 mm, 5 mm or 6 mm. This will be thin and it could be taken through a 5 French or a 6 French guiding catheter itself, which can be deployed from the arterial side. Next slide. So here in this case, we are deploying a ADO2 device from the arterial side.
And you may not be able to appreciate the device, but you can see a dot of the RV disc. Once the RV disc comes, we are pulling it across the VSD and then deploying the rest of the device, the middle part and the LV disc. Next.
Next.
And we are just confirming. Next. As I said, every time we will confirm with the echo. And here it seems to be a residual flow, which is not uncommon, but it generally goes off. Next time when you do the echo, there won't be any residual flow. Next.
So this is another VSD example done through using an ADO2 device from the retrograde approach. Next slide.
Next. Yes. And you can see the perfect sitting of the ADO2 device. Okay.
Next slide.
So basically, we wanted to give an idea to the audience how the VSD device closure is being done, because if the audience is not aware of these steps, further discussion will be only from between me, maybe Sambath and maybe Shivakumar or something. So I thought we will give an overview and you will be in a better shape to participate in the discussions. Now let us go to the current today's case. Yes.
So our patient is a 19-year-old lady who is thin built, and she is an antenatal patient of 5 months of pregnancy with a known heart disease since childhood. She was relatively asymptomatic but became mildly symptomatic after pregnancy, and parents waited for a spontaneous closure in the childhood. Now came with dyspnea on exertion for 15 days. Next slide. Her vitals are normal. She had a grade 3/6 pansystolic murmur in the parasternal area and no diastolic murmur. Next slide. This is her ECG.
Which is unremarkable.
Unremarkable.
Next.
Yes. This is a transthoracic echocardiogram, parasternal long axis view, where you can see the defect with the left to right shunt.
It's about 8 millimeter defect, partially closed by the septal tricuspidal defect or the tricuspidal apparatus, causing an aneurysm, and there is an opening at the tip of the aneurysm, and there is a restrictive component there.
And the aortic rim is quite small in this case. Next slide.
Next. Okay, this we have measured it, 6.4. Next.
It's a parasternal short axis view where you can see the defect between 10 and 11 o'clock position, confirming it to be perimembranous VSD.
Next
slide.
So the apical four-chamber view did not give a clear understanding. I mean, the window was not very good. So we resorted to doing a transesophageal echo. Next. So transesophageal echo gives a much more clarity that there is a kind of adhered or tricuspidal apparatus which will help us in holding the device, as you can see. Next. Okay, next. And as you can see that a kind of conical shaped defect coming up, and we can imagine where the device will sit and how it gives a much more clearer idea and much more confidence in taking the device inside. Next. Okay, this is the measurement there. Again, next. Okay, this is where we are, and we have already done the LV angiogram. I'll show you LV angiogram, and then I'll ask for the discussion from dear friend Shivakumar and others. How should we go? We should try a retrograde method through the aorta, or should we do the AV loop and do through the venous side? Can you show the LV angiogram, please?
Kannan, can I ask one question? In the echocardiography, what was the interventricular gradient between the LV and RV?
64, something like that.
She is currently pregnant with 5 months of amenorrhea.
Yes.
What will happen if we wait till she completes her delivery and then this situation is addressed, because it involves radiation? The pregnancy is associated with fall in the systemic vascular resistance, which will reduce the left-right shunt, and a restrictive ventricular septal defect with a normal pulmonary artery pressure may be successfully.
We can wait. Yeah, this is what was told. This is what I wrote in response when this lady came to me initially. I even spoke to the OBG, consultant. But you know, the kind of fear that has been given in the minds of the parents and the OBG, they are clearly told, unless you close it and come, we are not going to address. Either you close it and come, or we have to do MTP. They have been that strong. So it's as you have said, currently there is no strong indication. It's more of a mixed medical and social indication, social and medical indication. I strongly agree that as he has grown to 19 years with this kind of defects, he can go through the pregnancy without much of risk, and she could have come back again. But right now I tried hard but couldn't convince the parents and couldn't convince the OBG people, and hence we thought we'll take up and do the case.
While it is completely justified when there is a stenotic lesion which will not be tolerated with progressive increase in the cardiac output, conditions wherein lowering of systemic vascular resistance with advancing pregnancy is going to be favorable, in general we try to avoid. The small risk of this particular procedure is when we are instrumenting around the groin with catheters around the femoral vein and femoral artery. Sometimes it triggers abnormal uterine contractions and might predispose to some subtle, like events like premature uterine contractions. These are all some of the worries that we get when we deal with a pregnant
Yes, sir. Yes, Shivakumar, adukka ipdi romba bayamurtha kudadu.
Sorry.
Right. So what do you think? We should go by the antigrade. We will try antigrade technique now, having taken up. We have taken only one angiogram now, and our fluoro time right now is just 21 seconds, because we do the tapping method. We just tap and see like that, and we have taken this one angiogram. There seems to be a pouch, and our usual ADO2 technique should work, isn't it?
What is the
I suppose,
cream? What is the size of the aortic rim?
See, right now, just below the aorta, there is no specific rim number. But what you see as the pouch is created by the tricuspid valve apparatus. The tricuspid valve apparatus forming a pouch, and the opening is much below, at the lower end of the pouch. Our aim should be to deliver the middle component and the LV component within the pouch. Nothing to protrude into the LV or nothing to protrude. That's what our aim should be.
The apical conical portion, the apex, you want to place the
Exactly,
device there.
exactly. That's what. Okay. So now we have taken a 6 French JR guiding catheter, and I have attached a Y connector at the end, and we'll just try to cross the VSD. Yes, take it.
Yeah. Can I have a question?
Yes, please.
Dr. Kannan, this is Dr. Harish from Bombay.
Yes, sir.
Can you not do this without doing an LV gram and avoid a radiation with a cine? I mean, when you have an echo on board.
One angiogram is needed to give us an idea, sir, and to place our device. See, unless coronary angiogram, where you do have check angiograms and where you have anatomical landmarks and the coronary is relatively fixed situation, here at least we should know where is to deploy and where exactly this comes. And another thing regarding the radiation and pregnancy, in second trimester it is very well tolerated, and the alarming phenomena occurs in the first trimester. First trimester, if the radiation is harmful, the child gets aborted, or if the child doesn't get affected, remains normal. So in need, we have to use the radiation in pregnancy. It's not going to be that harmful. So we'll try to minimize our radiation and try to finish the case. But one angiogram is needed. Without this angiographic appearance in the mind, it would have been difficult for us to proceed and do the closure, sir. One second. Just stop. Okay, just
Going,
tap.
sir.
Tap. Tap. Yeah. Go in.
Going, sir.
Go in. Tap. Okay. Go in. Tap. Okay. Go in. Come up to the ascending aorta. Yes. Stop. Okay. Okay. So I have just entered the LV. Now I will try to cross the defect. Oh, sorry. Yeah, could you see that? I just could easily enter the RV. Could you see that?
Yes, yes.
Yes,
See
very well,
see
Kannan.
Yeah, the wire is just scratching the IVS, and when it comes to VST, it falls into the this one. I just simply pushed, and it's an RV apex. And I am going to track my catheter, and there is no need to take the catheter into the pulmonary artery and all. We need to just go into the RV. And when we go across the VST, slight clockwise rotation is needed so that it goes into the. Okay, that's it. That's it. Okay, take it out.
So since you are planning to place the device within that partial closed aneurysm, I think from the venous side closure device will be better, because you can pull it back and hold it at that apex and then deploy. If you
Either way, it is good,
if you
Sambat.
come from the artery, when you pull it back, will that second disc maybe across
we
the
have to push
ventricular
it in.
side?
Yeah, we have to push it in that time. In the sense, if the second disc doesn't enter into the pouch, we have to actually push it in. We'll see how it goes. We'll see how it goes. Okay. Now,
Sampath, one of the way that it can be done is connect the side arm of this guide catheter, to Hibost, to pressure. So as long as you are in the RV, you deploy only the RV disc. And when you pull it back till you start getting the LV pressures. And the moment you start seeing the LV pressures, then you deploy the second disc. Thereby you can cut off some of the radiations and...
Okay, same thing. I already connected to the pressures. And as you can see, can somebody show the pressures? It's showing us 36.
Suresh, parameters.
40, it's 40, okay?
Device.
Shiva, I am taking a 6mm device, 6.6 actually. Diameter chosen is, because we have chosen 6.4 and 6.7 was the measured sizes. I have chosen a 6mm device, okay? Somebody has to come and show the device here. Give me a 5 French sheet. நான் இங்கே எடுத்து வச்சிருந்தோம் இல்லையா ஆமாம் 6.6 அந்த 5 French sheet கொடுமா லோடரா
டேபிள் எப்படி கொண்டு வரணுமா லோட் பண்ணி எடுத்துட்டு வந்துரும்.
That's a 6 French guide, Kannan?
Yes. Even it goes through 5, but 6 is much more simpler. I mean, goes smoother. It's a 6 French guide.
10 minutes. 10 minutes.
And as you can see, it's a very kind of a very flimsy device, a very soft device. And I will pull it and show it to you. And you can see all the 3 components. Can you see all the 3 components here? There is no fabric inside. There is no fabric inside. That's why it can easily go through the even a 5 French sheet.
Kannan, one more thing about the echocardiogram. At some time when your colleague Sasinder was explaining, he was mentioning briefly 8mm, 8.5mm orifices. Is the narrowest part only 6 or is it likely to be larger?
That was the gap between the aorta and the IVS. Originally, the original size was that large, but that has been reduced by the our subalveolar apparatus. I mean our tricuspid apparatus. So I have taken the device inside now, and okay, we'll just take it in now. Come. So I have a 3-way here, and I'm just going to take it inside. So I'm going to follow what Shiva said, because generally by fluoro we'll do, and I'll also use the pressure technique and also the fluoro combined. And right now I am seeing the RV pressure. I am going to push the cable as much as possible, which I know that. Again, I just tap and see. It is not in the ascending aorta. Pushing some more, tapping, not in the ascending aorta. Yes. Yeah, now it is in the ascending aorta. Okay. Now, in fact, RV, save that please, save that. See, in fact, RV disc has been deployed by mistake, in the sense, RV disc has been deployed, and as we know, just below the diaphragm, it is exactly sitting the place where we expect the VST is. Now, I have to slowly withdraw the sheath and push the device. I am going to slowly withdraw not the sheath, this guiding catheter, and then deploy the device. save that. Now, how do you know that we are across the device? You can see that my device has come in an expanded way. It has not, see initially when I showed the device outside the body, all the three components were together. The middle component will not be seen generally. But here, if we have really deployed across the whole, all the three will be splayed out and we will see all the three components. That's what has happened here. Can you have the contrast? And I am going to give the contrast only under fluoro and save the fluoro. I am not going to give the full cine. There is no need for cine. And echo?
This step can be avoided by using an echo also.
Echo, okay. Echo, Satish, echo part.
Because it is a pregnant lady. Otherwise, we all would like to see beautiful pictures.
Apical 4 chamber and see how it is sitting and
Dr. Shiva, if the patient was not pregnant, you would have used a TE also?
Sampath, nowadays, let me tell you how we approach ventricular septal defects. The moment we have a very good delineation of the anatomy, presently in the last about 100 patients or so, what we follow is we take only venous access. We take a right coronary artery diagnostic catheter, 4 or 5 French depending on the patient's age. If the patient is young, it's 4 French, or if the patient is older, it's 5 French. Put it into the pulmonary artery, go to a fluoroscopic position of LAO 45, cranial 30, keep the tip of the right coronary artery catheter turned posteriorly and keep on dragging. We will first see the PA pressures, then the RV pressures, and as soon as the VSD is touching the VSD, you will start seeing LV pressure.
Okay.
At that particular moment, we advance a J termo angled 260 centimeter wire into the left ventricle and advance the right coronary catheter inside.
Go to short axis.
Over that right coronary artery catheter, if it is a smaller child, the same termo wire will act like the sheath for a 5 French coronary guide catheter, through which we will take the ADO2 device. If you feel that the patient needs a larger device, a 6 French Mullin sheath will be passed. And the whole procedure will be on transthoracic echocardiographic guidance with only venous access. This is what we follow. We are about to write a paper on it. We have completed about 86, 87 patients. We are just waiting for close to about 100 before we come out. 20 years before, we made the first presentation of transcatheter closure of PDAs with only venous access, without an arterial access, and now the similar attempt, only venous access for a perimembranous VSD closure. We are in the process. Almost, I would say, in 90% of the patients, we will be able to cross the VSD only from the RV, and we will be able to finish. In this particular patient, probably we may not do it because this is pregnant, and so you don't want radiation.
Correct. So perfectly said, Shivakumar. Basically, you go to the pulmonary artery, slowly come down and use your termo wire to enter the LV. And if it is happened, that becomes a relatively very simple, straightforward procedure. Either you can choose ADO2 or ADO1 or whatever you need. And I'll tell you, most of the time these devices are already chosen based on the echo. We don't much depend on angio. Of course, angio will give us some more idea. If the angio assessment is higher than the echo assessment, we will go by the angio assessment. If the echo assessment was higher than the angio assessment, we go by the echo assessment. For us, I mean, we are not doing that as frequently as Shivakumar is saying. Our frequencies may be 1 or 2 cases per month. Maybe the technique, whatever Shiva said, I have done maybe some 10 or 12 cases only. And so now, did you see the echo?
Yeah, we saw that.
Can you see the frozen image? Echo seems to be okay, isn't it? Just show the short axis, please. In the short, see, in the apical 4 chamber, parasternal long axis U and the parasternal short, everything will tell us. One disc should be in the RV side and the other component should be in the LV side. If it is there, that means we are in the proper position. Show the short axis view straight away. Yeah, can you see the short axis view? And as you can rightly see, and we are seeing that the tricuspid apparatus, and one component is clearly in the RV side, other components are in the LV side. Are we convinced?
Yes.
Yeah, okay. Parasternal long axis, please. Person long axis, please. Here again, it appears as though it is going to hit the aortic valve, but actually it's much more posterior than, just show the aortic valve. When you show the aortic valve, you don't see the device. See that? When you see the aortic valve, don't see the device. When you tilt towards tricuspid valve, you see the device. So this device is not hitting the aortic valve, rather it is sitting in the pouch. Okay, go to the apical 4-chamber view. Okay, here also as you can see the device is completely within the pouch. The device is completely within the pouch. Okay, so I think we are set to release Shivakumar.
Yes, I agree, Kannan.
Yeah, thank you. Go to the same view, LO cranial, LO 57, cranial 20 or something, what we had earlier.
Was there any AR?
No, right now echo will show some air because wire is across, and right now there will be residual flow also. What we will see in echo is whether our device is impinging on the aortic valve, which was not happening.
Correct.
So what we have seen by echo is our device is not impinging on the aortic valve. Now after release we will do an LV angio, if needed aortic root angio also routinely, but here we are not going to, because of the pregnancy we will just be happy only with LV angio. Yes. Yes. Now I am just fluoroing. As you can see the disc is well sitting. Actually my catheter is in the aorta. Only the wire is across, but still I just release it because we are happy with the echo position. Okay, I have released and I have pulled it out. Okay, save that. Now I am just going to pull out the entire thing, and maybe we can stop with this at all without the LV angiogram, but for the completion's sake maybe one shot of LV angiogram we can consider. Take it out, Again echo come. Show the echo please now.
Deliver catheter. Echo pigtail ready பண்ணி வைங்க.
Okay, so it is sitting perfectly. Now you put the color, basically not for residual VST, look for AR first. Are you convinced there is no AR? Yes, there is no AR. Okay, go to the parational short axis, long axis, short axis and all, everything. Look at the aortic valve first. Yeah, look at the aortic valve first. Look for AR. Look for AR, please. Okay, absolutely not any hinge of AR. Okay, there will be residual flow. As I said, there is no fabric inside. Many times there will be a residual flow. But what I have seen is that the residual flow related to the device, through the device and around the device, generally disappears in 24 hours time, if not in the first 3 months of follow-up. But if there was a residual flow through additional hole, that may not close. But here I think there was no additional hole, there was only one major hole, and I think we have the device is sitting well across it. And go to the parational short axis also. Okay, here also it is sitting well, and we do see some around the device through the RV, there is some flow still seen around the device. Okay, right, good. So what do you think, Shivakumar, should we do the LV angiogram or should we just accept and come out?
Kannan, I think we let us not radiate. That's fine.
Right, thank you. So thank you very much. Instead of AST, we thought we'll choose VST. It happened to be a pregnant lady. So our fluoro time is 1 minute and 37 seconds, which is reasonably long. Our PTMC for antenatal, and our GH has a very huge list of PTMC done in antenatal mothers. The fluoro time averages between 45 seconds to 1.2 minutes. Now here 1.37 minutes is the fluoro time, and I think it is reasonably acceptable level. Thank you, Shivakumar. Thank you, Abbat, for giving the opportunity, and my sincere thanks to Chennai Shivakumar. The initial thank was for our Madurai Shivakumar. My sincere thanks to Chennai Shivakumar for having been my kind of good help and guiding all my learning and things in conjunctivitis. Thank you very much.
Thank you. It was a nice case, Kannan. Thank you.
So again, once more I thank Sasinder, Satish, Govindan, and our other staff for helping us in doing case. Thank you very much.
Thank you.
Shiva, should we go for that lecture? Sampath?
Dr. Shiva, yes.
I
I think you can, what about your lunch? You had lunch?
I had, yeah.
Then please go ahead with your talk. We are waiting for that. Adult
Are you able
conjunctivitis.
to, are you able to see my slide there?
Yes, yes, yes. We can.
So I thank the Madurai Hub, Dr. Shivakumar from Meenakshi Mission and all the other participants there. Adult congenital heart disease interventions means patients who are having congenital heart disease with an age more than 20 years. It's like a huge ocean. It's a massive ocean. Starting from PDA in one end, a simple lesion like PDA at one end, to a post-Fontan for a hypoplastic left heart syndrome at the other end. It's a huge, massive basket. Adult congenital heart disease, the commonest congenital heart disease is atrial septal defect. In Madras Medical Mission, over the last 40 years of its existence, currently we have 40% of our adult congenital heart disease is ASD, and in many of you practitioners, you might see it even more commonly. So if you look at, if I take up adult with ASD, then I will probably be picking up the largest ship in that ocean, and I will try to discuss. So I am changing the talk to recent trends in ASD closure, because it is virtually impossible to talk about every congenital heart disease. If you look at the atrial septal defects, around 80% are secondum, 10% are primum, and 10% are sinus venosus defect. And the key interest of all the cardiologists in interventional closure is that it avoids cardiopulmonary bypass and cross clamp, reduces the hospital stay, morbidity, effusions, transfusions, rapid return to college and employment for a grown-up person, and scarless, cosmetic advantage. So if you look at who are all not amenable for device closure, we all know that around 60% of the atrial septal defects are standard device closure candidates. So who are not amenable, especially we are talking about in an adult scenario. Secondum ASD, which is larger than 35 to 36 millimeters, because the largest Amplatzer device is 40. ASDs with deficient margin, multiple secondum defects. ASD with borderline elevation of PVR index. I'm excluding ASD Eisenmenger. ASD with borderline elevation of PVR index. ASD in elderly with restrictive LV physiology. In all these patients, we need a good femoral vein access. So patients with no femoral vein access, sinus venosus defects, and primum defects. So these are all not usually considered for device closure. Let's talk one by one. Secondum ASD more than 35 to 36 millimeters are not suitable because American guidelines permit device only up to 38. The 40 millimeter device is not approved in America. Whereas European guidelines accept up to even larger device, and up to 40 millimeter is acceptable. Whenever the defect exceeds 35 millimeter on echo, at least one of the rim is absent or deficient. And if you look at most of the adults, majority of the times the ASDs may be crossing 30 millimeters. So we published our data on devices that are larger than 40. We know that Occlutech and LifeTech have got devices that are 42, 44 and 46 millimeters. This was a study that was done for 5 years between 2013 to 2017. 62 patients at that time. Today it is now more than 100. Size of the devices varying between 40 to 48. Amplatzer largest is 40, LifeTech is 40, 42, 44, 46, and Occlutech is 40, 44, 48. So the average age group was around 37 years with a weight of around 66 kilogram. The females were more common. The mean defect diameter was 38.3 plus or minus 4.7. So some of the larger diameters were like 43. The patient who had a 48 device was a 43 millimeter ASD. Deficient margin in almost 50% of the patients. Patients had atrial arrhythmia in 10, pulmonary hypertension, flow dependent hyperkinetic pH in 40%, PVR index was normal, IVC was congested, and patients had heart failure in about 1/3, QP by QS on an average was 3.7. Elevated LVED was seen in around 1/4 of the patients. I'm talking about this group is primarily an adult group. So this is the example of a 46 millimeter device on the left side, and this is an example of a 48 millimeter device on the right side. This right side patient was presented to us very sick with heart block, sick sinus syndrome, as well as a large ASD, initially stabilized with a pacemaker and about 15 days later taken up for a device closure. So what do we know? There are devices that are available up to 48 millimeter, which has made it even closure of up to 44 millimeter defects by echocardiography. In fact, we can custom order device up to 54 millimeter. So basically this has removed size as a criteria for selection of patients. Deficient margins, retroaortic margins, if they are deficient, they are associated with erosion. Posterior margin, if they are deficient, they are associated with deployment failure. Inferior margin deficiency may have late embolization. Mitral margin deficiency may encroach the AV valves and may sometimes cause heart block. So an example of a deficient inferior margin. This is a 90-degree view on the, this is or in other words a bicaval view. So you can see that there is an absent inferior margin on a retroflexion. Here you can appreciate that the inferior margin is absent. But in the same patient, in a horizontal view, we are able to see a small amount of posterior rim, and in a slightly oblique view, this is also almost posterior. We are able to see that there is some amount of posterior view, posterior rim. So that means the deficiency is confined to one margin. So what we do is, we go for what is called as a left upper pulmonary vein deployment technique. This is a 42 millimeter device that is coming up, and you deploy it almost entirely within the pulmonary veins. Come to the level of the ASD and now deploy the RA disc so that the RA disc forms in the right atrium and it pulls the device into the left atrium, thereby getting into a correct position. So this is a patient who was having the deficient inferior margin. What about deficient posterior margin? This is 0-degree view, horizontal view. So you can see that there is a absence of the posterior margin, but an inferior margin, antero-inferior margin is, posterior-inferior margin is adequate. This is a 45-degree view. Have a look at the 90-degree. In the 90-degree again, we are having small amount of inferior margin. So what is deficient is only this horizontal view. Posterior margin is completely absent. So again, you are using a similar technique. This is another device almost being deployed in the same manner. This is a 40 millimeter Amplatzer device that is coming up. You have deployed the LA disc within the pulmonary vein, deploy the RA disc, and then the devices collapse. So this is the post-procedural a mild wiggle that is being done. On transesophageal, the echo is remaining stable. So basically, the message is, if there is a deficient margin, it can be dealt with if the other margins are adequate. So if around 270 degree of circumference is providing support, the device remains stable. So you need to carefully understand the echocardiogram for a successful procedure. Multiple ASDs, whenever the device defects are very close to each other, they can be closed with a single device. But if they are far apart, they will need two devices. And whenever there are two devices, there is a concern about device stability, device to device interaction, and how to assess the size. So this is two devices that are being deployed in a patient. So we published our results in Annals of Pediatric Cardiology, wherein in almost about 20, there were 18 adults and about 7 children, a total of 25 patients who had multiple devices that are needed. Sometimes they are deployed simultaneously, which means you open the LA disc simultaneously and first deploy the smaller device and then sandwich the larger device over it. So this is the smaller device that is first being deployed. On transesophageal echo monitoring, this is the smaller device being deployed, and once it is being deployed, then subsequently work on the larger device and then subsequently release it. So this is called a simultaneous deployment. Sometimes you go for what is called sequential deployment, which means you first deploy the first device, and after fully deploying the first device, then you start with the second, and this is called sequential. So there are reasons for choosing simultaneous, there are reasons for choosing sequential. In general, if there is one small and one large, the smaller device will first be deployed in order to be sandwiched by the larger device. So devices using, closure using multiple devices is feasible and safe. Echocardiography and balloon interrogation are the key to success. Sometimes you do simultaneously, sometimes you do sequentially. There are no real additional new complications because of this. ASDs with borderline pulmonary vascular resistance. When ASD's closure is indicated if the QPQS is more than 1.5 with a PVR of less than 5 and PVR-SVR ratio of less than 0.3. If you have a higher number, then you have to test with nitric oxide. And if patients who are having a positive response to nitric oxide, which means a 20% reduction in PA pressure or index or PVR-SVR ratio, then you go for what is called partial closure.
So partial closure is done by a fenestrated device. This is a custom fenestrated device. You are able to see the hole here. You are able to see the hole on fluoroscopy, and you are able to see the hole on the transesophageal 3-dimensional echocardiography. I'll show the example. This is the hole through which we are able to pass a catheter, and we can in fact measure the pressures across, and this is through that hole. If you carefully see in this area, this is the hole. So you align the hole along the posterior part so that you will be able to cross easily. So this is 3-year follow-up of a fenestrated ASD device, wherein you are able to still see that there is a communication, and this is the transesophageal echocardiography. Elderly patients with restrictive LV, this is again another common problem in elderly. Underfilled left ventricle is very small, so they get less preload, and so proportionately, according to Frank-Starling's law, they will have reduced ejection fraction. And the RV distance in diastole, and it produces a reverse Bernheim effect. So this, in spite of the LV being underloaded, the LV end diastolic pressure is high. So the left ventricle with a reduced contraction and increased end diastolic pressure forces a larger left-right shunt through an ASD. This creates a vicious cycle. So there is an exaggerated ventricular interdependence in these patients. I'll show an example. This is the patient who has atrial fibrillation, a huge ASD, and you are able to see that the heart is massive entirely due to the RA, RV and PA, and actually the left atrium and left ventricle is very small. This patient, since she has an atrial, permanent atrial fibrillation, and the patient is not able to tolerate anticoagulation, we decided to close the atrial fibrillation, the LA appendage. So this is an LA appendage being closed by a 28 millimeter Amplatzer vascular cardiac plug. Then you check angio when you do, you see how small the left ventricle is. The left ventricle is as big as the Amplatzer cardiac plug itself. So we can imagine how much of restriction will be there. I'll just show one hemodynamic trace. This is the normal left ventricular end diastolic pressure in the same patient before an ASD, which is around 10 to 12, and it increases to about 24 to 26 the moment you balloon occlude that atrial septal defect. So we know that this patient also needs a fenestrated device. So this is that small left ventricle. You see the huge heart, entire heart is now only RA and RV. The LA and LV are very small, and you are putting in a fenestrated device here, thereby preventing a restrictive LV physiology. Vascular access is extremely important because these devices need 10 to 14 French sheath. In fact, 46 and 48 millimeter device will need a 16 French sheath, and it is easy to perform through the femoral vein because IAS is perpendicular. But if you don't have IVC, due to either deep vein thrombosis or IVC occlusions or IVC interruption with azygous continuation, you can still do it transjugular. So this is a transjugular approach to an atrial septal defect, and this is the device being deployed. The last component we are coming to, SVC form of sinus venosus ASD, which the diagnosis is often missed in childhood due to difficulty in echo imaging, and so there is often a higher incidence in adult life. So what we see, this is the sinus venosus ASD, straddling across the SVC, and this is the flow across the sinus venosus ASD. The basic principle in this closure is, we put a long cylindrical balloon across the SVC-RA junction with a parallel catheter in the right upper pulmonary vein, and you are able to see that the right upper pulmonary vein injection is only filling the left atrium. That means RUPV is routed to the left atrium, and there is no filling of this pulmonary vein into the right atrium, which means the sinus venosus ASD is closed. This is the transesophageal echocardiogram. The balloon is inflated. There is no flow from the left atrium to the right atrium. Previously you saw a lot of blue flow. Now there is no blue flow at all. So that means the balloon is able to occlude. So when you know that the balloon is going to occlude, you take a long covered stent. This is a long Andra XXL covered stent, and now you are inflating it across the SVC-RA junction. See the injection in the right upper pulmonary vein. It fills the right upper pulmonary vein, fills the left atrium, refluxes into the right middle and lower pulmonary vein, but there is no filling of the RA at all. So this covered stent has completely excluded the sinus venosus ASD, thereby producing RUPV draining into the left atrium, and superior vena cava after the balloon deflation will now be connected through this covered stent into the right atrium. Now this is the post-procedural, after the balloon is deflated, you can see that the right upper pulmonary vein pigtail injection is clearly showing only filling of the left atrium, and this is the transesophageal echocardiogram where there is no filling from the LA into the RA at all. We have published it in Circulation as well as How to Do It article in the Annals of Pediatric Cardiology. Suppose if a patient is having coexistent second ASD and a sinus venosus ASD, this is a large sinus venosus ASD, with a large secondum atrial septal defect. The secondum atrial septal defect is almost measuring 36 millimeter. So what we do is put in a large 40 millimeter device across the ASD, and now you test the balloon. You are able to appreciate that the pulmonary vein is getting routed completely to the left atrium. We have a transesophageal guidance also. This is a covered CP stent that has been deployed, and you can appreciate the right upper pulmonary vein is only going into the left atrium. The ASD, secondum ASD is closed. Sinus venosus ASD is also closed. So to summarize, ASD is increasingly becoming a cath lab problem and rarely needs surgery, especially in adults. ASDs that are more than 40 millimeter, ASDs that have deficient margin, ASDs with borderline PVR, ASDs in elderly, ASDs in restrictive LV physiology, multiple defects, without femoral vein access, SVC form of ASD, most of them are today amenable for a transcatheter closure. Since ASD is the commonest grown-up congenital heart disease, or in other words, adult congenital heart disease, this recent trend should be welcomed by most of the patients as well as clinicians. Thank you very much for your attention.
That was awesome. That was very eloquent talk by Dr. Shivakumar, but he is saying those findings, procedural details so easily because he has done it so many times. But I think it's, I mean, you need more skill and more experience. And Dr. Shiva, what is the largest device you have done for a child?
Okay, the largest device that we have done is 48 millimeter device in older patients. A child basically is a varying target. You know, you can have a child who is 10 kilogram, who is having 20 kilogram. In general, the rule is if the weight of the child is 2 times, if the device is more than 2 times the weight of the child. Let's assume it's a 10 kilo child and you need a 20 millimeter device. It is considered really large. We have gone up to 280 times. That means a 28 millimeter device in a 10 kilo child. Of course, you have to carefully choose these patients, identify all the margins carefully, and understand the echo thoroughly before you take up. One good thing about these larger ASDs is, larger ASDs produces very large shunt, and that is often associated with a roomy atria. So that fortunately allows you to put in larger and larger devices.
Okay.
In one of the adult patients where we put in 48 millimeter device, that patient had a complete heart block. So the patient had a massively dilated atria. The left atrium was 7 centimeter, the right atrium was 8 centimeter. So you have a space everywhere. So a 44 millimeter ASD will look relatively smaller for a 7 centimeter atria. So that is what I'm telling. Like as the patient grows older and older and the shunt becomes larger and large, even a large ASD will be proportionately be addressable by a transcatheter method.
Sir, one doubt. I mean, like for a patient with a restrictive LV in adult, so how do you decide upon the fenestration size? Because post-operatively, if the fenestration is too small, the patient may have pulmonary edema.
Exactly. So there are 3 things in this. The pre-operative prediction. So in general, you predict a preoperative possibility of a restrictive LV if the patient is a hypertensive, if the patient is having renal failure, if the patient is having coronary artery disease. And then in such patients, you have to pre-treat them. These patients will need a significant afterload reducing agents and diuretics. And on the day of the cath lab procedure, your RA pressure should be less than 8. If you are clinically, the patient is having an elevated JVP, don't take them, we diurese them a little bit more. Because if you are having a RA pressure of more than 8 in the resting state when you are catheterizing, that means LA pressure is 8. That means LVED is on the higher level. And the moment you occlude, the LVED is going to go up. So you should have a patient optimally diuresed before you take the patient into the cath lab. So on the day morning, you look at the JVP, and if the JVP is high, defer the procedure for a day. Then during the procedure, don't try to unnecessarily inject too many contrast and all. It should be a very limited 1-shot LCA, 1-shot RCA injection and nothing more than that. Keep the patient as much free of anxiety as possible. Anxiety produces hypertension, hypertension produces elevated LVED. Keep the patient the most comfortable. and don't unnecessarily give too much of fluid on the day of the procedure, and keep an injection of Lasix ready. Now, invariably, the moment you go and put in the sheets and all, they will have some degree of hypertension, and you control them with nitroglycerin. And during the procedure, the custom fenestrations are already made. You cannot decide on what is the size of the fenestration. The LifeTech devices more than 32 millimeter will have 8 millimeter fenestration, less than 32 millimeter will have 6 millimeter fenestration. It is custom made. We cannot create a new fenestration. Whatever fenestration that you create in the cath lab, by puncturing the fabric, will all close in 24 hours. They won't last for long. So these are custom made fenestrations where they stitch the edges. So these fenestrations will tend to last. And at the end of the procedure, if you are having acceptable LVED pressures, LVED, don't be very happy about that. Continue on diuretics, continue the patient on significant afterload reducing agents, and maintain a normal blood pressure for the next almost 1 month. Don't discharge any one of them without diuretics. Even if the patient looks dry, if the patient looks very comfortable, don't discharge without diuretics. Otherwise, third day they will come back with pulmonary edema and they will be in the emergency. So keep the patient on optimal diuretics. All the lifestyle measures should be followed. So this is the way. But I would like to add a word of caution. If the patient's creatinine is something more than 2, 2.5, most of the time your diuretics will not work. And these are the patients who are likely to get into severe trouble. So this is the patients who are having an elevated creatinine, significantly oliguric renal failures are extremely bad subsets. These patients should be taken very, very, very carefully. The last point to add will be after these fenestrated devices, always give dual antiplatelets lifelong. These fenestrations should not be allowed to close off by any sort of thrombus. At any point of time, if they have paroxysmal or any form of atrial fibrillation, put them on warfarin plus aspirin or rivaroxaban plus aspirin. These patients' fenestration should never close. In fact, I keep doing transesophageal echocardiogram at 4th year, 5th year, 6th year to just ensure that they are patent. It's important to maintain their patency.
And perioperatively, pre-closure, after closure, do you measure LVEDP and see if there is, and what is the guidance with regarding to that, sir?
Always we do it. And left ventricular end diastolic pressure of almost up to 24 to 25 will be tolerated, provided you give them appropriate NTG infusions, keep the blood pressure just between 100 to 110 systolic, and a Lasix infusion running through and through. Often, if you are able to maintain their hemodynamics for a period of about 48 hours, then they will come out of it. The first 48 hours, in fact, the first 6 hours is the bad period, and the first 48 hours is the caution period. After that, the body somehow tries to adjust itself. And in general, try to avoid all sorts of NSAIDs which will make your diuretics become ineffective. So avoid drugs like all the diclofenacs and any NSAID that is going to make your diuretic become inefficient.
That was a very fantastic, exhaustive discussion on ASD. It's good that you have taken only ASD as a component, and you have went into the all part of it. And we adult interventionalists will be always challenged with the larger ASDs. You took us and guided us what are all the tricks can be done. Thanks, Shiva, and the discussion part was also amazing. I think you are missing a lunch. Please have it. Tell the other Chennai Hub colleagues that we had a fantastic session, and I think the Chennai Hub can be relieved now. There's only one more formality of live case from Madurai. Thanks to all the friends there. With this, let me conclude this hub as well as that particular session from here. One last word from Shiva, please.
No, thanks a lot, Shiva, for all the kind invitation, and it was lovely to see each one of you, Selvamani, Shiva, all of you, Sampath. It's always nice to see, even though we are having this COVID fear and we are far apart. Given an opportunity, we would like to meet each other and shake hands, and I consider this as a good opportunity that I could see you.
Yeah, thanks, Shiva. Thank you, sir. Thank you. Right. So the last session of the day, for that, I think the same chair continues. Let them have let them have the lunch. No. Please have the lunch. We will. Meantime, I will hand over the chair to Dr. Selvamani. We will be inviting now Ganesan along with Jayapandian to go ahead with their live case here.
Shiva sir.
Yeah, good afternoon, Ganeshan and
Good afternoon,
JP there.
Salomani sir.
Good afternoon, sir.
Good afternoon to everyone, and we have our team. Our short method.
Good evening, sir.
Good evening, madam. Good evening, madam. I think my colleague Dr. Jayabandin will introduce this patient, and we have the same team, excellent team, CAT team led by Mr. Anbu, our chief CAT technician, and our staff nurse Sandanam Yasser, and all other my junior consultant Thomas. We are here. We have an interesting case, even though it's a last case. It is going to be a it will have a lot of learning points. I think I will sure everyone will agree with me. And my friend Dr. Jayapandyan will introduce this case.
Hello, sir. Hello, madam. This is a case 47-year-old male, recently diagnosed as diabetes. He presented chest pain and diagnosed as a NSTEMI in outside hospital, where they stabilized and did an angiogram and referred here for further management.
No, show the angiogram.
Angiogram
first. Don't
report.
show the live the thing now. Yeah.
Angiogram
good,
report.
Yeah, go ahead.
So I will tell the right side is minimal, dominant and minimal disease. The left side system only is a diseased one. I have a LAD from distal left main to proximal part is significantly diseased, and mid also. From mid to distal have a diffuse disease, and ostial circumflex also significant disease. So this is a finding.
Anbu, you can
RCA
share
is
the other views, Anbu. Just
minimal
caudal and epicaudal. I think that will give more idea about the complex bifurcation this patient has. Salomani sir, you can give your opinion, and Madam Selvarani madam, you can also give your suggestion. What would be your choice of
So
treatment
basically,
in this patient?
what I can make out from the angiogram is there's a very ostial LAD ostial circumflex, a significant lesion. It looks like that.
Exactly.
Distal left main is okay. Probably it's an extension of that disease there. Can you go to the epicranial? And mid LAD was totally occluded. Show the mid. So mid LAD is almost a total subtotal occlusion with TIMI2 flow there in the distal LAD. And you said it was a TROP-I positive. And ejection fraction is okay. Yeah? What was there in the ECG?
47, sir.
40, around 40. Sir,
ECG
40.
was any elevation or only?
ECG was actually, this is interesting case. Patient had almost a near normal ECG. No significant changes, only rest angina, class 3, class 4 angina.
This is not, okay. So that's not a
presented to a
STEMI.
nearby hospital,
So it is not a STEMI, it is a non-STEMI. And the patient is having a significant mid-day lady and distal left main disease. Now, Selvarani madam, you can give your comments.
Yeah.
Yes, sir. Distal left main, ostial LCX, LAD, and after the mid LAD, we could see a thrombus. So must be it is a case of something like unstable angina. The thrombus is there. Still, we could visualize, and the LCX is looking like a non-dominant. Okay.
Yes, ma'am. Yes, ma'am. It's a
non-dominant diseased vessel.
Another tandem lesion. I think you can see that.
Go for wiring of the LCX and go for the PCI provisional single stent strategy from LM to LAD. Open the vessel first.
We also had similar thoughts, but looking into other angles like levocaudal and epicaudal, the ostial LAD lesion seems very critical and like a very high grade stenosis, and distal left main also has some mild haziness in this view. So we thought definitely imaging is going to be of very much useful in this patient. So we proceeded with imaging, but before that we have to, since he had a near thrombotic occlusion or a high grade occlusion in the mid LAD, we opened that vessel, and we also opened the LCX lesion, which is looking tight, And after pre-dilatation, we took a pull through from LAD to LAD, and left main pull through was done, followed by LCX and left main done. You can, now there is running, you can show the OCT pictures. Selva sir, are you able to see this picture now, OCT?
No, show the OCT, make it big. Yeah, make it big. Yeah.
Yeah. This is from pullback from the circumflex or from to left main. You can see.
So this is from the
mostly
circ to the left main. Okay, good.
Yeah, it's a highly fibrotic plaque, and having a stenosis around 1.9, in some area even it goes to 1.0 like that. But patchy calcification, mostly deep, not very much superficial. Sometimes even though if it is superficial, it is occupying less than one quadrant of the one quadrant. But if you see now it's coming near the ostium, you can see now it's 1.9, very critical LCX ostial lesion, even a 1.6 in this area you can see. And you can come into the left main. Yeah, this is a LAD diagonal bifurcation. You can just open up the LAD now and you can see that angle looks okay, but very tight lesion in the LCX ostium. And another lesion in the mid LCX, which is continuing as a OM. So we thought provisional strategy will be very difficult in this patient for this type of complex bifurcation. We know that even though provisional strategy is the treatment of choice in most of the bifurcation lesions, but if you have a very complex lesions, now we even have a data supporting a decay crush or one of the modification of decay crush to treat these complex lesions. So we thought this was, you can also see the pullback from the LAD. So Anbu, please share that picture, pullback from the LAD to a left main. And this was then after adequate dilatation and preparation, and there was some initial spasm also there, but you can see a very long segment lesion involving the mid segment of LAD after the diagonal. Diagonal also looks, it's the big diagonal, but with the osteoproximal, maybe osteal lesion around 70 to 80% stenosis is also there. But the bifurcation angle you can see now, this is the area where after pre-dilatation there is a lot of dissection. That's fine, okay, because after dissection it's yielding not much calcium, only some islands of calcium here and there. And if you come near the LAD diagonal bifurcation, see, you can see the carinal angle is okay, but the bifurcation point PF distance, that is less than 1 millimeter. That's a little bit uncomfortable for me. So I wired both LAD and diagonal, and then first I thought I would finish my case. That's a distal lesion. That's my preference, and I thought, what's your opinion and comment? Because that's like a STEMI, like a picture, it's a TIMI 2 flow is there. I thought we can finish that short segment, a very tight lesion with a stent, and then address the left main bifurcation. Salva sir, you can give our suggestion. Siva sir, you can also comment. Yeah.
See, yeah, it's an excellent case, like where distal left main, and any of you need to treat both vessels, and definitely it's a two-stent strategy there in the left main. And coming to the LAD, it is a critical disease, a long disease from the ostium till the mid of the LAD. So, and then I think it's a fibrofatty and calcific lesion. You need to prepare a little bit well. I think you have prepared it well now. And probably what balloons did you use, and what were the balloons you have planning to use further now?
Yeah, since it is a very high-grade stenosis, and we used cutting balloon 310 to prepare the lesion, to modify the plaque which is present in the mid-segment of the left anterior descending artery. And this is after adequate preparation, we stented this segment. That's just we have finished that now, and now we are waiting for to go to live. And you can see we prepared adequately with a cutting balloon. Yeah, it's not showing. It's only the
Now we are seeing the balloon getting dilated. It is cutting balloon 3 into 10. Is it? What is the size?
Yeah, 3 into 10.
3 into 10. Okay.
Wolverine cutting balloon was used, and we adequately prepared. And you can show. Is anyone would have done it differently? because I thought the lady lesion is looking like a STEMI-like picture, some thrombus,
Okay,
very
now
high stenosis.
it is good
Yeah.
now. What is
Yeah.
your plan for the left main now? What technique are you going to do now? Anyhow, it is
Yeah.
decided it is
Yeah.
to stent.
Yeah, yeah.
So
We finished this. I will quickly finish. We centered this segment mid LED, proximal to mid LED, after wiring the diagonal, and you can see after we used 2.5 into that. Yeah, 38 stent was deployed there, and after post dilatation, there was some pinching was there. Some it looks more than 90, so we thought we can't leave it like that. So we recrossed and we did a FKB final. After preparation, sequential dilatation, we did a fine final kissing balloon dilatation to this segment, and now it looks fine. And now we are here now. Now we have to address the left main bifurcation, which is almost like a 111 lesion to me, with a downstream disease in the LCX. We thought we want to proceed with the elective double stent strategy. And we thought, if this is a patient, what will be your choice, sir? Salomani, sir. Salorani, madam, you can comment.
Selvarani, madam, you can give your suggestion, madam.
Yes, sir. Distally, actually, the vessel size is very small. You have taken 2.5. Usually, it's very unusual to take such a small stent for a LAD because of the diffuse species. Probably to avoid a distal dissection, you have taken this much. And have you post dilated it?
Yeah. Yeah, we have, as per the OCT image, it's only 2.35 lumen to lumen, and even if you add the EL, it's only 2.5. So that's the reason we took. And after post dilatation, we thought it can be expanded. This is a science platform, so we can be expanded. So after adequate post dilatation with 3 stents, it looks fine to me. Just I'm asking, what will be your treatment strategy for this bifurcation lesion? I'm asking, ma'am, bifurcation.
Yes,
we have
yes.
yeah.
Yes, I told previously single stent from LM to LAD.
Okay.
But Salomani sir is telling 2 stents, I think.
Yeah.
So I think we can proceed with
Yes, ma'am. Yeah, ma'am, if there is no lesion in the left circumflex artery downstream, maybe after 10 millimeter, if there is a tight lesion is there. So if I want to land a stent there, it will come near the ostium. So I thought, why not elective 2-stent strategy in this patient? Also, it's a very tight ostial stenosis. Even though ostial stenosis less than 5 millimeter from its ostium can be managed with a single stent strategy, I thought we can do one of the of late we have one of the modification of decay crush which is being used extensively in our lab. It's an inverted T stenting or reverse tap. It's a modification of that. Is this the one we are going to use in this technique? Salomani sir, you can comment what would be your choice if this is a patient.
Yes, Ganeshan, Shiva here. I think fantastic. So far you have nicely, you have divided your lesion into 2 parts. LAD and omitted the LM nicely and fixed the LAD, and you have taken care of the diagonal. Now, of course, we agreed that this is a true bifurcation and you want to include L6 also into stenting, and this is a great reverse tap where the metal is very much protruded, I think with the part and the subsequent thing. I think we are okay with you. And was there any pullback from OCT pullback LCX? What was the insight? Sorry.
Yeah, the same. There are 2 high-grade stenosis apart from the ostial, very tight stenosis, 1.6, I think. The MLA is 1.6 at the ostium. Mostly fibrous, some islands of calcium.
And in LM, we are going to land at the ostium.
Yeah, almost we are coming. We are planning to come up to the ostium. We are not going to protrude into the left main. It's just like a ostial landing.
And
we thought
you have nicely landed your LAD above the diagonal so that your overlap will not be asteroid the diagonal. Yeah. I think perfect. I think Silva is wonderful.
Yeah, correct. No, it is correct. And what was the length of the LAD stent you used?
38
you have
sir.
used. Okay.
Yeah.
So, but anyhow, that's a very good idea. And what you are going to do now is it is that reverse T with protrusion. That is what you are planning to do, isn't it?
Yeah, even slight modification, reverse, what we call a nano inverted T stenting. This is being advised by the of late by many people, and it is being compared with decay crush and other modification of decay crush, and it has been found to have a very good, excellent result. And they have found out that the stent thrombosis rate is almost zero in this technique. This is by a paper, it's a registry only. It's a paper from which was published last year, a European Interventional Journal, and they say that the stent thrombosis rate is very almost zero in this technique, because even though decay crush is an excellent technique, excellent technique. Everyone agree? I agree with you. Everyone, go down. Okay.
No, that's okay, Ganeshan, but it's a good technique.
Yeah,
and,
it's a good
it is-
technique, but there are several challenges are there. We have multiple recrossing, multiple two times you have to do even kissing balloon dilatation. So this modification means if the angle is around 70 to 90, definitely it will be very useful. No need to have a crust shunt in the left main area or the carinal confluence or the point of confluence. That's thing I think we are doing for the last 3 to 4 years, and we came across a nice paper called nano inverted T stenting, and almost
Ganesh, it is a slight modification of mini
decay,
crush. It's something like a mini crush only. Instead of taking two stents together, here we are taking the stents little bit separately. So it is almost a slight modification of a mini crush there. Anyhow, you can demonstrate it how you are going to do now. You are dilating the circumflex lesion. The very important step is your placement of the circumflex stent, and then taking it. You demonstrate it. It will be very nice for learning. And rightly, as you said, when you have crushed material there, probably ostium of the circumflex might have some degree of stenosis there. But here, if there is no crushed material, you might get a better lumen there in the circumflex. That is the only difference that they have suggested.
Okay, remove it now.
Okay, Salomani sir. Sir, Anand.
Yes, sir.
Sir, we have that short talk of like cath lab nightmare.
You can go ahead
Can
now.
we do that now and then
Yeah.
continue back? Dr. Ganeshan will probably leave you for a few minutes.
You can go finish
We'll
your
just have a short
talk and you can come back.
thing
By
from
the time.
We'll finish a small talk
Thank
by
you.
Dr. Shivakumar, and
sure,
we will
sure.
reach back to you again.
Sure, thank you.
And mainly you should show us how you position your circumflex stent, and every step we'll have a discussion, Ganesh.
Okay.
Yeah, it's over to you, Shiva.
Yeah, respected Chair, Dr. Selva and friends, Dr. Raja Ram Saravanan and Sambat, and all the people around here. Thanks to the AV team for the whole day. I want to fill this gap of, Ramesh was about to present, so he dropped out, so I thought, let me come out with one of the nightmare here. So this is a BME, just LA was wired. Can someone able to catch? What's the complication, Saravana? Can you tell what's happening?
Sir, the wire has torn out.
Yeah.
Yes, sir. A wire has torn out.
The moment I kept keeping the LA mitral balloon keeping it ready in the LA, the wire got cut. So no choice. I was little worried whether to dilate the mitral valve now or not. If I dilate, this wire may go into the LV. From the LV, but still, what I thought was, let me finish the balloon valvotomy. So went ahead and finished. It is roomy LA, it is roaming around. Then we took another LA wire. We don't want to lose that access, because otherwise it will be another puncture. So took a Mullin sheath. On top of Mullin sheath, took a RCA, snare, and of course this was not at the straight away. We didn't bang on this. Initially we tried snare alone, didn't work. So we thought, being a roomy LA, we need to get closer to the roaming cut wire. So this Mullin sheath with an added Judkins Wright catheter with a snare in was allowing me to reach the cut wire, and luckily I was able to catch it, and this is what it is. I think this has happened to me second time, I think. So just thought of sharing this. Why this happens? That steel wire, that LA wire is, the floppy portion is welded to the main steel wire. It is not converted. So when you are reusing it, always there is a tendency for this floppy portion to get cut. So you need to make sure that while you're feeding it, you need to feel that junction, how it is. If you think you are doubting the junction, better not to use the wire, new wire. And another key is, once the wire cut is, don't panic, don't lose your access into the LA. So this is what is a paravalvular leak also. This is the technique. IAS puncture, go to the, cross the leak, the GHK, you guys
Yes,
did it.
Yes, sir.
And close the device. So septal puncture and getting into the LA for a LA appendage closure, BME, parachute mitral valve, paravalvular leak closure, all that. The key is, you can even keep an additional wire. Yes, what I could have done, somehow, even if I lose it, that wire I can get another sheath inside. So these are all the few learnings in this case.
Excellent.
Thank you, Randa.
Excellent, sir.
Any discussion on this?
Yeah, excellent thing. But I think most of the time it is because of the reuse of our devices, and then that is what we have faced this.
Snare size, sir. Snare size, sir.
Snare is a regular snare. This is not a coronary snare, regular
snare.
Yeah, Ganeshan, we are with you now. அவங்க connect பண்ணுங்க. Hello.
Cath connect பண்றோம்.
Yeah, Salomoni sir.
Yeah, Ganeshan, we are with you now.
Yeah. We are deploying the LCX stent, sir.
Yeah, we are seeing it, and
yeah.
it is good. I think you have deployed the stent there. Just keep it and then take a fluoro or a cine. Let us see how we have placed it.
Okay.
Because we should not miss the ostium of the circ. Because here in this case, ostium was significantly diseased, and we have dilated that area. Only fallacy of this technique is you should not miss the ostium of the circumflex.
Yeah, that
is the only problem.
Crucial, yeah.
The placement is very, very crucial. And the way you have placed, I think it should be okay. And yeah, go ahead now. So you have kept a balloon in the LAD also.
Yeah, we want to do adequate part. You have to finish the part and post dilatation.
No, that is
And,
true,
we
but
should-
okay. But
Yeah,
anyhow,
yeah,
it is something like a crush only. And when you come back,
There
I
is a
think
modification of crusher. All these techniques are modification of
crush.
technique proposed by Ray and yeah.
I think what you are doing now is pulling the stent balloon back and
Dilating,
blowing it
yeah,
up again.
Yeah.
So
But
you-
ideally, we should need a post dilatation balloon to do a part. Huh?
So what you are doing is side branch proximal optimization.
No, Pova. We'll take a post dilatation balloon. Oh, okay. Po. Okay.
The balloon in LED is kept intentionally.
Yeah, but better you should also keep a balloon in the main vessel so that if inadvertent protrusion is there, we should be ready to crush that also. We can make it as a decay crush also. It's one of the modification. Various modifications of decay crush are now available, are being done throughout the world, mostly coming from the Southeast Asian countries. And initially they did a nano crush, and then now we are doing what's called inverted T stenting. Small check. Small check. Yeah. Idea. Shiva sir, any suggestion or
I think
thoughts about this?
Fantastically done. So can you just help us, your OCT guided, could you precisely land based on OCT, because Selva was raising some concern about too much protrusion or
Just you
too
can
much
see
inside.
the OCT. We have OCT. We did the SCR co-registration and we asked for the OCT.
Because you are running a nice branch there, so definitely that branch would have helped you to figure out the exact the ostium.
Can you show this picture, OCT pictures? அதை மட்டும் zoom பண்ணி காமிங்க அன்பு அதை மட்டும். OCT picture, yeah. So we did ostial stenting, just a very minimal protrusion, maybe 0.5 millimeter protrusion is the one they advocate. This people advocate 0.5 millimeter stent maybe protruded into the left main, like that. For DK crush we use minimum at least 2 to 3 millimeter, but here they recommend only 0.5 millimeter.
Okay. Madam, you wanted to say something?
Yes, sir. L6 ostium appeared to open belly.
Balloon.
And the amount of protrusion we could not recognize by angiography.
Yeah, but your point is, ma'am, your any doubt on the regarding the protrusion or the placement? What did you say?
Yeah.
Madam, you are happy with the landing, or
Regarding
you
the protrusion.
you wanted to pull the
Regarding
stents?
the protrusion.
See, only thing is, in case if there is an excessive protrusion, you may make it convert into a crush technique. That's it. There is nothing very problematic there. But always, what my feeling in this technique is, I don't want to lose the ostium. Even if you have an extra protrusion, it's okay. You can still cover it. But if you lose it, it's a problem.
Yeah, I think that's a valid point here. Not to miss the ostium.
Selva sir, that's mandatory. You should not miss the ostium. If you miss the ostium, then the whole purpose is lost.
Gone,
And
yeah,
that every care should be taken to position the stent exactly at the ostium, maybe 0.5 millimeter protrusion into the, maybe be there, into the left main.
Yes.
And and then the nano crush is done with the help of balloon placed in the main vessel, and they are partially inflating the main vessel and pulling the stent. I think everyone heard about that also, nano crush, modification of DK crush.
Yeah, you can
We have to inflate the balloon in the main vessel and then pull the stent, and then you are going to deploy that. But this is slightly modification even of that, and this is called a nano inverted T stenting, NIT. And they recommend even using a very ultra thin studs for this. It will be very useful. That's a recommendation by these people, by the authors.
Ganesan, this is something.
This technique will be very useful, especially in case of emergency like situation like STEMI. That will be a time where we have to quickly come and.
Sir,
No,
just a
yeah.
question, sir. I mean, like, how do you position the stent, sir? I mean, like, you're exactly placing at the LCX ostium. So this angle and comments on how to place it come.
No, if it is a smaller angle, it is slightly difficult. You might lose the ostium, or you can have an extra protrusion. But here it is almost like a 90-degree angle. So when you do a left main circumflex bifurcation, in almost more than 50 to 60% of the patient, his angle is more than 90 degrees. Very few patients in the left main bifurcation has lesser angle, unlike in LAD diagonal where they are in the circumflex, that is circumflex OM, you can have a narrow angle. But in the left main, most of the almost more than 60% they have angles like this, 90 or 80 or at least above more than 75. So in all those cases, this technique is useful. But if it is lesser, 60, 30, 40, I think you will have to go with the culotte or DK crush.
Sir, in such a situation, if we do a crush like this, and the first two struts are crushed, and then rewiring and everything will be a problem. Passing a balloon into the crushed stent will be a problem, particularly when it is a 90-degree angle. So that is what I was concerned about.
Yeah, your point is well taken. Unlike what Selumani wants to tell here is, unlike LAD diagonal angle, the LM angle is dynamic. The moment you wire it, this will separate out. So you need to keep assessing the angle throughout your procedure. Another key here is this technique which they are talking about all this time. this so-called reverse tap, you need to have a T angle. That's an ideal case to do this. Not in a very shallow angle where you'll be protruding and you'll be making it as a crash. Yeah. Yeah. So exactly you need to have a 70, more than 70-degree angle.
Positioning the stent exactly at the
that's what the
circumflex
OCT will,
ostium is the key
OCT
to
will
the
help us. In OCT, you need to figure out where exactly the ostium starts. You need to make a ACR. You need to fix the pointer. In the zoom, there is an option there. Okay. You have to fix a pointer. The blue pointer, there are 2 blue pointers.
Yes. You can show this picture plus. You can, yeah.
If you are not believing your OCT, take a help of some branch if it is available. They are very lucky to have one small RI there. So OCT, angio, and this branch.
18 and
you have a
you
take a insight.
Okay. Shiva sir, I think your point is well taken because you can see the OCT co-registration. Many times if you go by the angiogram, we may protrude too much into the left main.
Absolutely.
You can think ostium is very well into the left main, but it's not like that. It's only the block bottom, very ostial stenosis is there. If you go by the ACR and if you land the stent, then many times you'll be, you won't be, there won't be any much trouble.
And another point is you need to trust that precise landing guided by the OCT. Sometimes it will not match to your angio. You should not change.
But you should not. Yeah, that's important, very important, sir. You should go by the ACR landing, yeah.
There is a chance of missing, or if we come too much in, crushing the stent. So the exact position of this thing will be the key.
BP,
If you want to err on this, err on towards LM. Don't err on towards LCX.
Okay. So short to the Manbu. This is damping. Pressure coming out? Okay. Okay. Couldn't. And when part dilatation of its ostium is very much essential because we have to completely do a adequate apposition at the ostium, so that the recrossing will be every time will be easy and there won't be any accidents like abdominal wiring will happen. So that's very, very important.
Yeah, but Ganeshan, did you dilate the ostium of the LAD?
Yeah, we have already prepared with the cutting balloon. We have done the dilatation already, sir.
So
when
that's
we
a very
did the
important
same
step there.
Yeah.
Because after that, if you deploy the circ stent and then try to dilate the LAD, you can still have some block shift and some issues.
Okay. But we
use
have
the
no
cutting balloon
difficulty
for both the L6 ostium and LAD ostium, isn't it?
Yeah. Come again, sir?
Cutting balloon you have used both for the LAD and L6.
Yes, sir.
And do we need to put an LM step crush kind of thing, sir? Is it necessary?
That's the key here. That's the advantage of this technique. So that's what he said. In the hemodynamically unstable STEMI syndrome, you need not to go through all the steps. Now he is not doing that balloon kiss because you have protruded very little. Straight away you can take the stent. That's an advantage. So the final kissing balloon is predictable. Success rate is high. The meticulous steps are you can skip some steps so that less contrast, less radiation, less time, quick. You are not challenging the artery for a long time.
What is the LAD stent size, sir?
Okay. Pull pannuma.
What is this left main stent they are asking?
We are taking 3.5 stents, sir. We have to always it should be sized according to the distal landing, and so the LAD size is around 3.5. I think it can be post dilated with the here we need a post dilatation with the 4.5 in the left main. So it can go up to 4.97 or sometime even
It's mainly done by Asians. This Chen group, but the Sripal Bangalore, yes, he loves this technique. He promotes this nano crush and skipping this first kiss step.
அப்படியே இருக்கு.
Come back some more.
Babu, check mics.
Yeah. Yeah. Okay. வேண்டாம் வேண்டாம் அன்பு. ஓகே. பூஸ்ட் போடுவா? வயர் ஷார்ட் டவுன் பண்ணிக்கோங்க. ஜஸ்ட் we are positioning the stent almost not from the aorta, from the mid shaft or near the ostium to the proximal LAD stent.
Overlapping segment 3 to 4. Sir.
How much length in the
வெயிட் தான் போயிருக்கு. Yeah. Okay. Now it's okay, no? Anbu?
Just overlapping.
Yeah.
That's fine.
On the wire. And the advantage of this is we can keep the wire in the circle also. There is,
So today Ganesan is telling less is more, less protrusion, less overlap.
என்னம்மா ரொம்ப வந்துச்சு அன்பு.
ரொம்ப இருக்கு, ஒரு ஸ்டட் தான் இருக்கு.
Only thing I don't like this is there is no kiss.
Mike. Ganeshan.
Okay. Yeah, sure. Yes, sir. Solomon sir, tell me.
Sampath says he doesn't like this technique because there are less kiss in this.
No more kiss.
He wants more kiss. No,
there is one final kiss is there.
Yeah.
உள்ள போலாம்.
அந்த இது இருக்கு.
ஓகே ஃபைன்.
ஏபி கார்ல வரீங்களா அன்பு? என்கேஜ் பண்ணி எல்லோ.
Less kiss, less crush also. When there is less crush, less kiss.
Sir, I think you have to take a catheter little bit.
ரொம்ப உள்ள போயிடுச்சு. எடுத்துட்டு வேற பலூன் எடுத்துக்கோ. ஓகே.
Take a different balloon.
அந்த வயரை எடுத்துடலாம் அன்பு.
சார் கிப்பர்.
No.
Yeah.
I think Ganeshan, you can do a pot and then remove the pot, rewire the circ and then remove that wire.
Yeah. Just I was little bit more careful because I was using a 7 French guide, so I am taking all precautions. It should not cause any problem to the left main stent.
Okay. Now I think you can take a 4.5 balloon.
Generally, people don't leave the wire when it is between. When the wire is coming in between the two stents. Unlike the first time, when you are doing a second time, that is when you are putting a second stent. Probably was it intentionally done or?
What sir?
When you were stenting the LM to LAD,
okay.
The LCX wire was.
This technique you can keep. Only in our routine crush we remove.
We are not crushing any. Yeah.
In this you can keep it. You can keep it.
Not for the crush part. In the LM. Okay, there is only one little protrusion. Okay, it's not a culot. Okay.
What's that? Yeah, this step we should be very careful. We should place our balloon distal marker in front of the carina. Boost ready. Okay.
I think that's okay. I think that should be okay.
Yeah.
Babu, stent boost.
Stent boost, yeah.
Lightly withdraw.
Probably you need to.
Short, less than 10 mm the stent.
Full. Yeah. So pot is very much will be useful to recross, and if you position the balloon exactly in front of the carina, I think we can easily go through the distal.
So now the pot is done with the jailed wire, isn't it?
Stent boost bigger.
Yeah,
with the jailed wire.
Good.
We will keep the balloon.
AP எடுத்துறேன்.
Yeah, just I'm removing the.
Right,
Yeah.
back to live.
Okay.
You can appreciate the neo metal Karina, the flow divider.
See that the where it has come.
It's already.
Right, go live, Babu. Floor of full.
Yeah, you can go to the live, and it's a good stent boost image that we have seen. And now you should demonstrate how we are going to cross that LCX.
Sure.
Go into the LED, come back, try to get the distal cell and cross.
Okay.
Ganeshan, we should appreciate your handling of guide is too good. You are not allowing and you are taking all the precautions, the guide not to deform the proximal most part of the LM stent. Great. I think finally with the inflated balloon you will be engaging it. I think our lab routinely does this. Yesterday,
Yeah.
the Balbir had a stent deformity, proximal LM stent deformity. Of course, he corrected it because he recognized it very early.
Who's turn, Bu? Ready? Of course. The last la பண்ணனும் அன்பு. Okay. Yeah. Slip ஆயிடுச்சு. Okay. Yeah.
இப்போ ஸ்டெண்ட் யூஸ் பாருங்களேன்.
You can lose the guide, you can lose the balloon, but don't lose the wire.
Balloon deflate பண்ணுங்கம்மா. Okay. 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 Yeah. Okay. Deflate பண்ணுமா. பண்ணி ஸ்லோவா பண்ணிட்டு எடுத்துக்கோமா லெஃப்ட் மீன்ல இருக்கு.
Sometimes I have a feel, Ganeshan, we need not try to engage also. Sometimes if things are going on its own, we can.
Puduma. Guided. But 7 French difficult to engage, Anbu. I think.
But you are having some difficulty there, so better to coaxial it. Identify some favorable angle where it is allowing.
This is enough.
Idile pogde balloon alla. I think you can
just remove this.
Remove the balloon and take.
Rewire and.
End balloon. End. That's a konja and the. We'll take one more balloon. Okay. The 7 French guide sometimes will be difficult to maintain the coaxiality. So we should be taking all precautions to maintain that. Otherwise, sometimes it can cause damage to the proximal left main stent. And if you go through the most of the complex bifurcation interventions and even the Excel trial, I think it's around 6% damage to the left main stent is causing 6%, and especially with double the maze events. So that thing we should be very careful. And it usually happens when we are going to retrieve the balloon from the circumflex into the left main, or if you are not taking proper precautions, and if you are taking the balloon, sometimes if it is not fully deflated, then sometimes it can guide can go inside.
Yeah, absolutely. That's what that Excel paper was telling. Partially deflated balloon, pulling it aggressively causes the deformity of the proximal stent. So all the time we think it is by the guide. Sometimes it is by the balloon also.
Wait.
Slow. Yes.
Yeah. Inflate பண்ணிட்டு we can. Just these steps are done to maintain the coaxiality, and you would like to engage the left main. Okay. Yeah, wait.
Yeah.
Come back up and clockwise.
Okay, எடுத்துரு.
Great,
Yeah, wait.
Ganesan. Just a patience, allow it things to happen. Just wait for that particular moment.
Kuduma.
Light up. Okay.
Yeah.
Now don't aim for the ostial part of the stent.
Yeah, sure.
Yeah. Now the aim is only to coaxiality of the guide, then wire this thing, finish the kiss. Then finally you can do one for this thing. Imagine if you want to do, you can do it. That keep that one last, preparing the ostium of the repart of the ostial most part of the LM stent as a one final step and come out.
Sure, sir. So now we are going to rewire the circumflex artery through as much as possible through the distal state, most distal state. So that by doing this, we can avoid a long neometal carina. That's the advantage of crossing through the distal states. Okay.
No, కొంచెం
Okay.
Sir, for recrossing the L6 ostium, so any tips for the wire tip shaping?
make a wide
No, it
angle.
all depends on the anatomy. Generally, we give two curves. It could be usually probably around 60-70 degree bend, and primary and secondary curve are important. More than that, it's how you cross. You can just see what is trying. Actually, went into LAD and came back, but still he has entered the distal.
இன்னும் கொஞ்சம் போலாமா?
இல்ல distal இருக்கா சார்?
It looks like distal cell only.
Distal.
Okay.
Another beauty of this technique is it always goes to the mid cell only.
Yeah, that's
Okay. Test one.
Stent boost போட்டு பார்த்துக்கலாமா சார்?
If you are doubting if it is proximal or distal, if you push the wire, if the wire is traveling in the LCX, that means you have crossed proximally. If it is no great travel, that means it is. You are getting my point, Sambat? Yeah. Just push the wire.
It goes into the LAD.
No. Just simply
Okay.
that in the
போதும். போல கொஞ்சம் வந்து ரெசிஸ்டன்ஸ்.
That means you are proximal. If you are silver distal, it will not travel. But if it is widely open strategy.
No, but here what happened is from distal to proximal it is traveling wire. That
Okay.
means there are no struts across.
No stress.
That means there are no struts across.
3.25.
But this case it moved.
The bar.
SL Chen tells that by this technique, side branch proximal optimization and very little protrusion,
3.5
proper part. This we need not be so particular about.
சுத்தி வைமா.
Naturally happens in the optimal cell.
Okay. Proceed பண்ணி முடிச்சிரவா? Part left main part பண்ணல அன்பு.
பண்ணீங்க 4.5 ல பண்ணிருக்கீங்க.
4.5 into
5
8.
sir. 5
5 into 8.
You did with 5, huh?
Yeah.
We thought it is 4.5
Okay.
inch.
Just you want to finish the post dilatation as part of this segment, overlap segment. On the center, on the Kirnak poem, yeah.
Julio tells post dilation, post dill.
Post dill. Our English is far better compared to other Italians.
We have one more bifurcation, and we have done a recrossed. So we are taking precautions. You should not cross that carina also. Okay. Poma.
Okay.
Poma. And Siva sir, your comment about this, not about this technique, but I'm generally taking the, if you go through the webinars, most of the last 2 years we are on keen to the webinar, and if you see from what are the top authors, or most of the presenters from Europe, they recommend only provisional stenting, and if it is not complete, if your side branch compromise is there, they recommend the inverted culotte or tap or T stenting. And the decay crash is being done very much less in those part of the region. I think you will agree with me.
The reason behind this 70% of the time the distal LM bifurcation is a true simple bifurcation. Only 30% of the time it is true complex bifurcation.
Yeah. Yesterday also we were discussing, if you see the decay crash, only 5% it was patients enrolled in EBC main underwent decay crash. Only 5% people.
In that 30% also, with the help of imaging, this can be converted again as a simple. Of course, the simple can be converted as, can change as a complex, but that is very rare. So ultimately, we need to figure it out. Is it really true complex bifurcation? Then upfront two stents technique is definitely good. In that, when it comes to LM bifurcation with a little narrow angle, decay crash has definitely stronger data.
Okay.
I will consider V stenting or SKS or QLOT when the LM is short in a hemodynamically challenging situation.
One time
where you can quickly finish, maybe we can do that. We need to be ultra short LM. Sambat, you want to add something?
Yeah. Recently I saw in one webinar,
Okay.
Dr. Samin Sharma. Samin Sharma and what is that lady? Annapurna and Anupama.
Small balloon taringla.
Yeah. Dr. Anupama and Dr. Samin Sharma. What they were telling is for this sort of focal left main bifurcation stenting. Ostial LAD, ostial sac, and very little distal left main, not extending 4 mm into the left main. It's just less than 4 mm into the left main. They do V stenting, what is a mini SKS like.
That is SKS is Samin Kumar stenting.
Yeah.
No, that is outdated now. Yeah. But anyhow,
not a good technique.
No, but anyhow, this is a V stenting. They are done, and they demonstrated live.
Difference between V stenting and SKS is, if the protrusion is less than 5 mm, V. If it is 5 and more, it is SKS.
Yeah, we are doing now the sequential dilatation of the recrossing, and we are doing sequential dilatation of the circ and LAD now, ostium. Sir, pull panava.
Okay.
What are the balloons, Ganeshan?
Sir, circ 3.25 and in LAD 3.5.
And booster. Okay. Check.
Another beauty of this technique is with very little protrusion, both daughter branches, osteums are expansion is good and it's never compromised.
Okay. I think final part undu. Okay. After imaging, okay. I think we have done with
L6.
up to now kissing balloon dilatation.
Sir, L6 osteum still, I think you have to dilate little bit more.
Yeah, we are going to do. Yeah, that's a good suggestion, ma'am. Just we thought we were going to do a imaging and just we want to confirm is there any under expansion or like that. Then there is a lot of fibrous plaque was there. So we want to do imaging and then if needed, definitely we will do that, ma'am. Sure.
Yeah, both osteum, even LAD osteum is looking like that, but I think it will have an adequate lumen there on imaging.
In spite of using cutting balloon in both ostia, it looks like this.
Yeah, especially circumflex. Especially circumflex osteum, probably some more dilatation.
Yeah, we went up to 3.25.
We need to size our cutting balloon properly. It should be
use 3 balloons,
almost
sir.
closer to the intended stent size or distal reference size. I think they have done it.
Yes, we will have a imaging pullback.
That's clear. That's what the message is here. Don't take decision by angiography now. Take a imaging talk. If the MLAs are good at the both osteums, so-called that the rule of 5, 6, 7, 8, 5 at the lowest I am telling, 5 at L6 osteum, 6 at LAD osteum, 7 at the confluence of the LM, 8 at the remaining part of the LM, you are done.
And sir, you can see there is almost a less amount of or minimal crush or not even a much crush segment in the left main area. You can see that.
Absolutely, it is very convincing.
Yes.
But in caudal view, epicaudal and areocaudal, it will all be very convincing. But you need to see it in levocaudal view also. But it looks definitely there is no gap.
So OCT also will be useful.
Yeah, that's
to
what
see
OCT will definitely tell us. Are we missing anything? Even within the stent, there is a gap. But the point here is osteum. When you prepare the cutting balloon, right at the osteum, then if you miss, then you will have it.
Yeah, definitely. But we rated from left main to circ also with 3 balloon cutting, 3 into 10.
Another reason why we should not miss the osteum is the drug elution kinetics will be bad at that particular spot. When you deform the stent, when you don't scaffold properly, when you leave behind the uncovered osteum, then the drug elution kinetics will become different. So that particular area will have a natural tendency for restenosis.
Yeah, enough Anbu. Okay. My parent is good thing.
Update.
Okay. Okay, Anbu. Engaged, okay. Nitro Gurtacha. Okay. Okay.
Madam, you said you are in Chennai, but it looks like you are in America.
San Francisco. Yeah,
San Francisco.
I think
it's a golden bridge there.
How come you are in SFO?
See, your sari also is swaying
Flying.
like this.
It's just flying
Lot
like
of
that.
wind there, I
Wind.
think.
Just still, yeah, you, Selva sir, you can, I think you are able to see the OCT images now?
Yeah, we are seeing, yes. It's a good image acquisition that you have got.
Yeah, well, it's landed in a good normal segment, and you can see the expansion. We have to divide, I think that will be better because it's a long, 2 stents overlapping has been done. Just to be, okay, it's, you can divide and, yeah, now you can see this is the distal part of the stent what we have done, and the expansion is above, some segments are around 80, 83, otherwise it is 90, 95 percentage expansion has happened here, and good position is there, and come to the, yeah, this, okay. This is a overlapped segment, exactly 3, I think 2 straights overlap. Yeah. And but Bella post and very good area is also there. This is the ostium of the lady around 7.89. So, sir, Solomon sir, you are talking about the slightly under expanded, but I think it's.
No, it is acceptable, but let us see.
Yeah.
Come.
Yeah, better.
What you can do is,
5,
you
11,
can do
12 will be better.
Carinal
Yeah,
catch, just measure the diameter.
Yeah.
Or you can get the figure of 8 and you can draw area for the LCX. This all may not be exact, but or even if you take the yellow cursor to the LCX mouth, automatic lumen diameter also will represent the LCX.
Yeah, this is a circ mouth, what you are seeing.
Yeah.
Yeah, almost it's it's not a link free. It's completely no. There is no link connected to the Carina. So link free Carina. I think we will do one more pullback from circ for completion's sake.
That discussion of straight link or committed comes
doesn't
only in a
occur
provisional
here.
technique.
Yeah, not
here
for this.
dedicated to stent, final kissing done. We need to know whether optimally scaffolded, optimally expanded, any crowding of metals around.
Yeah, that's correct. Yeah, that's also correct. But if you do, there is no metallic, I think metallic carina. That's the thing I am intended to say that.
Yeah. You need to see the neo-metal carina.
No metallic carina.
How much the length? How much the length is it coming into?
Because Shelva sir also was a little bit apprehensive about this technique, because if you protrude too much, it will be like the problem with the tab stenting is many times you may end up with a long metallic carina because if you protrude too much,
That is with the classical tab. Here is a reverse tab. Or nano crush, whatever it is.
So that's the thing we should be always be taken care of, and
Ganesh,
if we have imaging guidance, I think it will be very useful. We can exactly position the stent and we can get the desired result.
Yeah, just show me around 64, 65, something like that on the LM side of the LCX.
Yeah, we have to do.
That's where the crushed material will be there right now.
Just show that. You can show this. You can just. I'm taking the catheter now. Yeah, I think you are able to see now. There is no metallic crust studs seen near the crush.
Just roll. We just saw one.
Little bit. Go back.
Go back. No.
This is all LCX ostium. Go little towards LM.
Come towards 67, 68.
LM, towards LM.
Guide.
Stay there.
Also.
No, stay there. Just go back again. Are you able to see some two?
Yeah, that part.
That part somewhere around 4 o'clock. Looks like that.
Maybe less than one. Not a big. Maybe it will be there. Maybe because it's a.
That's good. You should be happy about little bit crushing.
Otherwise, ostium of circ will be missed sometimes. Yeah.
Correct.
My wire coming in. Circ wire.
Sir, if the patient hemodynamic get worse, you are
Yeah,
given
it's
the
stable.
chance to go for only one OCT run and to read
Yeah,
about
that's.
the L6
Yeah, I fully agree,
oscillation.
ma'am. He is hemodynamically stable and creatinine is normal. That's why he said
No,
we
no,
are
no,
doing.
not this case. If
Yeah.
madam is giving a
So, for
scenario,
example,
yeah. First is
scenario
always the
where
best, madam.
yes.
They
So
did from
LID
LED
will
to
be
LM.
better.
If LED to LM run.
LM to LED, pre-dilatation, I mean, before the stent
Wire ulla ponnu.
OCT. That is the best. That will give you most of the information.
Okay.
இல்ல அந்த குட்டி பிரான்ச்லயே தான் போகுது.
அது புல் பண்ணிட்டு
குட் ஓகே. இங்க நடுவில் வச்சிருமா, அது நடுவில் வைமா, நடுவில் வச்சு. திஸ் டைம்
இல்ல
ஓகே இந்து
போதும்.
Almost we are near. Okay. Okay. பரவாயில்ல. புல் பண்ணணுமா கைடு அப்படி இருக்குமா?
Try to take the ostial LM also properly.
Left mean it will be very difficult because if you manipulate sometimes
As
it's a
much
7
as
French.
possible.
Yeah, that's I'm a little bit I'm not.
Let LCX clearance வராது. If you pull back the guide too much, you may not get clearance.
ACT எதுவும் பார்த்தாங்களா? ACT கொடுத்தீங்களா?
கொடுத்துருக்கோம்.
கொஞ்சம் yeah. We will remove the catheter and do. Looks fine.
Get the OCT out and do the ACT now.
Yeah. Okay.
Madam, you have to be careful while sitting. There is a C behind you.
டிஸ்டல் பண்ணணும் இல்லைங்க வேண்டாமா?
ஸ்மால் வெசல் தான்.
பொசிஷன் பாருங்க.
அந்த ஒரு செக்மெண்டா?
ஒரு செக்மெண்ட் பொசிஷன். அந்த இடம் தான்.
ஓகே.
இல்லையா?
இத மட்டும் 98 காமிக்குது. I think this is a pullback. You can see, you can nicely expand that stent, almost full silver or white line that shows good opposition. And you are now coming through near the sarcosteum. It's 6.5. Yeah. I think anything more than 6, I think okay. I think Siva sir, Solomoni sir, madam, you can comment.
Yes, sir.
Yeah, it is acceptable,
Yes,
but
sir.
more the better.
Yeah, sure. If it is, you have used only 2.5 stent, I think 2.5 stent I think it's okay. Huh? Okay.
And it is a good expansion, and then it's a good result. It's a good figure of 8 there. No struts across any side branch there. And the run from both LAD and LCX is excellent. And left main is also well opposed stent there. I think it's a very good result, and I think you have demonstrated it very well there.
Thank you.
Yeah. And moreover, we don't have any proximal stent deformation. You have handled the guide well. It has not hit it there.
Yeah.
And it's a very good result, Ganesh.
டிஸ்டல் வயர் போனது எல்ஏடி எல்சிஎக்ஸ்ல பாத்துருங்க. ஒரே ஒரு ஷார்ட் எடுத்து.
Okay, I think, can you conclude, if you are happy, can you just...
Sure, sir. Thank you, Siva, sir, for the opportunity and invitation. Thank you so much. Thank you all.
Jay Bandi, say few words.
Thank you.
Sure. Thank you,
Nice
sir.
case, nice case.
Thank you, ma'am. Thank you, Salva, sir. Thank you, ma'am.
Thank you, everyone there. Yeah.
Thank you, everyone, for waiting at this hour. Yeah, thank you so much. Bye-bye. Thank you from Meenakshi Mission. Yeah.
I know we are all tired. Let me just conclude this formality of day 3. That we started with live from MMHRC by Salomani. That was a great case. Salomani was lucky to have chaired by Julio and great panel, Pratap, and he nicely demonstrated cutting balloons to 2 LED ostium and diagonal, a fantastic result. And we had a lot of lectures, presentations from various people. Chennai Hub joined us. And finally, we could finish the day with valve presentation was great, and CTO presentation was great. And finally, we finished the day again with live from Meenakshi. That was a very challenging left main bifurcation. Not only left main bifurcation, there is an added LED diagonal bifurcation, which was treated provisionally, and the LM bifurcation was treated with 2 stent. Thanks for the people who stood with us till the last minute, Salomani, Sambat, Satish, Saravanan, and I thank AV team, Anand, led by Anand. Fantastic 3 days. Even the first day, second day was jam-packed. And thanks to the INTAS, thanks to Beat, thanks to all the people, particularly my colleagues, who helped me in the workshop to pile up the cases and do it. Thank once again. Yes, AV team, yeah, I told. Thanks, Abad Vascular. They are... Because I consider this is their meeting. Salomani and myself is just, we are changing the captainship once in a while. And they are the real people behind this. There is nothing. So, thank you, one and all. Thank you.